it's because what happened as if you see the laboratory study also, whatever assessment is pre-operatively, that is your final assessment. So if pre-operatively or it's ACL and MCL, it should be an ACL MCL tier and you should treat them accordingly. So grade 3 MCL and ACL, I think we can go for MCL repair in this case.
I think 13 to 14, whether it's a male or female, makes a huge difference.
Definitely, sir.
Okay, by 14, most females have finished their growth, but boys haven't. Okay, they're still growing till 17 sometimes. So I think you really need.
I think isolated MCL grade 3, isolated, that can be left as such. But if you have it in a combination with other ligamentous injury, you should go for a reconstruction.
As told by John, sir, I think second growth spurt in male is around 14 to 15 and for 15.
So it is 14 to 16 when the
gray area is the 12 to 14 because 12 to 14, yes. Less than 12, always facial is present. 12 to 14, it's a gray area. And 14 and plus, I think normally we plan for normal ACL construction. See, physis, you will see physis in MRI up to 17. The physial line will be there up to 17 or 18 years of age. Physial scar, you can see up to 19 years of the age also.
There's a grading of the physial growth on the MRI, whether it is closed, whether it is narrow, or whether it is widely open. Yes. Yes, sir. Yes. So this is the video in which the examination under anesthesia was done. So the Lechman test was positive, and the drawer test was also positive. Trying to pivot shift, but because of the MCL deficiency, was not able to assess.
Yeah, it's grade 3. You can see the opening. It's grade 3 MCL. Gross opening on the medial side. And normally, if MCL tear is there, you can't do pivot because your pivoting axis is MCL only.
Definitely.
So you can't do pivot.
Could not elicit it. So these were the stress views taken under anesthesia. So showing the picture that there was in the neutral, there was no opening and slight opening on the varus stress and complete opening of the joint in the valgus stress. So there was a hyperlexicity as well in this one. Yeah. So the height of that patient was around 5 feet 8 inch, and there was a hyperlexicity as well.
So one small comment, whenever we check this stress view, it is always comparable to the other knee. So we have to compare with the other knee, check the other knee, and then only you quantify how much is the difference. It is about the difference, not the absolute opening.
So I haven't kept the pictures, but we have compared it as well. So now the graft choice, like what is your take, like apart from hamstring, any other
always
choice?
Soft tissue graft, as Ashish sir told, and usually whenever you have a concern of physis, whether the physis is fused or not, don't there is no option other than soft tissue graft, whether it's a hamstring or a peroneus, anything, or a quadriceps, but it's a soft tissue graft for me.
So we have decided and gone for the SEMI-T. Luckily, we got a good graft. Only SEMI-T was more than 32 centimeters, so required was much lesser than this, and gone for the facial sparing all inside. This is a video how we proceed. So the diagnostic, the ACL found complete injury. It is the femoral area. The PCL was intact. Medial meniscus probed and found stable. Yes, because of the MCL injury. On the the lateral side, there was slight mobility on the lateral meniscus, and the popliteus was found partially injured on the lateral sides. So with this much of the information, we have decided to go with the all inside facial sparing. So as usual, I have gone for the cleaning of the femoral notch before. For the all inside, there's a good jig available with the Arthrex, from which you can make an outside in tunnel. So while making an outside in tunnel, one can put a jig and then confirm it on the CM image and see that whether we are in the epiphyseal region. So it is very useful for the all epiphyseal femoral side. Rest all comes. So this is the CM picture in which we have confirmed that we are well below the physis, and then with the flip cutter, use of the flip cutter, we make a femoral tunnel in the epiphyseal zone. And so another advantage of using this flip cutter is that the tunnel which we made from outside in, only the amount of the length of the tunnel in which we are going to put the graft is bigger, and the rest of the tunnel will remain smaller in the size. So one has to be very careful while coming back. The flip cutter should get closed properly, otherwise the tunnel size will become bigger. So one has to be very careful while using this flip cutter. The only take-home point is that we have to close that flip cutter properly, otherwise we can damage the tunnel. After that, cleaning of the tunnel, cleaning of the mouth is very important, because the graft passage in all inside is one of the major thing. So after this, I've gone for the probing of the lateral meniscus again. So I usually do my femoral tunnel before doing anything to the lateral meniscus. So there was a lateral meniscus tear for which I have used a all inside device and a single all inside meniscal repairs for the lateral meniscus tear. Sorry.
So it seems that you have done your ACL reconstruction, physeal sparing, as well as meniscal repair.
Yes, sir.
So do you brace your repair also? Whenever you're doing femoral repair, do you put some internal brace, fiber tape kind of thing, or it is always a repair only?
For
I think he has gone for
for MCL repair.
So MCL repair.
Do you brace your MCL repair, or you don't brace your MCL repair? MCL repair.
So I have done
only repair.
Repair with the anchor.
But no bracing.
No bracing.
Okay.
Okay, in the meantime, the video plays.
Yeah.
One question to the entire house. We are going for a physeal sparing reconstruction or tunnel creation.
Yeah.
If the area of a physis is considered to be 100%, what amount of physis needs to be damaged to lead to a growth disturbance?
मिडवे से वीडियो चलाना है नहीं मिडवे से चलाना नहीं आधा चल चुका
Table can go down a bit. Table can
So
go
the
down.
area of physis that you have to damage really varies, because even with K-wires in the distal radius, there are reports of growth arrest. It's not just area, it's the amount of damage, the level of trauma, etc. that matters rather than just what it was. So in the
So some of the
that,
pages were saying around if 5% of the area is damaged, so not much of chances of the damage.
true, but like I said, even with a K-wire or distal radius, the rest
We can have a damage.
And also it's the age, at which age you are damaging the physis. That is more important. So literature says at the age of 13, 14 year onward, if your funnel is central, as sir has said, there is hardly any problem with the angular deformity.
So it is the physical plate growing. If we are going, they may damage the growth. If we are going in the physis, there is no question relative to growth plate. So this is the physis, physical plate, growth plate, epiphysis, growth plate, and the metaphyseal. So if you are going through the physical plate, you may damage. If you are going through the physis or epiphysis, you are not going to damage the growth plate.
No, the question was
you are going through the growth plate, then
through the physis.
Physical plate.
So what is important? Try to be central and perpendicular. So and at 14 years of age, you are very safe. But Arvind was telling when you are doing such patients, sometimes gymnastic player comes 9 years or 10 years of age. In those cases, actually it's a really issue because the tibial physis is very small and the tibial physis is wavy also. If you see the femoral physis, it's very straight line, but tibial physis is wavy. Chances of one of the width being, if you think in one of the view, it's not crossing the physis, other view see it's crossing the physis. And there the chances of physical damage is more. You should be more cautious when you are dealing the pedestrian case through ACL reconstruction under 10 years, especially in gymnastics player or something, because you have to do ACL reconstruction in those patients.
And coming back to the video, so after doing it is not coming. Excuse me, it's not working.
How many slides left?
So, the video after, can we proceed after the video? So
yes, sir, we can proceed after the video.
We have gone for the physical sparing and then the right show ये है ना नहीं जा रहा
You can summarize, Bharat.
Yes, sir. Just a minute.
So in the meantime, my question is very basic question regarding the timing of surgery. When is the too early? When is too early? When to time the surgery? In any ACL?
So normally now the scenario has changed. You can operate on this patient any day between after 5 or 7 days. And if you see the knee is not very much angry looking, you can operate on it because you can address MCL repair, meniscus repair, all those issues if you are operating early. So I think when we were postgraduate resident, it was the dictum was try to keep them conservatively on brace for 6 weeks. After that, mobilize the knee. After 12 weeks, go for ACL exercise. I think now after 7 days, now you can address this knee, you can repair your MCL, you can repair your meniscal injury, and 7 to 10 days is a good time for me.
Because early operation has higher chances of arthropibrosis.
No.
And patient may not follow your rehabilitation because he is in acute pain.
So the advantage is that you can address those issues, and lots of studies have done which have shown the risk of arthropibrosis is very less because you are doing arthroscopic procedures. So chances of arthropibrosis is not so much. We are doing it now 7 to 10 days. Normally we address this knee, we repair this MCL, we reconstruct the ACL, we repair the meniscus also, and you can mobilize the knee very early.
So 7 days is the
7
right
to 10
time.
days is a good time.
Yeah.
So usually, sir, it is the primary inflammation should get settled down and the knee range of movement should be in between 90 to 120. At that time, we can go ahead with the the reconstruction.
Yeah, so it's the timing is not so much important. Is the clinical status of knee. There should not be any swelling. There should not be any tenderness. Angry looking knee should not be touched. If range of motion is full, even at day 5, you can go. There is no swelling, range of motion is full, you can go for a surgery. Johnson.
So what about in sportsmen? I think we hear about them getting scoped immediately or operated on immediately for ACL reconstructions, etc. They have the injury, they are in surgery the next day or the same evening.
Yeah, rightly said, sir. We are also doing a lot of multi-ligament surgery in acute setting at 5 days, 7 days, 10 days. And if your fixation is strong and you have mobilized early, the chances of arthroplasmosis is not much.
I think a professional sportsman is a different breed altogether. Okay, so they are motivated, they'll mobilize, they'll do the physiotherapy. And so for them, time becomes the most important thing. So they are a different group of people than when you're dealing with an average person who's just leading a sedentary lifestyle or is a sort of plays sports as a recreational thing. I think professional sportsmen have to be treated differently.
So this is the post-op X-ray in which showing the epiphyseal fixation of the all inside repair. This is 1 month post-op, and these are the videos which the patient has sent. He's doing all the exercises, like he's 4 to 5 weeks post-op, so still partial weight bearing with the knee brace, and patient is doing well at present. So a brief review of literature. So ACL tears are very common injuries. Still we don't know the exact amount of the incidence of the skeletally immature patients, but day by day, as the number of the kids are more involved in this sport, the incidence is increases. There's a very good paper presented by the Olympic Committee consensus statement, and they have given a very detailed description of how to manage all these ACL injuries. And a very recent paper in which the review was done by the Dr. Dillon and all, which shows that the ACL incidence is increasing day by day. The type of ACL tears can be cartilaginous avulsion, or it can be bony avulsion or the tibial eminence fracture. It can be a mid-substance complete tear or a complete or a partial tear. So in pediatric age group, partial tears are much more common, which can be handled with a conservative way. The mode of trauma is low velocity deceleration injuries. Patient presented with usually with the hemarthrosis, sometimes with the instability giving way sensation, and the locked knee when the meniscus is also involved. So basic Lachman test and the pivot shift is the most important clinical examination, which gives us the idea whether should go ahead with the investigation. So standard X-rays are AP lateral and notch views. MRI is important to rule out the physeal injuries and the associated ligaments and the chondral injuries, which is very important to address early. Skeletal maturity assessment should be done whenever the patient comes, because that decides that whether we should go with the surgery early or we should wait, and what kind of treatment should be planned. The management always, the decision remains dicey, so whether to go with the non-operative or...
One announcement. What is ready, so we will be stopping this. So please conclude it.
Yeah. So the take-home message is that early surgical reconstruction is recommended in children with physeal sparing ACL reconstruction technique. Favorable clinical outcome and less growth disturbance is achievable. Hamstring is still the most preferred graft. Specific pattern of bone bruise and lateral meniscus is the most common associated injury. Complications like graft rupture and contralateral ACL injuries are the 2 to 3-fold higher than the adult ACL reconstruction. And early return to the sports is the most common reason for the complication. So thank you very much.
Thank you.
There is no connection to the section.
हेलो
आप कनेक्शन डालते हैं सेक्शन में,
ठीक है ना?
हाँ नहीं बराबर है, अलग अलग से कनेक्शन नहीं डालते, हाँ है तो दो और फ्लो करने के लिए है तो दो.
Dr. Ravi Kumar, Dr. Deepak Joshi. I think you are going to moderate the meniscus repair session. Ravi? Yes, yes. Hello, Rajkumar sir. Yeah, Dr.
Rajeev sir,
Rajeev.
good morning. Rajeev sir, good morning.
Good morning, sir.
You are able to hear?
Yes, sir. Nice to see you after landing from airport. You came directly to OTA and you are live now. Sir, Dr. Ravi is there.
Yes, I think you can just take on to the history of the patient in the meanwhile and have some discussion. We have just, entered the joint. Okay?
Okay, sir.
My charge for today is to show you the meniscus. This is a young
Sir, what are the
gentleman.
clinical findings and can you show the MRI sir in between?
History is young chap, 25, 30-year male boy, having injury 1 year back. And that time he was managed conservatively. Again, similar incidents 15 days back in which his knee was locked. That get reduced spontaneously by himself. And after that, he has continuously pain around the medial side of the knee joint. The joint line tenderness was there. Range of motion was full. Anterior door test was positive. McMurray test was positive. MRI shows the very classical picture of meniscus tear. ACL tear is there. That can be focused on view box.
Can they improve the
Increase the tourniquet, no? 350.
picture?
It's coming over also.
Too much glare. I don't know what's
Increase the
happening.
tourniquet.
I think they are
Rajiv, did you get the history of the patient?
Yes, sir, we got it. So we got brief history of the patient. So we can see the inside and outside both view.
Yes.
Yes, sir.
We are just, trying to get the things sorted out here. And once we are in little comfortable zone, probably we'll try to connect with you in the theater. Is that okay?
Yes, all right, sir.
So in the meantime, we are continuing with the
Increase the
ACL.
tourniquet, no, please. Can you please increase the tourniquet?
With the lectures. Yeah.
Rajkumar sir, in between we are having one talk. So
Yes,
once
yes, yes. Please go
once you are
ahead,
ready
please go
with the
ahead.
preparation and everything,
Yes.
we will come back live also. All right.
Yes, yes.
Rajiv, we can have your talk now. Yeah. Case presentation.
टूर्निकेट ऑन कर ले भाई, नहीं तो ऐसे होता है. स्विच ऑन द टूर्निकेट, इंसर्ट कर दो. मेंटेनिंग टूर्निकेट कितना है? टूर्निकेट व्हाट इज 300 350 350. चल शेवर ला दे. Yeah, that is a bucket handle tear. Yeah. Lateral all is empty. Yeah, you can see the lateral wall. It is not there. Yeah. No. Hey, inflated.
It's inflated.
Okay. No. Okay, bend the knee some more. Bend, yeah, okay. Support है ना? No. Just a second. Please. Yeah. All right.
A very good sorry, a very good morning to everyone. Today, the topic of my talk is ACL tear, to repair or to reconstruct. But this topic is better suited for a debate rather than a talk. So we will just see, we will go through quickly the conventional, what is commonly used classification, the Sherman classification for this ACL tear. There are 4 types. The type 1 is the truly soft tissue avulsion with minimal ligament tissue left on the femur. And the type 2 had up to 20% of the tissues left on the femur, whereas the type 3 is up to 33%, and the type 4 is the true mixed substance tear up to the 50% of the ligament tissue left on the femur. So this is a case of a 30-year-old male with 3 weeks old injury, which shows the Sherman type 1 tear, which is evident in this. Where is the mouse? Is evident in this 3rd slide. This is the another type T1 image, which also shows the same finding. The coronal one also shows the same. So this is the intraoperative finding. We'll just go through this.
Okay.
The scope is on the anterolateral side and the probe is inserted from the anteromedial portal. We can see there is a minimal soft tissue attached on the femoral stump. The other structures are intact, the PCL is intact, and the ACL is still not attached to the PCL in this case.
The
menisci were intact. So, what shall be the plan of treatment in this case? To repair or to reconstruct, all the things are there. The MRI findings are there. Clinically, patient was definitely having the laxity and the symptoms. On the scopy, we can clearly see that it's type 1 Sherman. So, how many would like to repair or how many would go for the reconstruction? Sir.
Okay, so our aim is to get this reduced.
So, definitely, if we go by literature-wise, then definitely we should go for the repair. But till now, there are very few long-term follow-up of this repair, ACL repair. What we had 2 papers, one was in the 99 and one was of the 2004, which were showing around 20 to 23 years old follow-up study. All of them showed the poor results. Less than 33% survival, and very few studies which are having 3 to 4 year follow-ups, which were showing the good results with the primary repair, basically insisting on the deciding on the proper candidate for the repair rather than the technique which decides. But in this case, this was operated by Dr. Arvind. In this case, we decided to go for the reconstruction.
So, Bhusan sir, you are with Dr. Anand Joshi sir, who is doing this repair or reconstruction for a very long time. So, what is your opinion regarding this very
this repair or reconstruction.
तुम्हारा अपने आप
बात कर रहे हैं।
will be to have a good vascular stump. So if you are able to see some vasculature at the base of the ACL going all the way up, with a complete femoral avulsion or very small stump left on the femoral side, it's a good one to repair. The most important criteria is young age and the chronicity of the event. So if you are intervening within first 3 weeks, I would be more than happy to repair that ACL.
Sir, young, considering the age, majority of the literature are showing that this type of one injury is most commonly seen in the 30-35 age group. And another chronicity. Chronicity is also not defined well in the literature. It's varying paper wise. Someone is saying less than 2 weeks is good. Someone is saying less than 3 weeks. And even someone is repairing at the 3 months. So results are also varying. So there is there any consensus regarding this on the basis of which we decide it's more than 3 weeks? Just go for the reconstruction.
This is fairly controversial and hot topic with various companies taking various stances for this. So as we all know, internal bracing is a big thing for a few of the surgeons who follow one company. It's frowned upon by surgeons who are following other companies. So it's become a slightly political issue. If you look at it from a surgical point of view, there are no RCTs you can compare.
Yes.
But in young athletes, I think there's a paper by Sonori Kote about repair of ACL. There are a couple of papers from US, from I think Shelburne's group, which have talked about ACL repairs, which have showed decent result, but the failure rate is around 20-25% as compared to 10% in a standard ACL reconstruction group. So if you are discussed with the patient that we are giving a chance for repair, there's no harm trying it. We are not burning any bridges by trying to repair it.
Definitely.
So if you see the history of ACL repair or reconstruction, till 1980, all the ACL were used to get repair.
Yeah, mostly was open also.
Yeah, open and arthroscopic also. So the paper comes around in between 80 and 90. It says almost 33 to 40% of the repair ACL is having very good result. Remain 60 to 70% are worse. And at the same time, ACL reconstruction was gaining popularity with almost 85 to 90% of the success rate. So ACL repair almost stopped, and the ACL reconstruction were take the advantage of that success rate. But if you see, the same paper says almost 33 to 40% having good to moderate result. So they selected which type of patient they were, because even with the ACL repair, your 33% are doing very good. So they found that such type of lesion, those who have a type 1 type of lesion, they did very well in the follow-up. So they advocate for repair of such type of tear.
Yeah, they have also decided some the quality of the tissues should be good and some other criteria they have mentioned. Yes, sir.
How many years old is this injury?
1980s, what we are talking, that was a separate era, rather. Very primitive thing. Now we are talking about all the time stump preservation, stump saving, stump doing that. So if you have this kind of tear, then it has to be preserved as far as possible.
Yes.
Now people are doing, they are making graft passage also, and we are suturing the stump to the graft, something which is beyond only the internal bracing.
Yes.
So nowadays, just saying that I will just remove it and will do a reconstruction, that may not be very feasible if we say in present scenario. This is what I have to say. Maybe it fails, you tell the patient it may fail, I will reconstruct it afterwards. So that's the thing, my opinion.
Definitely we have to take the consent for reconstruction also. If intraoperatively we'll decide whether we can go for the repair or not. So in this case, any other opinion, any other suggestion, please? Yes.
Yes. All good, sir.
Operatively shows it's a grade 2 sprain kind of thing where complete substance or complete emulsion. In those cases, I always keep at the back of my mind that repair is one option.
Definitely. In this case, we may go for the repair, but we all have our reservations and still we are not, the results, what we have done, the repairs so far independently, I have also done, Dr. Arvind has also done several cases. The results were not so promising, so we are on the back foot so far, but we are also gradually tending towards that repair side. If we get that such properly selected cases, then we should definitely go for the repair. What we did in this case was a reconstruction with the remnant preservation. Sorry, it's not moving. Yeah, pre-operatively we have to plan that in this case we
we are going to repair or reconstruct.
Yeah, definitely. On the basis of MRI, we can see that on the basis we can judge that it's sorry, it's type 1. So in type 1 only there are, and definitely the duration of the from the injury. In type 1 only, definitely we have a chance that we may go for the repair. In such cases, we have to consult the patient regarding that. That is possible. If the things are in favor, then we may go for the repair. Otherwise, reconstruction is the option which we have already. No. Pre-operatively, on the basis of MRI and considering the duration of the injury, we counsel the patient that if there is a possibility, we may go for the repair. Otherwise, the reconstruction is always there. The chances are always there. Anything?
So, purpose of putting this case for the discussion was, if you see the MRI in acute setting less than 4 weeks, if MRI can predict it's the type 1 Sermon type of ACL tear, avulsion, just avulsion from the femoral side. So you can counsel the patient about the repair, and you should be ready with the repair material in OT. Anchor and this knotless swivel lock nowadays with maybe if you want to augment with pivoted. So all these things would be available. We did 6 cases previously also. In this case, the patient was not counseled about the repair. So reconstruction was done with all the remnant of ACL, whatever it was, to be preserved. You can see in the video also, the remnant was not touched at all. Remnant was as it is. And this ACL reconstruction was done. You can see the reconstructed ACL.
So one concern is joint is getting overstuffed with this much of remnant. So to just take care of that, we have checked for the notching in the full extension. It was not notching, so we are assured that it's not going to hamper the extension.
It is totally turned upside down.
Here we can see that in the full extension we have checked.
It is damaged usually by the reading or...
So in this case, we are using that anchors, soil of anchors if you are going for the repair. And in this case also, we try to protect as much as possible. Yes, definitely it's damaged. That's why we have not done the repair.
18 gauge needle dena.
It is more like a double bundle where the PL bundle is kind of the remnant and
so
you can build the tunnel, visualize everything, make sure that the skill that is not protected.
Yeah, definitely. So if you see the complete ACL footprint on the tibia, it's almost 14 to 15 millimeter in the anterior posterior part. And this graft was, I think, 8. So you can take this graft in the anterior part just at the anatomical level. So even that anterior part of this remnant ACL will be there. My one question to Bhushan sir, lot of people have started doing this remnant preservation ACL reconstruction. Do you have any chance of second look into the joint? And what is happening to this remnant preservation? Because I have once that remnant was as it is. It was not healed to the reconstructed graft. It was as it is there.
So the main problem of remnant preservation or a big stump preservation like this is a cyclops lesion with a resultant FFD in post-op period for most patients. Now, a quick comment on this: beautifully done surgery, I agree. But if the remnant is sitting on the graft, the chances of not forming a cyclops lesion are quite good, not forming. So it's a good result I'm saying. Now, most important thing about what you were saying is that the periphery of the ACL is where the blood supply comes from. So even if you go in the center of the ACL and take out the central part of the footprint, you're still preserving the peripheral synovial part of the graft where the blood supply is coming in. So when you're doing a remnant preserving ACL, your aim is to come through the center of the ACL footprint, the so-called Samba technique. So when you put your guide wire and a drill in, you should just see the ACL stump moving about like that, and you are sure that the blood supply is going to be preserved. Central part can be easily taken off. An important thing is not to take a thick graft. So quite a few times we just take essence when you have a really good stump. So that becomes a bib technique or biological internal bracing technique. So you are internally bracing the present ACL with biological tissue, and in addition you can take a stitch on the stump and fix it with a small anchor or with a stitch or suture which goes in your endo button, tritro button, or whatever you use.
Yes, I agree with you, sir. When I was a fellow with Professor Gurudev Kumar in University of Pittsburgh Medical Center, USA, and he is very keen to preserve all the remnant while doing the ACL reconstruction. And I observed him for 6 months of his technique. He did just to separate both the AL and PL bundle and pass this guide wire. And while you have mentioned that there is rotating the reamer, that is technique. And another thing, how much tissue should be kept there? The tissue which is attached, the remnant which is attached, falling down over the ACL, it should be kept as like that. And the tissue which is falling down, it should be removed. Otherwise, it will later on lead to the cyclos formation.
Any stump which is anterior to the ACL, I think footprint, don't keep it there because chances of cyclo formation is more on the anterior part. So I think in these cases you can keep that part because the whole of the footprint, whole of the ACL was falling on the ACL graft, the construction graft. What was the diameter of your graft here? 8.
Okay.
So the question.
Sir, can you pass the shaver, please? Shaver.
And graft thickness.
Probe निकालना है सर. Probe निकालो.
Again, it depends upon the patient. Normally, you should cover 80% of the footprint. So, minimum 8 millimeter graft is mandatory. But that is not true for, I think, an athletic population or a basketball player. There you can go up to 9.5. It should not be overstuffing. You should not have any impingement with the wall, with the roof, or with the PCL. And minimum graft diameter, I think 80 millimeter. I think all of the whole, there is a consensus that it should not be less than 8.
वो pedal ऊपर रख देना. ऊपर करवा देना. वो foot switch ऊपर रखवा दो.
Pass through the substance of the original ACL of the graft.
You have drilled the bony tunnels of the right diameter. That soft tissue stretches out.
And normally, when you try to pass it, you take your probe, try to push your remnant of the ACL towards the lateral side. Then you can see you can fire a width pin. Then put your scoop over the width pin so that you are not damaging the remnant here. So by these are the two, I think, simple technique by which you can preserve the remnant. Yes, Rajeev, next.
ठीक है.
Yes, so we were like any all inside.
All right. Yeah. ठीक है. पकड़ो इसको.
Okay.
Okay. Yeah. Lateral meniscus है कि नहीं देखेंगे? Lateral meniscus figure of 4 कर. Figure of 4 lateral meniscus. Yeah.
So problem with all inside technique is passing the graft in the tibia or in the femur if you have kept the remnant there. So for passing it should be completely clean. So very less chances.
नहीं जरूरत नहीं.
When you're doing an all inside, normally we bottom out the graft on the femoral side and put it on the tibial side. If you have got a good stump, you have to reverse it. You have to bottom it on the tibial side and put it on the femoral side. So your the cigar graft, it goes inside the tibia and then when it comes out to the femoral side, it pulls out all the remnant. Like a sleeve. So it works really well. What you have to do is put a 3.5 shaver in your prepared socket to clean up the central part of the ACL tendon. So you just are left with a nice sleeve. And then you can pass the graft in. Sometimes you take your arthroscopic scissors or small biter and make a vertical cut on your remnant for allowing the graft to go in easily. Even stitch it later if you want. That's a bit of an overkill in my opinion, but you just reverse the step of all inside when you're doing a remnant.
So, going through the literatures, one of the paper by Gregory et al. Which was published in 2015. It was a retrospective review of 11 consecutive cases. They had included the proximal avulsion tear having the excellent tissue quality confirmed just before going for the repair. Patients were excluded if these criteria were not met or the patient had a multiligamentous injury pattern or significant arthrosis or grade 3 corneal changes. The ACLs were reinforced with the 2 fiber wires and it was anchored with the 4.75 mm swivel lock anchors. The 10 of the patients had good subjective and clinical outcomes at an average of 3.5 years follow-up. So they concluded that the preservation of the native ACL using the described this primary repair technique can achieve the short-term clinical success. They also didn't have that long-term one follow-up in the carefully selected subset of patients with proximal avulsion type tears having the excellent tissue quality of the remnant. This was the
long needle system, please.
Photograph provided in
long
the
spinal
paper.
needle.
This
Long
was the
needle.
anchor they have used, and this was after a final repair of the graft. They also said that the torn ACLs are resolved and nearly 3/4 of disrupted ACLs showed some intra-articular attachment. This reattachment is indeed a noteworthy finding because it was described that the healing properties of proximal ACL tears are just like that of MCL, in which in acute cases we go for the repair instead of the reconstruction. So the patients having the excellent ACL tissue quality, which was defined by a broad stump with mild interstitial tearing and the ability of the tissues to hold the sutures properly at arthroscopy. This is the criteria for going for the repair. Another technique by the Nishi Shah et al. Was the suture pull-out technique. In this paper, they have mentioned they have gone for the repair in the cases which were less than 2 weeks old. And they have also mentioned that the selection of the tear pattern rather than the technique of the surgery were responsible for the failure rate or the success rate in these cases.
Okay.
They have done that around 7 mm rimming from the, they passed the guide wire from the intra-articular side, but they have drilled from the femoral extra-articular side and they have,
they'll see a very
logic was that if they are having that 7 mm tunnel, then some of that tissue will be inside the tunnel, so it will promote the healing better rather than only the surface healing. So that's why they have drilled it and to preserve the remnant, so that during reaming the remnant is not damaged. They have drilled from the outside, and they have used that suture disc outside, and they have repaired it with the pull-through technique.
Okay.
Another, this journal has, this paper has tried to classify these tears in a different way, just to have a better predictions for the survival of that, better prediction for having a decision making for this repair.
Excuse me.
Or inside out, take open karo.
Theater is ready now, so please.
So we can just
just finish it off. Okay. So Rajeev Ranjan sir.
Rajeev.
Yes, sir. Ravi is there, sir. Ravi is moderating this. Dr. Ravi Kumar.
Ravi. This was a 1-year-old injury. How many times he had locked episode, we never know. But you can see the ACL is not there. The lateral wall is empty here. Okay?
Yes, sir.
I just prepared a bit for you. The lateral compartment is fine for all practical purpose.
Okay.
We have visualized that. This is the anterior of the lateral meniscus. That is your PCL, medial tibial spine. And this is your bucket handle tear which was locked and very resistant to go in.
Okay.
Okay? Can you see that?
Yes, sir.
Yeah?
Yes, sir.
I can barely hear you, doctor. Okay, we have to reduce this in this fashion.
All right, sir.
Okay, right?
Yes.
We had a little struggle to reduce this because it was not going in, budging in inside. Okay, we had to do a lot of pike resting on the medial side. And if you can see this, a bit of shaving is done to promote some vascularity. We also have poked with the needle to, stimulate healing here.
Yes.
You can see this point. Yeah?
Yes, sir.
Okay. But the good thing about this cartilage or this patient is you can see the cartilage is great. Okay.
Yes, sir.
The tibial condyle is great. The femoral condyle is great. And he's a young bloke. So in all possibility, you should try to reduce this and try to save this meniscus as far as possible.
Okay.
And then get one first reduction stitch here in the center here in this fashion.
Okay.
Okay. Then you can work on it because there is also tear going close to the root here. You can see? Yeah?
Yes, sir.
Yeah?
Absolutely, sir.
So this is important. This cartilage structure is important, how it is when you do a repair. Age of the patient and of course the collateral, whatever injuries he has. He has an ACL also here. So ACL for a young bloke with bucket handle, it will also go in favor of doing an LET. But for the time constraints here, we are trying to do only the meniscus. Is that okay?
Yes, sir.
Okay, slotted cannula, please. Idhar se aa rahe tu.
Rajkumar sir, if it was a acute tear, what was your sequence of repair? What could have been your sequence?
What is the sequence of repair? Good question. It's a locked joint. Then you need to first of all give a traction in the ward, try to get it unlocked. If not, then probably post him for a unlocking of the meniscus and repair in the acute setting. But having said that, acute setting scenario, the challenge would be for you to handle the life of the knee. The life of the knee and the oxygen supply of the knee comes from the infrapatellar pad of fat. If you are able to handle the infrapatellar pad of fat well, the stiffness in the joint can be reduced. And also you can very well use a good post-operative rehab protocol for the patient in the form of game ready and those kind of things. And then that will, take away the fear that you have of an arthrophyrosis of an acute setting reconstruction. Is that okay, Rahul, Rajiv?
Yes, sir. And so what do you do for preparation of the meniscus bed? Because as we know, it's an avascular structure and we want a fibrous healing there. It's a fibrosis which is important. So how do you prepare the meniscus bed, sir?
Meniscus bed. I just mentioned it, Rajiv, once again for the benefit of the viewers. Okay. Keep as much as this meniscus as possible. Okay. We need golden handle rasp. Okay. To rasp this meniscus here. Okay. Can you see, Rajiv?
Yes, sir. We can see.
Yeah?
More towards the capsular side, less towards the meniscal side.
Yes.
Yeah.
But sometimes you have to do towards the meniscus side also if it is causing a blockage of your vision there. All right. So then once you have done there in this fashion, can I have a probe? I'll show Rajiv. Can I have a
yes.
probe? Yeah.
Is he audible?
Once you got enough space on the medial side, you will be able to reduce this in this fashion. Okay?
All right.
Suction, please. Suction, please, doctor. You do keep checking here. Okay. So then you have a look at this side. This is where you use your shaver very gently in slow speed. Stop it. Stop it. Yeah. Yeah. And then create some vascular channels coming in. I was showing, you can see that spots there. The two eyes that you are seeing on the meniscocapsular junction.
Yes, sir.
That is where I use the spinal needle to, create some channels of vascularity. Okay.
Yes.
To come in. Wait, I'll show you. पकड़ो इसको ऐसे पकड़ो इसको. One minute. Yeah. Can you see that two spots? Yeah.
Yes, sir.
Yeah. That is where the needle has gone in, and there it is vascular a bit. You can see bleeding under the meniscocapsular junction. So this is a very important area for you to prepare and find out how much of meniscus is remaining. The cartilage that is there on top is good. Cartilage on the bottom is good. So this is a good need to go in for a preservation of the meniscus rather than an excision. Yes, there will be some challenges. You need to do that. You need to face the challenges, take it up and give the best life for the knee for this young gentleman. If there is no ACL, then you have to do a microfracture on top of the ACL attachment. But since there is a ACL reconstruction also planned for this patient, there will be some stem cells that are going to leak in and provide some healing to the meniscus. Okay, Rajiv?
Yes, sir.
Okay. So let's do the meniscus. I'll show you a few steps and then you probably can go ahead and continue with your lectures. Yeah?
Yes, sir. So what will be your sequence of repair, sir? From posterior to anterior or central stabilization suture first, then posterior, then anterior?
You can skin the cat whichever way you want, but Rajiv, there should be a pattern of it. For me, I need a stabilization suture in this fashion here, you see? Okay?
Especially in chronic cases, I think it's preferred to go for centralization suture first, then here.
Like this. Okay? Yeah. So get a kind of fixation in this fashion, get your posterior root organized. You see that?
Yes, sir, we can see.
Yeah? You see that? So my plan is just for the sake of viewers, I'm going to shoot one arrow here and then we'll see how best we can do. Okay? Yeah. 20.
Rajkumar, sir.
Yes, sir.
Vinay here.
Yes,
so,
Vinay,
some words about the trajectory that you think you should approaching to the posterior horn, middle or anterior. There's some difference in trajectory. Same portal, the other portal you use for this.
For the middle third and all, I like to come from the opposite side. Same side, I generally go with for the posterior horn. Anterior horn, you can go whichever way you want with the flex needles now, or you can come from outside in this fashion. Okay? Inside out here, from here to there. Okay? From middle third, inside out. Posterior third, you can keep it as all inside. Outside in or inside, all inside with the flex device on the anterior side. Okay?
Yes,
but remember, the fourth zone that is there in the meniscus as described by Smegleski doesn't have a meniscocapsular attachment. But we all of us will fix this to the meniscocapsular junction. Is that correct, Vinay?
Yes, sir.
Yeah, we still fix it because anatomically it is not fixed. If you read this Smegleski's paper. But we all wanted to fix it in this fashion here. Okay?
Yes, sir.
I'll also just show you one more trick. Can I have a spinal needle which is long one? You can see this needle coming in.
Yeah, we can appreciate that.
Yeah, but it is going at a tangent. Okay. So I need to come in a direction wherein it is useful for Can you see it now?
Yes.
Okay, the length of this needle is very small. Okay, it is hardly able to reach, and I am already on the skin there. You generally can hold it in reduced position in this fashion by poking the meniscus. Okay, that also you can try if you want a reduction. Okay,
yes,
clear?
sir.
Yeah, in this fashion. Yeah, okay.
Yes, sir.
Yeah, chalo. Bravo. Okay. Okay, also the trajectory I will always check. Trocar dena bhai jara. Trocar dena. You always have to be perpendicular. Nikal isko. Your line of action should be perpendicular. Always check with the trocar if you are in doubt whether you will be able to reach that zone and you will be able to fire the meniscus and fix it. Okay. This
Yes,
is how
sir.
it has to be done.
You like this all inside thing for the reduction stitch, or you use inside out device?
Both can be done, but in this case, for demonstration purpose, I am using the all inside here in this fashion here. Okay. Yeah. Chal bhai. Okay, this is a slotted cannula coming in. You can use it both for reduction and passage of your device. All right. You have to be careful while you're passing it through the slotted cannula because your assistants are very keen to, help you as much as they can, but they also can, poke themselves. Okay, out. Yeah. Okay. Yeah. Okay, this is the first one that I am going to use here. I'll drag it a bit in this fashion. Okay, this is only for getting the length of the meniscus there. See that? Okay?
Yes, sir.
Fire. For the beginner, this device will give them some challenges. So they have to work with guys who are used with this kind of a device, because you can see I am not that, very smooth in exiting. Correct? Okay, why that happens is you are seeing this knot here.
Yes, sir.
It is because of that your exit through the meniscus is not smooth. All right?
Yes, sir.
ये क्या है भाई? अभी जाएगा? नहीं जाएगा? जाएगा कि नहीं जाएगा? Valgus, 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 valgus. Okay. Okay.
Bhushan, sir. So you said, Dr. Bhushan, you said you use inside out for this reduction stage. So did you shift it to inside out, or you originally using inside out and shifted from all inside to inside out?
हाँ भाई, top light लगाओ. Top light देना.
Even the root. Till the root, you can do inside out switch.
With this zone specific cannula system which has come up.
Absolutely.
So wonderful system.
And you do a small incision posteromedially.
Yes.
You can put a small spoon, ice cream spoon, or Henning spoon, or even a normal tablespoon in the back of the knee, and that
Correct.
saves your needle.
So medial meniscus more or less is all inside.
Yeah, middle meniscus, everything is on
All inside.
inside out.
Inside out, sorry.
Yeah.
Okay. So this is their device to, just to get the sutures little taut onto the meniscus. Yeah.
Yes, sir.
Okay, pull a bit. Yeah. Okay. There it is. Chal. Cut, sir. Cut. So that is your first stitch holding the meniscus there. Reasonable reduction, I can say. We need to get the top part of the meniscus there. This one has to go down. Well, yeah.
Yes, sir.
We'll go in for a vertical suture there from the top. This was a horizontal one, just to show that we have to keep it there. From here, you can come inside out or outside in. Both can be done. We'll get one vertical suture here for you. Please. Plotted cannula. Yeah. Okay. Yeah. Yeah. What's that? Nickel spoon.
Dr. Rajeev, any chance of neurovascular injury you think in this place?
Medial meniscus, you are more safe, but when you are dealing with the posterior horn, try to avoid putting your mid needle towards the midline. So what I do, I always with either any of the device, these are angulated device. So you just try to put it towards away from the midline. You are on the safer side. So don't try to put it toward the midline. Because your neurovascular structure is just lateral to midline. So you are more safe on the medial meniscus. And lateral meniscus, again, try to put your needle away from the midline. So all these needles are curved needle. You can just make it zone specific.
Okay.
And also on the capsular side, you can reduce the length of the needle. You can make it around 8 mm or 10 mm. That required hardly for the capsular side. Again, if you are on the substance of meniscus, then you can increase the length to 12.
Give me a probe.
Something like that.
Wait, Mata. Okay, if you think your knot is not great, you can just put your probe under the suture here in this fashion and ask your assistant to pull that. Yeah. Pull. Till you can see the knot. Yeah, that's okay. Some more. No. Oh, इससे push करेंगे बस.
So normally this cheese cutting phenomena occurs whenever you are dealing with a poor meniscal tissue in old tear. So
Yes.
This is the technique. Put your probe there and ask your assistant to push and then pull your knot so that your anchor will also not come out and there will be less or minimal cutting effect over the meniscal tissue. So when you are dealing with this chronic tear repair of this chronic tear, I think this is a very important technique what Rajkumar sir has shown. And you can see the knot is not perfectly sitting there without cutting the meniscal tissue.
Pull. Yeah, stop. Yeah. Cut. Yeah, cut. Okay, it should be just right. You can see the meniscus little lifting, but that is fine for me. I need to do a bit of gardening here so that I can get this flat. Can we go for the inside out? Yeah. Any other burning question that you have, Rajiv, that you want to know? Bhushan can add.
Practice. So bucket handle tear, posterior horn, all inside. The body and the anterior horn, you can go for inside out or outside in. Yeah.
Correct.
Yeah.
But in all practicality, try to preserve the meniscus. as everybody is discussing. And that is the way when an youngster like this, for me, the health of the joint which is there like this decides what I do for this meniscus. Okay, if it is too bad and all.
Would you like to prefer some suture on the undersurface of the meniscus to prevent?
I will be doing that. I will be doing that. Yeah. I think there are time constraints for this. Whether we will be able to show everything, I am not sure. They are organizing all inside for us here, so we'll see. Inside out, sorry.
Rajkumar sir, Arvind here.
Arvind, bolo.
Sir, in such type of unstable meniscus, that bucket tunnel, quite long tear it is. Do you want to, it's better to take one stitch that is inside or in the middle part of the meniscus so that this will keep your meniscus stable, with one guy outside taking that tractional stitch outside the knee so that your meniscus will be in place, and then it's better to put all inside meniscus suture in the posterior horn, then you come to the body and...
Correct. That is what Rajiv was also mentioning. I said for a demonstration here, I am doing that. Otherwise, I would have done exactly as what we all know to do. You know, the reduction stitch first, and then probably they go ahead and do all the work either from posterior to anterior or anterior to posterior, but preferably posterior one first. Okay?
Yes. Ashish sir, just to wake you up, you have been doing ACLs for like years together, so many years of experience. You would have been doing a lot of meniscectomies early days. So have you seen any meniscectomy along with ACL reconstruction coming back to you after 10-15 years of follow-up that, okay, my knee is osteoarthritic and I want to get done? So what's your experience of doing meniscectomies like 20 years back, 25 years back when you were doing this?
To be very truthful on that, our patients, generally don't come regularly for your follow-up unless they are from the same town. We do handle patients from all across the country, number one. Number two, the very few who come back to us for a re-surgery or re-look is the ones who have a re-injury. And in those individuals, if the meniscus has been, as you said, meniscectomized or removed, then they will have some amount of early OA that can be seen. The duration that can, the time duration or the time frame which the joint needs to develop a OA is around 10 years. So if you have a career spanning more than that and you have patients coming to you at that time, you will see some amount of early OA with a mild virus in that knee associated with your instability, which is secondary to a failed ACL or whatever it is. Yes?
Yeah. Also, sir, we will shift to lecture again. And at the end of, I think we will see your repair, whole of the repair. By that time, you can complete your repair. We'll come back to you.
Yeah, that will be fine. Yeah.
Yes, sir. So I think next talk.
Inside out the air. Yeah.
And after that, we will call Dr. Ashish Kumar. Yeah.
एक मिनट हाँ
अच्छा
चलो फटाफट किधर है
बीच में
कर लो
This was a paper published combinedly by the radiologist and the orthopedic surgeon, where they try to classify this ACL tears again, so that the decision making for going for the repair becomes easy. In this, they have classified the type 1. It's almost like the Sherman type 1, in which the remnant length is on the tibial side is more than 90% of the total ligament type. Only in this case, they have recommended for the repair. And also, they have quantified the incidence of the different types of tear, in which they have said that type 1 tear is 16%, and they have also emphasized the number is significant. So we should also try to go for the remnant, try to go for the repair if possible, because this is a significant number of total number of ACL tears. And they have also mentioned that its associated advantages of the repair is the maintaining the proprioception, preserving the biology, minimizing the morbidity, surgical morbidities, allowing for the faster recovery, as well as in some of the experimental findings, they have observed that if we are repairing the meniscus, then there are chances of restoring the native kinematics, and that's why preventing the long-term sequelae of the development of the osteoarthritis in the case which we also see in the cases of the reconstruction. This was the long-term study which we have already discussed about, which have mentioned around only the 33% survival at the 15 to 20 years, which also raised an interest in this, that even after the repair, 33% has survived for so long. So we should try to go for the repair. So one paper by Dr. Tapaswi in 2017, they have mentioned few of the, in which he has used that augmentation with the fiber tape augmentation to give the initial protection of the repair. He has mentioned some of the pearls which is very necessary if you are going for the repair, in which the assessment of the ACL for suitability of the repair, quality of the tissue which we have already seen, and in case of doubt, if slightest of the doubt, always go for the standard anatomical reconstruction. And one thing which is technically helps a lot, that we should use that the central portal, the transportal, the medial third portal, which we use, in which that case through that portal, it's very easy to visualize the medial aspect of the lateral femoral condyle. And in these cases, it should be avoided if the tissue quality is not good. And these are the various nuggets we have already discussed. So with all this, thanks a lot for your patience hearing.
Thank you, Rajiv. And now I would like to invite Dr. Gurudev Kumar. He will be talking on ACL and LT.
Respected Chairperson, my topic of presentation is ACL reconstruction along with lateral extraarticular tenodesis. It is a procedure on the anterolateral side of the knee to just augment the reconstructed ACL to prevent its graft failure. This is a 24 years male hammer throw player having right knee twisted injury. This is the X-ray. It looks normal, and this is his clinical examination. Anterior drawer test grade 3, pivot shift. It's grade 3, grossly moving. And the Lackman test, which is also grade 3. So we have planned to do a standard ACL reconstruction along with lateral extraarticular tenodesis. This is the MRI to confirm the status of the meniscus, ligament, cartilage. There is a classical buckling of the PCL, and
I need another 2.
Rest of the structure is normal.
Another 2 I need.
So coming to the anatomy of this, on the lateral side of the knee, it is the anterolateral capsule attached from the lateral epicondyle to the Gandhi tubercle. It is nothing other than the anterolateral ligament, which prevents the pivoting mechanism central from the knee. So the purpose and the goal of this lateral extraarticular tenodesis is to increase the soft tissue restraint on the lateral side of the knee, a distance away from the central pivot, that is the ACL. So there are certain indications. So in which cases we have to go for the lateral extraarticular tenodesis. In the setting of revision ACL reconstruction, pivot shift grade 2 or the grade 3. This is the patient is doing the pivoting mechanism of his knee. There is grossly subluxating of the leg on the
knee. Sports with pivot mechanism like the football player. Ligament laxity. See here, there is a grossly laxity of the multiple ligament. Lachman test, more than 7 millimeter of the angulation, and the contralateral ACL rupture. Usually the lateral side of the knee is too much tight. Here we can see there is drive-through sign in the lateral side of the knee joint. The completely the joint is going to open. Other indication when there is the chronic ACL tear, young individual which is highly involved in the high demanding sports activity, and the radiological sign of the lateral femoral condyle depression is more than 1.5 millimeter. And the last, there is second fracture where we can go for the LET. So coming to the quick procedure, how it can be performed. So before going to procedure for the lateral extraarticular tendinosis, we do the standard anatomical ACL tunnel both on the femur and on the tibial side. So for the LET, we mark all the bony prominence, lateral epicondyle, Gandhi tubercle, fibular head, then make a skin incision along the line of the IT band more towards the posterior side, approximately 6 to 8 millimeter proximal to the Gandhi tubercle. Then dissect the skin and subcutaneous tissue with the help of fine scissor to indicate the border, both anterior and the posterior side, to expose whole of the IT band. Then with the help of 11 number knife, delineate both anterior and posterior side of the IT band, then pass the artery forceps underneath this IT band as a whole, then mark the central 1/3 of the tendon or the 1 millimeter, 10 millimeter of the central tendon width and 8 centimeter in length. Mark with the marker pen. Then detach it proximally, and then fascinating the under surface and from the vastus lateralis, keeping the attachment, keep the attachment intact at the distal segment at the level of Gandhi tubercle. Then whip stitching the free end of the detached IT band. Then measure it. It is approximately 8 centimeter. Then identify the fibular collateral ligament. Sometimes it is difficult. In that situation, we do the figure 4 maneuver to identify it. Then mark both anterior and the posterior side with the help of 11 number knife. Then pass the mixture underneath the fibular collateral ligament and dilate it to smoothly passing of this IT band, which is kept it in the extra-articular, extra-capsular, and pass this IT band underneath this fibular collateral ligament.
All right. Yeah, fine. Yeah. All right.
Then identify the attachment of the the lateral epicondyle, which is proximal and lateral. Then pass this the guide wire towards the anterior, and keep in mind you are not passing through this the reconstructed tunnel on the femur for the ACL. It is just touching. So before doing the ACL, we keep the thread inside this femoral tunnel. Then drill according to the size of this graft. Then pass this ACL, finish the ACL surgery. Then pass this graft through this tunnel and fix with the 7 mm bio screw in 60 degree of flexion and neutral rotation. Don't overrest tensioning over this graft. And this is the immediate intra-op stability. The knee is quite stable and there is no pivoting. Then closure of this wound with the interrupted stitch. Don't close it through and through. Otherwise, it leads to the over stiffness and over constant the lateral side of the knee joint. And this is the post-operative X-ray. It is a location of the tunnel and the button and the suture disc. And this is the picture I got from him today. He is under the rehab program. This is the around 9 months of the post-surgery. He is in Punjab doing this, doing his training. So thank you for your patience.
So wonderful result. So your decision to do LET is pre-operatively or intraoperatively? How do you decide you to perform in LET?
No, not on the intraoperative. It's decided pre-operatively because he's the, in particular this case, I have seen his activity and he's involved in that game. So I decided to do the LET along with this ACL.
And any chance of restriction of internal rotation? So in the sports which involves pivoting, you only need to pivot. So any restriction of rotations which happens with this procedure?
Restriction of movement.
Yes, restriction of rotations because it is going to inhibit the internal rotation.
Yes.
So any restriction, how do you manage the tension that you're going to give because it is going to restrict?
Yes, it is written in the literature. You have to apply the 20 Newton of the tension while tensioning the graft. Before coming this procedure, there is in the literature, there is overstuffing of the lateral side of the knee and the osteoarthritis. So in the original lemma, there is a fixation of this graft in the external rotation. So that leads to the type of complication and the over stiffness. Nowadays, it is just in 60 degree of flexion in neutral rotation with not too much amount of tension over the graft.
Sir, how do you ensure there is no tunnel overlap between both the?
Yes, it's very close to the while you are doing the, passing this graft over the femoral side. You are very close to your ACL tunnel. So for myself, I do the tunnel both on the femur and on the tibia, not passing the graft, just pass the loop thread, and then for the LET, pass the guide wire and check after all the steps. Guide wire, then put the scope, check the tunnel, whether your guide wire is through this tunnel, then remove it with the 4 mm of the reamer for the endovert, for the passing of the bead pin, again check, and then finally 15 mm of the femoral drilling for the graft passage.
Two more tips in this case, Ravi. One, you can keep the 4 mm reamer through and through that you have made initially in the femur.
Yes.
That keep there, and then you do the LET part. Okay. Another thing, once you have passed the bead pin for the LET tunnel on the femur, and you have removed the 4 mm. You can check the bead pin again inside with the help of a scope from the anteromedial portal, and you check in the tunnel whether this bead pin is not in your ACL tunnel. So these two tips, that is very confirmatory that you are not collision with your tunnel is not going to collide with the ACL tunnel. And third one, you can keep the thread there. But when you left the thread in the tunnel, and once you are with the 4 mm for LET, then there may chance, if your reamer is through that tunnel, then your thread may get entangled with reamer. So this is little bit dangerous. You can put the 4 mm reamer of ACL tunnel, left it is as in the tunnel. And then Bhushan sir, your expert opinion on that, LET with ACL.
So we normally just leave the thread as you rightly did. So if you leave the thread in the ACL tunnel and then you do the LET, and after that you put a scope in the joint and have a look in the ACL tunnel. And if you are able to see the guide wire going through, that means your tunnel is not right. And you can play with the position of the LET tunnel. You can increase the trajectory, you can change the trajectory going superiorly or inferiorly based on, well done Rajiv. So you can either go anteriorly or posteriorly based on your trajectory. But it's very possible that your LET will go through your ACL if you already passed the graft. So always be certain that it's not that there's no tunnel coalition before you pass the final graft.
But he said nowadays there are so many techniques. You can use the swivel locker also and the stapler to prevent that type of complication during your LET procedure.
Sirji, we are waiting to show you something.
So we have our next talk by Dr. Ashish Kumar. He will be talking on ACL tibial spine avulsion fixation.
Rajeev Ranjan sir.
And also he will be requesting everyone to register for ISCON 2023.
Thank you very much. मैंने क्या म्यूजिक वालों को स्टेज को सलाम करते देखा था. राजीव इतना ज्यादा स्टेज पे रहते हैं कि इनको भी ये ठीक है जो करके आए. So actually this is not exactly the case, but I've just modified it for the purpose, and this will serve the purpose, I think so. So a 24-year-old male, history of fall from bicycle 1 month back with a knee pain, swelling difficulty in walking that was immediately there, that reduced over the time. He can walk, but with feeling of insecurity. And on examination, the anterior laxity is there, rest of the things were normal. So if such a case comes, we go for the X-ray, we see an insignificant type of injury by the patient, but we all know it is not that insignificant and one has to go for the MRI. And once you see this kind of case, this was a case given to Rajiv while he was in Lucknow. Same case, he did it. So you see this kind of bony chunk, it's a big one, you are happy, you have many options to do it. If it's a smaller one, then it's a trouble. So, these are the views you see, and you understand that this is the situation where the tibial avulsion, this was the topic given to me. Tibial avulsion, a bony piece of varied size that is avulsed along with the ACL. So this is something which is common in children, which is contemporary to our ACL tears in the adults, leads to anterior instability, and malunion is a common problem with this, where there is an extension block into the notch. So this has to be taken care. This is the basic crux of this talk. This is the classification one should know, type 1, 2, and 3, and type 4 is also there. So type 2 is something which is the most common one, where you have a posterior hinge which is attached to the tibial eminence posteriorly, and anteriorly it is elevated. And of course, this is highly likely to get malunited with your conservative treatment and will lead to the extension block. This is the major issue. Of course, if there is a combination, then it's a different story. You have to be more cautious. When it's floating high up, then it has to be taken care in a better manner. And the type 1, where it is undisplaced one, there you can go for the conservative. This is the basic thinking. Old tested techniques, old tested thing. We all know it. We all do it. And anterior part of the knee is always easy to play with, and everybody is comfortable with his own experiences. Another classification the MRI people have proposed, but I think that one, the first one that we have seen, that is good enough to understand. If you go for the further understanding and make things more clear and happy for you, go for a CT scan where you can get the size of the chunk, whether it's a just wafer-like or if there is any combination. So this is what you can go ahead with this CT scan. Now, what should be the treatment option? Of course, the simple algorithm. If it's an undisplaced one, just wait in extension, full extension, and confirm that it is reduced to its crater. Once it is reduced in its crater, no problem, you can achieve full extension. Just leave it as such over there for a few weeks and then go ahead with the rehabilitation. Type 2 is again always plus minus either way. If you can do it, better to do it. This is what we are doing so that we can start with the physiotherapy and prevent other complications like stiffness. So this is, and the type 3, definitely you have to go for the different techniques of reduction and fixation. And the timing of surgery, earlier the better. We all know it. Once we are going to repair anything, earlier is the better. Delay leads to difficult reduction, and if it's a very old one, then crater has got a lot of fibrosis that you have to clear out. And hypertrophy of the Avals fragment is reported also. So it's not sitting into its crater easily. Contractures, ACL also is a problem. So whenever there's a chronic one, always tell the patient, I may go for a repair or I may have to go for a reconstruction. Of course, taking out that bigger part is always a problem. You create a mini arthrotomy when they are big chunks and you think about the reconstruction. So we have done up to many, many years old also. If it's a big chunk, then one should try, and we can do it by doing some special things, and we can go ahead with the repair also. So open reduction, older time, we are not here to discuss that. Arthroscopic reduction and fixation with the sutures, with a mini tightrope that Rajiv did there. Screw fixation, we all have done it. We know that it has got its own problems at times, but definitely a time-tested procedure. Screw fixation with a 4 mm screw is good enough many times. Other options like K-wire, bent K-wires, staples, I don't have experience of them, but people have done it. This is something given in the AO manual with a circulage wire people are doing, but I have never done it. Not any experience, but must be a very cheap procedure. It appears like that. So one can do that. These screws are time tested. We have done it, but controlling their direction, you can create more combination. These are the problems. So, and hardware removal may be a trouble later on, but many times you need not to do it. It works very well. So it's a big chunk like this. We have seen in this MRI, you can go very well with this screw fixation and it works. As you keep tightening it, it compresses the fragment very well and there's not a problem. These staples I have never used, but people do it. I have seen few videos like that. This is one thing very important. One should understand that underneath your fragment, there can be menisci which can go inside. And of course, this transverse meniscal ligament is something which definitely hampers your reduction many times. And you can very well remove it. You can pull it anteriorly through another portal and can go ahead with the fixation, or you can simply remove it. It is not doing anything, which is very important. So just a small video I had for the intermeniscal ligament that you can see it is lying like this underneath the chunk and it is hindering your reduction. So you can very well remove it, but it's a known thing. Then this was the mini tightrope fixation that was done. It is proposed by the Arthrex. So you can very well do it. It's a big chunk. You can reduce it, press it upon with the simply your ACL jig, drill it with a less than 4 mm. Its drill is provided with that. And you can either just flip it, try it, it can flip by itself, or you can ensure with your hook because in a lot of space where you can work, flipping, and then you can pull it and like any other tightrope, you are tightening the thing. So this is one of the way of managing these things. But position of this tightrope can many times lead to malreduction also. So that's one thing you have to be quite careful. said you do it, but and this endo button can sink inside also over the time. So these are the little bit of problems with this procedure, but definitely it's one of the. Chalo bhai. People have used the threads used for pulling this tight rope. They have used it with the swivel lock anchors. You can just press it upon, put some swivel lock anchor either side, but that will exponentially increases the cost. That's the other thing. Then this is something very important. We all are doing with the sutures nowadays. The suture lever technique is definitely a very well established and very good technique that we all are doing. People started with using a single thread around the ACL. Then people use 2. Now it is proposing the 3 threads fiber wire that you are using. So the central one is going to reduce your fragment to its crater. That's important. You take this first bite and then go in the posterior part of the crater and pull through tunnel. That will lead to reduction. Instead of putting a K wire either from outside or from downwards, instead of putting a K wire and theoretically increasing the chance of combination, you can use this thread, which is not disturbing at all. Even if a small wafer, a small bone, then you can do with this technique very well. So this is the concept. See this video, spend a little bit of time. It's a good one. And it shows that you are separating the ACL and PCL between the septum. So this is, you can see, this is the chunk. And as you clean it up, you will see that's again the most common one. The type 2 has got a posterior hinge, and you are cleaning the crater, the blood clot, the bone pieces, and the fibrosis that can be there. Just clean it reasonably. It's a cancellous bone. You can remove as much as you wish. So be careful. Just
tight nahi karna hai.
So just take this first bite from the central part and make a nose around it. When is sitting here, this nose. So you can make it, you cannot make it. I will show his one slide afterwards, as I always do. So this is in the posterior part of the crater that you just come out to shuttle this suture through that tunnel. So this is how you just shuttle the first one that you had taken. And as you just pull it down through the pull-through tunnel, you will see that the fragment is going and sit in its central part. So this is, instead of wire or anything, this is the suture lever. This is the lever that is pulling down. So you are not disturbing anything with the bone. Now you are free with the reduced fragment, one from right side, one from the left side. Take 2 more sutures, make 2 more drills, 4 millimeter, and just pull through. So 3-point fixation of the fragment. You tight it over a suture disc or something like that, and then you can start with your rehabilitation on the very next day. The biggest advantage of this technique, once you have secured everything, fixed inside, and don't worry about the vascularity of the ACL. They are long-term studies.
No problem.
So nothing happens to the vascularity. But on the rare occasion, they have said that ACL will fail above this bony fragment. But most of the time, people are very happy and there's no trouble. So the last suture that is being pulled out, and you just see that you have a 3-point fixation of your ACL. Then, so this is what I was talking about. Vinay has posted these movies. I just copied them, but I always say that I show because of him. Most of the and this is how he is saying, instead of making the noose around the ACL, you pass the loops like this. That will be more happy patient here. So in epiphyseal time, you can use simply an anchor. You can do with this kind of repair simply, instead of piercing through the epiphysis. This is what you can do. Rehabilitation depends on the quality of fixation you have created, and there's nothing very specific about this. So just gradual, you have to resume till the bone unites, and you can leave the person.
Sorry.
happily. Complications, of course, knee laxity may still there be persistent. You did a good job, or it didn't taken over by the nature. The failure of ACL proximal to the bony avulsion can at times happen, and you have to do later on ACL reconstruction. Quadriceps weakness and wasting is an integral part of any ACL injury. We all have seen. Arthrofibrosis, if you don't start early exercises, and malunion may lead to extension block. These are the problems. Literature is full of articles. If you talk about, it's old techniques, and people have minor changes. And the important thing that ultimately it says everything works well. So there's nothing like that this one is better or that one is better. Putting a screw, its direction, creating more comminution, these are the ever-present complications. Sutures are a safer option. So this is what I can summarize at the end. It's not an uncommon injury. Meniscus, transverse meniscal ligament and bone pieces are obstacles to reduction. Be careful for them. Identifying, removing blocks and reduction may be critical for good outcome. Suture screw fixation technique can provide good outcome for displaced fractures. A strong fixation permits early rehab and predictable results. So at the end, for what I am standing here, this is the ISCon upcoming. I request everybody to please register for it. Everybody has to register, whether he is faculty or he is the delegate. And for those who are heading their institutes, I request please promote all your residents to go for it. Early bird is up to 15th of April. And we are not planning to extend it any further. It's very clear. So please promote them. And we are having the cadaveric workshop also on the 31st. That is a pre-conference workshop. It is all there, as you see, and abstracts is also open. Although there is a reasonable time till 31st July. But still, those who are willing, they can send it. This is what you can search on the Google. It is IASCon. You have to write full IASCon 2023. Then it will be there, and you can see everything, all details which are updating continuously. So welcome you all to Lucknow, and that's it. Thank you very much. Any questions? Anybody?
Rajeev sir.
Yeah.
Rajeev sir.
Yeah, Rajkumar sir.
Okay, ji, I'm just waiting for half an hour now. You can imagine my condition. Anyway, Rajeev,
yes, sir,
can you see what I'm trying to show you? This is the last of the inside out suture that I'm going to show you.
Yes.
You can see this. I just kept this for you to see. This is how the needle will go through that. Okay, it's a curved device. Can you kindly pull that? Kindly pull that. Yeah, pull. Yeah. Okay. So there are a lot of vertical sutures going in here in this fashion.
Yes.
Yeah.
So it's a continuous vertical mattress suture you are putting.
Continuous vertical from anterior to posterior. You can see this.
And I think that has a best cinching effect.
Yeah. Okay. One is here. The second one is there. Third one is here. Some of them are fiber tapes. Okay. You can see that.
Yeah.
This is a suture tape. Sorry. Here. Can you see that?
You are using Zone Navigator, sir?
Yes. Zone Navigator.
Yes. And then this is the undersurface meniscal suture that I have put. Can you just pull the tape, brother?
Yeah, pulling that will reduce the meniscus flap. Uplifting of the flap. Yes.
Aram se. Bas hai.
And you can, yes, it's getting reduced.
Okay.
Yes.
So you can see the sutures on the top here. Okay. You can argue whether this is good or bad. Earlier, when we were doing meniscal repair, they used to say that the meniscus should be a good meniscal repair will have a everted meniscus like this. Okay. But later on, we started putting the top surface as well as the under surface to make it flat on the tibia. Okay.
Yes, sir.
So, any questions? Otherwise, I will be signing off after tightening all this here.
Yes, sir. So I think it's, sir, the whole of the meniscus has reduced well. There is no uplifting also. And you have shown all inside technique, inside out technique, and all this technique. And I think in 2023, we should come with the note, save the meniscus whenever it is possible.
Yep.
And Ashish sir is also requesting that you should show this procedure in ISCon 2023 in Lucknow.
Thank you so much, sir.
Thank you, sir. All right.
You can also augment this with the fibrin clot. It is arguable because already when we debride this, there will be some amount of blood clot coming. But if you want to add an extra blood clot here, it is feasible. And
by anyhow, you are making
other
ACL
things
tunnels, sir. If you go for ACL reconstruction, you will get enough blood from those tunnels.
Yes.
Down over the raw area.
Yes. Thank you.
Thank you so much, sir. And big
Arvind
clap
sir,
for Rajkumar, sir.
Raji sir, Sabnis, thank you so much. Chalo. Cut the live and then let them proceed with what they have done. Chalo. Thank you.
Said that you have repaired a few of the cases which were more than 1 year old. So does the quality of the ligament remain the same after 1 year? But I have repaired maximum up to the 3 years.
I think ligament is not disturbed, but you have to make a little bit of release. Rarely it can be contracted enough that you are not able to bring it down.
Not
So
required.
you have to tell the patient, I may not be able to do the repair, but if you make a gentle separation upwards releases, then you can make it. It's not a
Top
big
light, please. I need top light. Yeah.
quality remains the same. Quality is not that bad. No way. Quality is okay. Anybody has other experiences for the older ones? Any compromise with the quality? I don't think.
There was a study in Japan where they said that when there is immediate fast disruption of ACL complex, it is the bone which comes up. It's a gradual deformation, the ligament like snaps. But it is never absolute this way or that way. It is somewhere in the middle, gray zone. So there is deformation of ligament as well as the bone that comes out. Whatever happens earlier, bigger, it is intrasubstance or avulsion. Based on that, the Japanese people, they recommended that taking bite through the ACL would not be a very good idea. So taking the circumferential bite and doing something and knotting. So it's never that the ACL ligament is, there is 50% patients who had intrasubstance changes in their ACL as well. So that is.
So now scorpion has come. Otherwise, we used to do with the lasso, or rarely with the only right angle only.
Yes.
That works. So normally we are doing that.
I think that regarding the question of Dr. Rajeev, you were asking about the position of the about the quality of the ACL, and I think. Chances that it might retract a bit more over time. My question to the house is that how many of us are using antegrade devices and how many of us are using retrograde devices for the suture technique, suture pull-out technique? Integrated? Hands up.
No, what do you mean by antegrade and retrograde? Oh, lasso and all right. So I think lasso is the standard. If you are comfortable with lasso, we have started doing it with.
But you can take a big bite that goes almost from the posterior part. So it is something like circumferential only. You are not going into in between.
I think if you are comfortable with any one of them, either the antegrade or retrograde, you can just, because you want a cinching suture, cinching loop there, and there should be a 3-point fixation, one central and one on the medial side of the gutter and another on the lateral side of the gutter, so that you can mobilize this knee early. That is the main issue. Yeah. Yes.
So about the chronicity of ACL spine avulsion. If it is chronic one more than 2 months or 3 months, so repair depend upon the chunk of the bone. I have seen sir has fixed almost 3.5 month or 4 month older injury. John sir has fixed in 2014, and that patient period. So it's depend on bony chunk. If it is a small or very small bone is there, and if it is chronic ACL, it's not the bone to bone healing, it's the ligament to bone healing. So in that case, the chances of failure is high if you do repair with the chronic ACL. If fragment is bigger, bone is bigger, then you can go to 3-4 time. Definitely the vascularity of this ligaments.
The only issue is when you are dealing with this neglected ACL avulsion, there is synovalization of the fragment, and you have to make the crater, you have to debride the crater also, and sometimes you have to debride the undersurface of the bony fragment so that it sits well. But anyhow, if you can repair this ACL abrasion, that is the best way to that.
Regarding the chronicity of this advanced Ashish, most of the time to body cases or old cases, where there is carrying of the student of the application to the new goal. That situation is when we are going to start fragment. There is a chance of a person of the
to re-tear or the rupture of that anterolateral meniscal fragment, anterolateral meniscus.
Anterior horn of the lateral meniscus. I think that is attached with the fragment.
Recently, I got to one case where it was a continuous avulsion. So for that reason, to me, the meniscal root was more important. Otherwise, I could have gone for a reconstruction later on. So I just fixed it, taking the loops around the junction of that kind of thing. But whenever you are doing it, you have to be cautious. You have to first delineate your margins for the meniscus. You should not disturb the meniscus. That's a sacrosanct. If you do that, then it will become criminal. So when you are so accustomed to see the anterior part of the knee and where the ACL lies, this is the basic bread and butter of any arthroscopic surgeon. So how can you say that you can do any damn thing you wish to do? But otherwise, you have to be first clear that this is the ACL which is coming here, and I have to be safe enough. That's one thing. Otherwise, I have no specific answer to this question.
Thank you, sir.
On anatomical ACL reconstruction with radiological evaluation.
Right. Okay. Good afternoon, everyone. So thank you for inviting me for this talk. I think I have given this talk 2-3 occasions on different platforms, even in Patna. So what we do is that we started using SIA and our indigenously designed grid for doing ACL, making the tunnels for ACL reconstruction. I will show you the results at the end of the day, where we are right now in that and what we are doing. So the whole idea is to reconstruct the anatomy as it is, as close to the native anatomy as possible. Okay, there are a lot of common mistakes that people can do in ACL reconstruction, and the commonest of all across all the literatures, if you talk to the surgeons, if they evaluate it correctly, it's the tunnel position. Okay, the most common problem with all the ACL reconstruction is the malposition of the tunnel, though there are many causes of failure. Okay, so how to correct that tunnel position is very important. You want to preserve the remnant because remnant has something. Remnant does have something. It has proprioception. It has neurological implication in a longer run, because we know that at the end of 10 years, 12 years, probably patients are losing the effect of what you have done the reconstruction for. So it is very important, as long as possible, as much as possible, to, and if you have the remnant, to preserve it. But then there are many literatures about preserving the remnant, many literatures about the tibial tunnel and femoral tunnel position affecting the outcome of your ACL reconstruction. Okay, so there have been many theories in the past. Lot of the time, anatomy has been redefined, defined. Lot of lines and ridges have been told. Okay, but then how to recreate it? Because the ACL never changed. The ACL anatomy in the human body has never changed, but we have kept our, how to make the tunnel, how to position the patient, we have been keep on changing. We have taken the clock into the theater, and we have taken clock as 2 o'clock position or 4 o'clock or 10 o'clock, whatever. But then again, ACL anatomy has not changed. Okay, so there are papers where when you're doing a single bundle ACL reconstruction, how you are going to use it. So intraoperative navigation is one, you can do it. Okay, there are methods to use fluoroscopy in the past, that if you're using fluoroscopy, the outcome improves. These are older papers in the past. Okay, so and then what you people have done is that they have done it without doing fluoroscopy. They have revisited their tunnel and they have found the ways to improve. If they think that they are too much behind, too much front, too much up, they have come back and improved it. But our idea was to how to improve it real time. So we took Bernard and Hertel grid. These are the papers in the past where they have inbuilt Bernard and Hertel grids inside the SIAM. So they proposed to use this grid, and this is how they were doing it. And there are many studies which has told us where exactly in a single bundle reconstruction the tunnel should be or the bundle should be placed. So what we did is that we designed a grid which was printed on a transparency sheet, and we took a SIAM image before making the tunnel by just putting the guide pin, and we just measured where it is and where we want it to be, and we changed it accordingly before we started drilling. So initially it used to take 10 minutes for us to overall extra 10 minutes. Now it is just 3 to 4 minutes. This is in the femur, and then this is in the tibia. Okay, so this is a small video. Okay, so what we do is that SIAM is positioned from top or bottom. So SIAM is positioned, we don't use a leg holder. It's just that patient knees flexed on the table. Okay, and we take a shot. So we put our guide pin there and we take a shot, and then we measure it. We measure it and we want to, and if it is not where we want to, then we change the position of the guide pin. So we measure, because these are equidistant boxes, and it is showing that it is at the 18% from front to back. We don't want 18%. Okay, so we'll change the position and then we'll take a shot again, and we want to change it. And then if it is according to where we want, we'll go ahead and drill it. So we have changed the position. You can see that it is like 5 boxes from behind, and it is overall 18 boxes. So equidistance boxes. So 5 by 18, it will be roughly around 27. 5 by 18, roughly around 27. So this is where we want to be actually. In your femur and top to bottom also, we want to be at 33%, which is exactly 37%, which is exactly where we are. And this is a very small step, very small device, with which you can actually make a difference. Same is in the tibial tunnel. You'll place it. You place it where you want with your seeing the anterior horn of lateral meniscus. But then taking a SIAM shot, it does improve little bit here and there. It does improve. Okay, so what we did is that of course there are pearls and pitfalls of all these methods. Pearls is that you want to preserve the remnant, which you easily can, and it's non-expensive to start with, and it is very easy to master. SIAM is there in every theater. Pitfalls, of course, if you are using a transtibial femoral tunnel technique, we have not done using that, and it may be difficult. There is definitely a risk of radiation exposure, but then, and one value may not suit all the patients. Okay, but then most of us are doing a single bundle tunnel placement, so this actually does not come into place. Then we evaluated all our SIAM tunnel with 3D CT scan, and we took measurements. So we went ahead and we published this grid in 2017 in Journal of Arthroscopy Technique. And recently what we did is that after taking this 3D measurement, we followed our patients for 4 years. So those which we did from 2014 to 2017 and from 2017 to 2021 mid and 22. So we followed them functionally. Their tunnels were seen by 3D CT. Both the group tunnels were seen, and we published our results in just now in Arthroscopy Journal. And we found that our femoral tunnel placements have drastically improved. Okay, we have not changed anything in the past. Only the SIAM and the grid was changed, and our femoral tunnel placement, you can see, have drastically improved. Not so much as the tibial tunnel position, because tibial tunnel, there is a less chance of you going too much wrong. Okay, does it really improve when it comes to patient function at the end of the day? Yes, it definitely does. And at the 4 years, all these parameters at the end of 4 years, they showed up good with statistically significant definite improvement in patient functional outcome. So, and of course, we are making this as a more user-friendly device. We have patented this. We have filed a temporary patent. We are improving our device so that it can be used for everyone, and at the same time has to be very, very cheap. Okay, so of course, this improves our tunnel position, and we have shown that over a period of time, 4 years is not a small period. Okay, of course, we don't have too many patients who play sports. We don't have too many patients who play sports, so that could be a different ball game altogether. But then 4 years time for the average patients that we operate, for at least I do operate, they have shown a significant improvement in 4 years. But this method, SIAM, grid, and follow up all these patients. So thank you very much. Utilizing SIAM is definitely not difficult and can be easily be done. Thank you.
Nice study, Sudeep. Sudeep, so what is your position of the knee when you are taking the CR 90-degree flexion or hyperflexion?
Hyperflexion, definitely.
Hyperflexion.
We start with 90. So when we start with 90 and we hyperflexion.
And you don't use the offset jig also?
No, I don't use
6 minutes.
Good.
No.
6 minutes.
Just 1%. Where do you?
The 5 or 6 minutes. Hello.
So it has to be at 42 to 44% from front to back. Okay. In the relation to the in the center. In the center.
रहने दो, लटके रहने दो. मैं ऐसे करता हूँ.
Your tibial tunnel should be averting the anterior part of the tibial spine.
Yes, it should be.
It should be absolutely parallel to that.
It should be absolutely parallel to that.
ये meniscal injury है.
Ideal.
Sorry, MCL.
So that's the tip. Probably you will show it in the theater when you are operating. Thank you.
I think we are ready for live surgery. I would like to invite our moderator, Dr. Ashish Kumar and Dr. Avinash Kumar.
Hello, am I audible, Dr. Ashish?
हेलो हाँ लाइव छोड़ दी
Am I audible?
माइक में बोलिए हरी भैया
Okay, I think I'm not. Your voice is not coming that great here, Dr. Ashish.
Hello.
So I think if we have a short history.
हाँ भैया.
हाँ जी. So is this patient? हाँ. आवाज आ रहा है हमारा?
हाँ अच्छे से आ रही है.
So this patient had a short history. 18th March he had an injury. He is in the RTA. He is in late 20s, young lad. So this is what I got. Clinically, the drawer was positive. The lashman was positive. It was very painful knee on the medial side. I couldn't elicit that much of opening, but it reported MCL, I think grade 2 in an MRI. On scopy, this is what I found. After under anesthesia, it was opening in in 30 degrees on medial side valgus, but not on extension. It was not opening, so it's more of a superficial MCL. You can see that's a drive-through sign is positive. I can see the MCL injury there in this patient. Okay, so that was an ACL tear. I have done little bit of cleaning here, and I also have some radial tear of the lateral meniscus here. Okay, quite friable here.
Inner picture is not seen. Just.
अभी दिख रहा है?
हाँ अब ठीक है.
So this is what I have on the meniscal side. So I'm going to repair this with an horizontal stitches. Quite a big tear it is. So I think posteriorly it is continuous, but this is how the flap. It's a big. We can say sort of a radial tear only. Okay. So what I have taken is, I have taken the peroneus longus in this because he has an MCL injury. I have taken a hamstring tendon with an open stripper attached onto the tibial side. The graft is lying here. Outside picture भी जा रही है ना? So I have taken a peroneus longus. I have tripled the peroneus longus. The graft is 9 millimeter. I have tripled it with a fiber wire. So the graft is 9 millimeter. So I am going to drill my tunnels because I still have some. Oh, the spoon is there. So I am going to.
You will use peroneus for ACL.
I use peroneus for ACL, and the semitendinosus is attached on the tibial side
For
for
MCL.
the MCL. So that is my plan. So you can see, can I have the tibial jig? So let me show you the stump. I have looking from the standard anterolateral portal. So that's the stump of the ACL. So for the residents, this is the interior horn of the lateral meniscus. So that is what is in talk now these days. So this is the level where we drill all our tunnels. So my jig drill bit has to come out somewhere from here. That is center of the stump of the ACL and on the highest point in parallel to the posterior border of the anterior horn of the ACL. So that's the plan for it to come. And if you look at the stump on the femoral side, so this is the ridge here, and that is the entire stump of the ACL. That is the over the top position. So since this is a fresh case, it's very easy to identify. We have to make everything behind and below the intercondylar ridge or the resident ridge. So the ACL lies in the lower 50% of the nose. So we are not talking these days of the clock position. So we have to make the tunnel somewhere here in the center of the stump of the ACL. So I take a jig. So you can see this is a meniscus referencing jig, but the mark is not that great. So I am parallel. And so this is where my drill bit come out in the center.
Joshi sir, can you check the white balancing of your camera, please?
Okay, I'll do it once more. White balance करना मैं यहाँ से कर रहा हूँ. White balance दबा दो उधर से. Somebody press the white balance. Yeah. Now it's okay.
Yeah, it's perfect now.
चलिए. So, am I okay with my tibial footprint? You can see the entire tibial footprint and the anterior horn of lateral meniscus, and I am totally parallel to that. Okay.
Yeah, looks perfect, sir.
So I will go towards the midline on the tibia. It is basically between the posterior border and the shin. So I don't injure the MCL. I am good. धीरे धीरे जाना है ना. रेजिस्टेंस आ रही है मेरे हाथ पे. So I think everybody agrees that we have to do MCL in this case.
Yes, sir.
थोड़ा उठा के करो. You leave this. You leave the foot. Let it hang. Yeah. Now go. थोड़ा ऊपर उठा के करो. टेढ़ी जा रही है. हाँ चलो. नहीं तुम मत उठाओ.
Dr. Deepak.
Yeah.
Why are you making tibial tunnel first?
That's everyone asks me. It is just that this is how we are trained. So we never change, but definitely you can make a femoral tunnel first so that we have less of an extravasation. So it's just that this is how I was trained by my boss and I have continued to it. But it doesn't matter. You can make a femoral tunnel first and put a thread there and do the repair, and you can come back again for the tibial tunnel. So that is also can be done, and it is better to do that way, some people say, because there is less fluid extravasation. The pressure is maintained. क्या चीज नहीं है अभी? दिल फंस गई. So I'll just wait.
So even if you made the first tibial tunnel and you want to prevent the extravasation of fluid, so
Yeah.
Plug comes cannula.
You can, yeah, you have lots of tibial plugs, commercial plugs also come. If you don't have the plug, you can use the cap of your T or set. Okay.
Yeah.
So that is what we used to do. And that is what I would be doing. Yeah. Chalo? Okay. So I protect. You can happy with the tibial tunnel? Sure.
It looks perfect, sir. Just one question. Suppose it is a little bit posterior or little bit anterior.
Yeah.
So you change it or you do with a smaller reamer and then...
Yeah. If it is little bit, then it's okay. Then I change it. Do a smaller reamer. So I am here. I use the 9. So use a smaller reamer, 6 millimeter, and you can make it posterior or anterior. Because if you drill it once or twice, I think after that it is very difficult to find a track. So that is the best way to do that. Okay. Now, yes. क्या चीज रह गया? आवाज नहीं है.
Deepak sir, we have lot of our PG students and senior resident also here. They wanted to know the exact placement of over the femur, about the resident ridge, and about the anatomical position of ACL footprint on the femur.
Yeah, let me put my scope on the medial portal. Leave it hang. Let it hang. So you can see how the ACL looks like. Okay, so that's a fresh case. It is very good to see in the fresh case. If the ACL is chronic, sometimes these landmarks are not visible. So this is the ridge. Okay. This is the ridge and ACL, entire ACL is behind and below. You can see the entire stump. There's the posterior or the top position. The ACL starts from here. I'm looking from the medial portal. So this is where there is an anteromedial bundle. It is very near to this ridge. Okay. And the posterolateral bundle comes here, which almost touches the cartilage. Okay. It is below and anterior, the posterolateral bundle. So this is how the entire oblong ACL. Now, what is the exact point, the G point, Dr. Joshi used to say? It is very difficult to find where exactly it is the exact. So we take it in the center of the stump. So if we are not, there is a chronic ACL, sometimes the ridge is also not visible. Okay. Sometimes this ridge is also not visible. So if I look from the anterior portal, so when I think, Arvind, you also must be knowing, we used to do lots of transcerebral. This is how we used to look. So ridge used to be anterior. So people mistake it for the over the top position and make the tunnel here. So which is anterior. Okay. So ridge is here. So now with an anteromedial way, we look like this. So the ridge is, now this is the ridge and the entire footprint is below and behind. So in nutshell, if this ridge is not visible, intercondylar ridge or the resident ridge is not visible in chronic cases, try to make the tunnel, use an offset and make a tunnel somewhere in the posterior half of the notch and in the lower 50% of the notch. Okay.
Yeah, thank you, sir.
So I need an offset of, so you can use a freehand technique and an offset. Offset is easy. So I do little bit of cleaning just to place my offset, whether my offset is reaching fine or whether I have to make an accessory anteromedial portal.
You are using 7 millimeter offset all the time or sometimes switching to others?
6 and 7. Depends on the size or the diameter of the graft. So I am trying to look at the posterior most point, the over the top position. So that's the over the top. So here the graft is 9. So I use a 7 millimeter offset. And you give me that thing. Oh, wire dalo. Yes. Straight wire. So 7 millimeter, it is basically we remade 4.5 in front, 4.5 in behind. So I expected 2.5 wall. So that's a spade wire. Spade wire is there with Arthrex.
The position of your knee.
Yeah, it's
putting this jig and other things.
Yeah, while the position of knee is 90 degree, so I go behind and behind and behind. I reach the posterior most part, and when I reach here, I just flex it. I ask my person to flex it more than 90 degree, and और flex ये हटा लो, पिल्लो हटा लो बेटे, नहीं ऐसे नहीं करो, फिर सीधा करो है ना, थाई को पहले बाहर निकालना है और फिर फ्लेक्स करना है. तो ये भी डक एंड फ्लेक्स 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 more flex. So I just do a little bit of hyperflexion around 100 degree. You can see I am in the center of the stump and below the ridge. So when I flex it, the posterior part of the condyle comes in front. थोड़ी बाहर निकाल दो ताकि easy हो इसको drill करना ना. हाँ, very good. बस ऐसे ही रखो, छोड़ना नहीं अब, है ना, flexion. So the spade wire is good to measure the distance from the far cortex. आगे नहीं, बाहर नहीं निकालना, बाहर निकालो थोड़ा, अंदर करो, अंदर करो. बस ठीक. नहीं, फोरम की ड्यूटी नहीं है इसमें, ये हो गया, फोरम में होगा. So that's the size of my tunnel. Standard, it always come like this, Dr. Ashish. In our patients, is always in this position. Nah, I will rather put 7 out of 10 time it comes like this in the male patients. 35. So it's okay. So I am pulling it. So this is for the resident. So my distance from the far cortex is 35. So I am going to ream now. So as per the literature, we should have minimum 15 millimeter graft inside. So I'll ream 20. This karo. So 15 is what the literature say. Now the another Japanese literature is saying, they say even the 10 millimeter graft can incorporate. But we go by the standard 15 millimeter. So plus 5 millimeter for, so that I don't have any, I am clear that I am more than 15 millimeter. So if we have a fixed loop or anything, or we have a smaller tunnel, we can still use variable. So around 20 millimeter has gone inside.
Dr. Joshi, please adjust your mic. It is not sounding well.
आवाज नहीं आ रही है, देखना.
बहुत धीमे धीमे आ रही है.
किसकी मशीन चल रही है? अभी आ रही है डॉक्टर आशीष?
हाँ, कुछ ज्यादा ही आ रही है.
अब ज्यादा आ रही है, देखना. थोड़ी कम करो. So I have drilled. ना आगे सेट ना. So I have drilled, reamed around 20 to 23 millimeter. I wanted 20 millimeter, so it has gone up by I think 2 millimeter. So my now this is a variable loop. I am using a tightrope RT here. At 35 millimeter, I can also use a fixed loop. So fixed loop have different way of measuring. In a variable loop, it's very easy. You have to just ream, and the amount the distance you are reaming it is actually the graft going inside. So since I have reamed around 20 to 23 millimeter, my graft will go 22 millimeter inside the tunnel. छोड़ दो बेटा इसको, सीधा छोड़ दो, सीधा छोड़.
Your predilection for which fixed loop or variable loop?
No, since other arthritic people are there, but I always these days I'm more inclined towards fixed loop.
Towards the fixed loop.
Yeah, the only variable loop I believe is that works, that doesn't loosen, is probably the tightrope, and one more that I won't tell here. So arthritis So whenever I use a variable loop, I always use an Arthrex device because it has lots of studies which shows that it doesn't loosen. OWASH कैनुला दे दो कुछ दिखाएं टनल.
So Joshi sir, you have did ACL reconstruction with variable loop for many years. Any reason behind shifting from variable loop to fixed loop?
So most of I feel that there is, even if there is a 2 millimeter of loosening of the loop, that is good enough for patient to have a post-op laxity. So when we examine, the patient has some post-op laxity. So that is the reason most of the loops are not that very good. They do lengthen a little bit. So that is the thing that I always have, even if you can see the studies. You can see the tunnel here.
Yes, sir.
Yeah, you can see.
It's 2 millimeter. It is in the center. Okay.
Yeah.
So that's how the tunnel looks like. So we have a cortex and we have a socket.
And how much distance you want from the articular side?
So it's almost near to the articular side. Okay. The PL bundle comes somewhere near the articular side here. So maybe I'll say 2-3 millimeter up. So the idea is to put in the center of the two bundles. So we'll be around 2-3 millimeter up the articular side. Okay. So the idea is to make the entire tunnel in the lower 50%. And this is a ridge here. So basically the ACL sleeps. It's doesn't make a perfect triangle. Picho? Yes, sir. Picho? So that's how the tightrope. So the idea is that the ACL basically sleeps in front of PCL and not the perfect triangle. That's how the tightrope button is going inside. Okay, lead karo kuch. 1 minute karo. Upar karo. तो टॉकर ले लो, उसको घुमाना है. टॉकर ले लो, ऐसे ले लो सबको. What are you doing? Okay. Don't. So the variable loop, the issue with the variable loop is that.
At times you can pull through the facial lata.
Yeah. चलो घुमाओ. ग्राफ ठीक था जी सर. टॉकर ले लो. ये लो, मैं करता हूँ. ना मत करो, ये ऐसे मत करो. ऐसे पकड़ो इसको. ये पकड़ो. तुम करोगे सर? So we have to have an assistant. So we have to rotate. So that's how, if you can look at the outer picture, he is rotating on the hemostat. And put a retractor here. Take a retractor low. Okay.
Sir, Ashish sir.
Yeah.
So would you like to see the button flipping in the variable loop
Yes,
device,
we should see through the tunnel inside.
Okay.
Tunnel view from the medial portal. You must see it. Dr. Joshi?
I'll show you like that also.
Yeah. That's a fancy, good looking.
So you can see it going up. So that's the mark here.
Yeah.
Okay. So the rotational pull, don't pull it horizontally with your force. So we are rotating so that the button doesn't go into the soft tissue. Now leave it.
Yes.
Hold do, chhod do. So I pull it back. It's not coming. So we have a RT device where we can also check the flipping. देखो blue और उसमें देखो flip हो रहा है कि नहीं. So we have a blue and tiger here. So we'll check the flipping also. So that's the interior. So you can see the ACL is in posterior and lying in the.
The mark at the mouth of tunnel is also confirming.
Yeah, it's confirming that it is in the. Yeah, so he had tested also, because sometimes the button may flip obliquely. So this is why the Arthrex has come up with this tightrope device where we have another additional fiber wire to check the flipping. Karo, shorten karo. So now we have the white threads. So this is a variable loop. So it shortens, it takes the graft inside. So it has a Chinese trap mechanism at the edge of the button. So there is only one unidirectional shortening. Yeah. So that's, you can see the graft going inside.
Yes, we can see.
So, so very slowly, the variable loop can break. Very costly device. So one thread at a time. The graft has to be very bended. It's gone.
Mark 20 पे.
Mark 20 पे था. चलो थोड़ा सा और. ये देखना स्पीड इसकी शेवर की तेज नहीं है. कितने पे है ये? Can you see?
Do you pull it completely or leave some space for the final tightening at the end?
I generally do it completely at here. Right now only. So that's what is not going further. And I can feel the flip again now on the button. So that's how it has gone inside around 20 millimeter. Okay.
Okay.
So if I look from the anterolateral portal, this is how it looks like. Can you see?
Yes, we can see that.
So I have the entire stump you can see in front of me. So I will just debride it a bit so that there is no scope of impingement. Try to do minimal thing so that this will provide some proprioception. If I extend it, you can see how it looks like. It goes away from the notch and everything is in the notch. Okay, extension. So this is how it's going to be the ACL. नहीं अभी मैंने इसको रिपेयर करना है.
Meniscus repair.
So I am putting the scope in the to the above.
Dr. Joshi.
Yeah.
So felicitation and other things are to be done. So
Okay.
your video is on. But,
yeah, what I am going to do is I am going to do a meniscus repair here, the same fiber stitch that Dr. Amaravati used, and I am going to do an MCL, make an MCL tunnel. Okay, I will make a basically, since it's a superficial MCL, I'm used to use this free end as a graft. I'm going to make a tunnel behind the epicondyle of the femur. Okay, and then I'm going to put a screw there. So and the double loop will come back. Since there is no opening in the extension, so I am not going to make a POL. I'm just going to make a superficial MCL. I'm going to stitch it, bring it back, and I'm going to stitch it. So this is what I am going to do.
Fine.
How will you take care on the tibial side, the direction of MCL, while you are using the insertion?
On the tibial side, basically, I am not, either you can make a tunnel. The anatomical way is that you make a tunnel behind, okay? So I'm not going to make any tunnel, but when I'm doing a POL and I make a tunnel, the direction of the either I'll use a swivel lock ankle to fix it, the graft, or so that I don't need the two tunnels, okay?
Okay, so you will use the insertion of
semitendinosus, yeah,
and change the direction by using a swivel lock.
Swivel lock, yeah.
Okay, okay, thank you.
Table up करना.
So, thank you, chairpersons. Is the time we felicitate our speakers, chairpersons, everyone from the beginning. We didn't have any. So may I invite first Dr. John sir to felicitate Dr. Prabhat Prakash sir. Is he? Haan, sir, please. Sir, right. Dr. Rakesh Choudhary, sir. Dr. Sudeep Kumar, sir. Dr. Sudeep and Dr. Bhushan, sir. Bhushan, sir. Thank you, John, sir. May I next call upon Dr. VK Sinha, sir, to facilitate our next chairperson speaker, sir. Dr. Ravi Yadav, sir. Dr. Manish Kumar, sir. Dr. VK Pandey, sir. Dr. VK Pandey. Thank you, Sinha, sir. May I next call upon Dr. S.P. Gupta, sir. Please felicitate Dr. Ashutosh Agarwal, sir. Dr. Ravi. Dr. Ravi is here. Dr. Rajeev Ranjan, sir. Dr. Ashish Kumar. Sir, please. Thank you, sir. Thank you. May I next call upon Dr. Pawan? Dr. Rajiv Bhatt? Dr. Rajeev Ranjan? Dr. Bharat Bore. Dr. N.K. Singh, sir. Sir, please come. Dr. Avinash. Dr. Gurudev. Is Dr. Rajeev Ranjan around? A big clap, everyone, please. Dr. Rajeev Ranjan. So, will Dr. Manish Ranjan is here? So the surgery is going on, and in the meantime, we will break for lunch now, and we'll gather again after half an hour. Thank you.
Joshi sir.
Yes.
You are live here.
Yeah.
People are taking food at the same time watching you also.
Yeah.
Any special technique or any special tips? Whenever you want to demonstrate us, you can just say, we will be here.
It is basically, it's a very difficult area, this particular. And the tip is that the tissue is sometimes not good, and we can also use an, you have to bring that, यार इसके अंदर डालो ऐसे अच्छा इसके अंदर तुम डाल के दे दो, मैं अपने आप कर लूंगा, ऐसे डाल दो. So the only thing is that it should come at the right angle. You should test you whether your spoon should go. ये कोई कटारी फेंकनी है. लो चम्मच दो, वो पंच दो. मदद नहीं है ना इसकी. हाँ है स्कॉर्पियन. हाँ दे दो, उसमें फाइबर वायर लोड करके दे दो. फाइबर वायर शेवर दे दो. है फाइबर मोटी में. Since my tissue is not that great here, and I am going to use a, try to use a, यार शेवर देखना, तेज करना. शेवर की स्पीड बढ़ा दो. लाओ दो स्कॉर्पियन. So I'm going to use a, कौन सा है उसमें देखी बार मैंने स्कॉर्पियन वो नहीं है, मैंने इसका स्कॉर्पियन. So since it is, I'm not getting a good hold with that, biter is not holding that well, I'm trying to use it. ठीक है, ले लीजिए ना. नहीं ये वो निकाल लो, लूप नहीं बनाना है, एक धागा निकाल लो. ला दो मुझे, दो निकाल दो. हाँ मुझे दो, मुझे छोड़ दो, तुम सब कुछ छोड़ दो. निकल गया ना, ठीक. एक धागा दे दो और फिर से एक धागा. नहीं ये वाला. धागा खींचना, लूप ये वाला. हाँ जो मुझे दिख नहीं रहा. खोलेगा नहीं है. सीधा करो. हाँ प्लीज वो कंटिन्यू.
हो गया ठीक है चल ठीक है ना दैट्स फाइन हाँ लूप बन गया फ्यूचर ट्री पर दे दो मुझे हाँ सब कुछ छोड़ दो तुम ऐसे आगे दोनों भाग ठीक है नहीं नहीं एक बाइट और लेनी पड़ेगी ये वाली लेना चाहिए एक देखो ये मिलेगा ये कौन सा है हाँ ये वाली में देना हम्म, हम्म, मला ये घूम जाता है वो निकल गया
नहीं
निकल नहीं निकल गया मिनिस्कल स्कॉर्पियन नहीं है मिनिस्कल स्कॉर्पियन इज ऑलवेज वेरी गुड इंस्ट्रूमेंट हेयर में
नहीं तो वो वाला सेट कहाँ गया सर वाला
मैं इसको तो पतला स्मॉल उसकी वो होती है ना कौन सा पहले वाला अब दोनों है तुम्हारे पास खींचो मिला ना पकड़ो ठीक है और दो मिस्कल स्कॉर्पियन दो ये दो टिश्यू ही खराब है इसमें ऐसे ऐसे रखना हाँ जब जाएगा तो एक्चुअली जो हॉरिजॉन्टल टेयर भी है ना होल्ड नहीं कर रहे नो मेरे को है कि आज की डेट में द दिस इज अ वेरी बिग डिवाइस इट इज कोई भी डाल दे यार बिकॉज प्रॉब्लम विद दिस इज दैट issues के थ्रू हाथ में आ जाना टिश्यू यू नीड है यार इतना फायर करता है ना कुछ एक ही है सीधा दोनों खींच लो एक ही है दोनों ही नहीं किया उसने। हाँ, स्विच रिट्रीवर देना मेरे को। ये आदमी तुम्हें कर देते हैं। ला दे। इसको थोड़ी सी ट्रैक्शन दे के रखना ना, थोड़ा दूर से करो, है ना। जितनी बार बाइट दूंगा उतनी बार पड़ जाएगी, मैंने इसका हाथ में आ जाएगी सब कुछ। And it's parrot beak radio. I don't know. Very difficult to repair.
रिट्रीवर दीजिए, रिट्रीवर रिट्रीवर दीजिए।
यार ये निकल गया, निकल गया यार। इसको पकड़ो, इसको ऐसे, यू ऐसे ना, ऐसे पकड़ के रखना है इसको ऐसे, ठीक है, so that निकले ना ये मेरा। पकड़ा हुआ है, धागा निकल गया नहीं
लगा है सर, धागा भी नहीं निकला। ये ये सर,
मैं बताता हूँ। लूप कहाँ है?
ये वाला लूप,
ये 2-3 कैसे हो
नहीं, ये
गए?
बाहर आ जाएगा सर पूरा। हाँ, ये लूप है सर उसका।
हाँ, छोड़ो, दोनों को खींचो।
रिट्रीवर दीजिए, रिट्रीवर जल्दी दीजिए, जल्दी नहीं सर, आप घिस लीजिए और ठीक है सर।
हाँ,
चला गया
है क्या? ला,
ये दोनों
लगा दो।
नॉट पॉसिबल।
पकड़ो।
लाइट इधर कर दीजिए।
ला, देना, डालना।
लाइट फ्लैश
मेरे को तो दिखेगा नहीं। ठीक है, बैठेगी दोनों। अब काटने का कटर पे साइड से डालना है। डाल, अंदर नहीं जा रहा ना साइड से।
चला जाएगा सर। पकड़ के रखिए। पूरा में वो कुछ भी ये तो काट देगा बाहर ही।
अच्छा,
अंदर जाके
ये में जा नहीं रहा ना, मोटा है सिलेक्शन का, बहुत ज्यादा मत देना। ये जा नहीं रहा। नहीं आया।
चला जाएगा।
ऐसे ही चले जाओ, ऐसे ही कर दो। हाँ नहीं निकल गया ये। ला ऐसे ही करें। ऐसे ना मेरे धागे नॉट खराब हो जाएंगे, कट नॉट कट जाएगा मेरा। ये देख कैसे काट रहा है, पंच दे देते हो। पंच इसको धागे मेरा नॉट कट गया फिर से। तो वो कटने वाला डिवाइस नहीं है तुम्हारा, आर्थरेक्स का? हाँ और पंच ही दो इससे। ये क्या है?
पंच ही है सर, मिनी पंच।
अल्लाह फाइबर कटती भी तो नहीं है। क्या यार, लास्ट सेवर दे। बस हो गया सब। है बच्चा कुछ? प्रोब दो। बहुत इजी है लेकिन बैठ गए, इतने सारे पंचर हैं, हील कर जाएगा। चल ठीक। हमें एमसीएल भी करना है अभी। लाओ लाइट ऑन कर दो। है क्या चीज? मैंने इसका सभी भी थोड़ा हाँ वो हील कर जाएगा। लैटरल तो वैसे हील कर जाता है। The other thing is we cannot take bite. It will either we cut, then we cut so many things. Big thing. Yeah, it's a very difficult area to repair. You need to have a good knot pusher and knot cutter and everything. +1. लो पहले एमसीएल करेंगे। नाइफ दे दो। एपिकोंडाइल देखना। यहाँ भी इंजरी है, मोरल साइड ना। एमसीएल टॉन है। मतलब 20 दे दो। नहीं उसमें लोड करके दो। हाँ बिल पे लोड कर लो। टेबल थोड़ा डाउन कर दो।
टेबल डाउन करो।
ये रहा ये दिस इज एपिकोंडाइल है ना।
टेबल डाउन
लाओ वो दो स्लीव दे दे अपनी फेशियल की। नहीं स्लीव दे दे बुलेट। हाँ बस ठीक है।
बस
एक एपिकोंडाइल, ये रहा एपिकोंडाइल। ठीक है इसके जस्ट पोस्टीरियर। ठीक है सुपीरियर और मूवमेंट। पोस्टीरियर टू है एपिकोंडाइल। डायरेक्शन ऑफ द टनल सुपीरियर और इंटीरियर, जिससे मोरल में ना मिले। आ गया आ गया। ला 6 मिलीमीटर या 7 मिलीमीटर का रीमर दे दो। हाँ मोटा होगा अगर आप 7 का दे दो रीमर।
7 का दे। 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 7
फोकस है। सोने के टाइम कितना हो गया? डू फास्ट। मैंने 30 चला गया देखना। अब
25 गया है सर। 25 जा रहा है सर।
या चलो धागा दो। लूप डाल दो। प्लायर से उधर से खींच लो। प्लायर से आएगा, ऐसे नहीं। हैमर दे दो। हैमर रोको। हैमर आगे कर दो। ओहो ये मुड़ गई। हैमर रुकना, ये मुड़ गई, निकलेगी नहीं। प्लायर है, ये मुड़ गई, यहाँ टूट ना जाए अंदर। इनको सीधा करना पड़ेगा। निबलर खराब ना हो जाए, देखना। सीधा कर लो। हाँ अब हो जाएगा, देखो। इसी को पकड़ लो, हैमर कर दो। इसी से ऐसे पकड़ लो। हाँ ऐसे कर लो, ड्रिल से खींच लो। चल घूम गया। खींच लो अब, जैसा भी है। खराब हो गया। नहीं, वो प्लायर लगा के हैमर कर लो ना। वो ये निबलर लगा के हैमर कर लो पकड़ के। ये में रुकना भी मत करना। ड्रिल से मत करना, है ना। या चक लगा के ड्रिल का वो लगा के भी हैमर कर सकते हो। ला लंबी आर्टरी दे दो। सेक्शन कर लो। सीधा करना थोड़ा। ग्राफ की एज लगाओ। आ गया, आ जाएगा, पूरा आ जाएगा। छोड़ो, नहीं आएगा। टिप से पकड़ लो फिर। ठीक। हाँ लो स्क्रू दे दो। 8 का 28 दे दो। कट गया। है अब क्या करें? एक धागा और दो। ऐसी बॉन्ड दे दो, नहीं तो। ओह ले। खींचो। नहीं जाएगा, खींचो जोर से। नहीं आ जाएगा। हाँ वायर आ गई। हो गया। ला अटैच करना। केवर इधर अटैच करना, नीचे जहाँ से जा रहा है। केवर दे दो अपनी। हाँ इधर दिखाना, मुझे टनल दिखाना थोड़ा नीचे करके। लाइट दे दो थोड़ा। ला चलो ठीक है, खींचो 30 डिग्री। हाँ जोर से खींचो। गया मेरे ख्याल में। बस बस हो गया गया। ये मैं रुकना, खींचो फिर से, मैं बाहर बाहर खींचू। हाँ ठीक गया। ला इस तरह से ट्रैक्शन देके रखो, तुम भी खींच के रखो। ला स्क्रू दे दो भाई, टूटने की टाइम हो रहा है। तो वी हैव 30 डिग्री वेरस, ऐसे पड़ा है ना, तो वेरस में है और 30 डिग्री है। बेटा स्क्रू दे दो जल्दी से ना, नीचे वाला भी खोल देना, 10 का 28, ठीक है। नीचे 8 था, इसमें 8 कर दो। टूर्निकेट आधा घंटा बढ़ा देना, और अगला स्क्रू भी खोल लो, टाइम वेस्ट ना हो। ठीक है, तुमने खींचा तो ये टाइट है यहाँ से, ठीक है। कोई बात नहीं, ऐसे करो। हाँ घूम जाता है स्क्रू कई बार। आगे वायर देखना पूरी। ला छोड़ दो। ये निकल जाएगा।
निकाल सर भाई।
हाँ निकाल। ला रिट्रैक्ट। अटैच करना, दिखाना, ये दिखाना, इधर इधर दिखाना है इसको। हैं?
हाँ सब लोग ले ली।
नहीं सब लोग क्या करना है, अभी देखते हैं। ये पकड़ो।
रुक जाइए। अच्छा सर फुल टाइम।
वो देना है क्या, टैब है तुम्हारा कोई?
वो टैब सर।
हाँ दे वो टैब दो। जा नहीं रहा हार्ड है।
Joshi sir.
Yeah.
So Dr. Jaswinder this side. We'll close this session, sir. We'll go to the next session.
Yeah, if you can see, I have made an MCL if you were seeing.
Right.
And I am just fixing the ACL now. I have fixed the MCL and I will just turn this graph like this and I will stitch it onto the same just posterior to that graph. So this is how it looks like. So that was, meniscus was very friable there. So what I was not able to hold with the fiber stitch. Can you see how it looks like now? So I have stitched it using a scorpion device. I have taken one bite through medial and one bite through the
we cannot see the arthroscopy picture. We are seeing only the outside the
अंदर की picture दिखाओ। इसको पकड़ो, पूरा ऐसे पकड़ो पैर।
ज्योतिष भाई ये पकड़िए इसको। Right sir, we can see that now.
So you can see that torn meniscus there. It was very friable. So my that device was not holding. Probe दे दो. So I took a mini scorpion. So I have taken one bite through here.
Right.
If I am able to reach, because I don't want to now stretch my MCL. So I have taken one bite from here. Okay. And one from there. And I have tied the knot in between. Okay.
Right, sir.
So that's what I have done. So this happens in these tears. You can see the MCL here. I am not able to go at all now. Okay.
Right.
So drive-through sign was positive. See, I was not able to go. You know? So that's the ACL here that I am putting a screw now. Okay. And it is full extension is there. Okay.
Okay, sir. Right. Thank you, sir. So we'll cut off the live video now. We'll go to the next session, PCL session, sir. We'll start a presentation. Thank you so much, sir.
Thank you. Thank you very much.
Started, huh?
कुछ वो दो तो कार दे दो फिर ये
So we'll be starting in next 5 minutes. They have uploaded their presentations for the next session yet. Requesting everyone to do that, please. Whoever is the next speaker. So another next 5 minutes, we are starting with the next PCL session.
Battle शुरू है कोई बहुत tight है.
Meantime, sir, Deepak sir, can you hear us, sir?
Yeah, I can hear you.
So this is Dr. Manish.
Yes,
so
Dr.
you're
Manish.
fixing the MCL on the tibial side.
Yeah.
To check for the isometry.
Not because isometric is when I am putting the screw on both the sides.
Okay, sir.
Because I am using the same tendon that is not in very anatomical position, because the anatomical position around maybe 1 centimeter medial or behind that point from where I have taken the hamstrings. So I have not detached the hamstrings from the medial side. This way it saves. It's not an anatomical way the operator has described, but it works well. So sometimes in the multi-ligaments, we can't make so many tunnels in the tibia.
Right.
This is how we do. I have not detached. So you can see that this is the MCL tendon still there. So I have fixed it here. So I'll take the tendon backwards and I'll fix it somewhere here on the superficial MCL side, where around 4 centimeter below the joint line. Okay.
Right, sir. Right, sir.
Either I can do it with a swivel lock anchor, or I can just stitch it onto the fascia. Okay.
Thank you, sir.
Yeah.
Requesting everyone to please finish the lunch and join in. So the chairpersons for the next session are Dr. N.K. Singh, Dr. Pawan Kumar, and Dr. Anil Ram. Please welcome on the dais, sir. Please come here, sir.
Request everyone at the back to either come here or please don't make noise, because you'll be disturbing the speakers. Okay.
Dr. Gurudev is there. Dr. Gurudev Kumar. Dr. Gurudev Kumar. Dr. Vidya Sagar, are you ready with it?
Good afternoon, everyone. Hope you have enjoyed your lunch. So PCL injury is, this is PCL session. So I'm going to talk about the PCL case, about the PCL injury. PCL is not much common. Isolated PCL injury is not much common. It is basically 1/20th of the ACL injuries. Okay, yeah, I can see it. Usually PCL is associated with MCL injury or ACL injuries. So coming to the case, here is a gentleman of 49-year-old male presented from Northeast, having a BMI of 17.4. He met an injury in last May. Actually, he was working in sawmill and hit by a wooden log. When he came to us with the pain and the difficulty in working for 26 days. Meanwhile, from the accident of the, he consulted locally, their X-ray was done, but X-ray shows no bony injuries. Then again, he consulted another doctor, their MRI was done, and he was advised for, on the basis of MRI, he was advised for some surgical procedure. So he came to us. So on local examination, there was swelling, there was wasting of the thigh, there was posterior sagging of tibia, that is Godfrey sign was positive, and there was tenderness over the medial joint line. Posterior drawer test was positive, it was 2+, and the valgus stress test was positive. Range of motion at that time was 0 to 90 degree of flexion. So, sir is here. Bhushan sir, what is your take on range of motion? Do you think in all of your cases you want full of range of motion in before going to PCL reconstruction? At least 90. So we waited for 2 weeks. We have our physiotherapist there. So when the patient got full range of motion, then we planned for the operation. At that time, the Tegner lysom score was 47. So it was initial X-ray, and this was the X-ray after 25 days when the patient presented to us. And this was nil stress X-ray view. Sir, in all of cases, Bhushan sir, in all of cases, you used to do nil stress X-ray view. Is it necessary? Oh, okay, we have done that. And here is the MRI. You can see here the PCL injury and ACL is found to be intact. So after consent, the patient was taken to OT, epidural anesthesia was given, and you can see the posterior drawer test was positive. So arthroscopic inspection of the knee joint was done, and PCL was found to be torn. Then graft harvesting was done. So another question, sir, regarding that, the graft harvesting, what is your take on graft, sir? Do you take always semi-tendinous, or you can also prefer peroneus grafts? Sir, in our case, we have taken peroneus graft and semi-T also, and graft thickness was 10 mm and length was around 14 mm. So then debridement of PCL and this was done. Then tibial tunnel preparation was done. We kept our PCL jig at 15 centimeter from the joint line, so that we have sufficient amount of bone there. Then femoral tunnel preparation was done. That was, you can see here the guide wire passing through the PCL remnants, and then passing of the graft and fixation was done. Sir, another question regarding this, sir. What is your take on killer turn? How do you prevent the graft passing through the killer turn? Ashish sir, would you like to comment, like killer turn, how to prevent this graft passage, graft passing through killer turn, how to prevent it?
You can pass from above to downwards. That's the easiest way of avoiding killer turn. If you are passing from down up, then you cannot avoid, but you can manage by putting a Bissinger rod or something like that from the posterior medial side and directing your pull of thread accordingly, posteriorly. So that you can do. These are the two ways of doing that I know.
Okay, sir. So, sir, we have taken SS wire and to and from motion of SS wire, so sometimes smoothen this. So after graft passing and fixation was done, so here is the final video of the fixation. So regarding post-op rehabilitation, we applied knee brace with bump below the calf muscle. And here's the post-op X-ray. In the during interop, when the fixation was done, we found there was some laxity, so we have used this screws. Here is the post-op. Here is the post-op X-ray and 8-month follow-up. The patient was walking comfortably. So coming to operative management of PCL injuries, here few literatures we have taken. This literature was published by Water and all last two years back. Actually, this was meta-analysis, and there was 6,000 of arthroscopic knee was included in this particular study, and he found both the treatment conservative versus operative, both yielded satisfying functional outcome, but the osteoarthritis has occurred less frequently following PCL reconstruction. Another study was done by Zemi et al. That is isolated posterior crystal ligament injury, and he concluded that majority of isolated PCL injuries can be treated non-operatively with rehabilitation. So the take-home message is, if there is grade 1 and grade 2 injury less than 10 mm of injury, less than 10 mm of laxity, then we can go for conservative treatment. And if it is grade 3, more than 10 mm of posterior laxity, may go for conservative, but instability, then we should reconstruct. Thank you, sir.
Any questions?
So with this conclusion, do we feel that it is okay? For me, PCL is very, very disabling. It is not like that it can be treated conservatively because quadriceps is taking care of your PCL. That we think. But somebody who is having a real posterior sag or anything that posterior laxity is there, I don't believe that PCL, of course, it needs more strong reconstruction and more slow rehabilitation. That's okay. But just saying that even grade 3 can be treated isolated with only your conservative means I'm not believer of that. What about others?
Okay, if there is instability, high level of instability, then surgery.
What is high level of instability? Some patient is having a lot of trouble. Once he is having a PCL injury, maybe it is isolated. But if it is a significant PCL injury, there is a reasonable trouble they walk with. They can better live with the ACL. It is just when they are having that pivoting or once they have uneven surface and then they have problem. But with PCL, it's every step is difficult for them. If there is this grade 3 is a big thing. And what about grade 1, grade 2? Even if you reconstruct, you may at the end you can land up with grade 1 and grade 2. So that is why for grade 1 and grade 2, one should not go for it. But if it is grade 3, then definitely one has to do. There's no need to go for any paper or something like that, or anybody who has said that you can do conservative. It's not like that.
Agreed, sir.
Yeah, fully agree, sir. Grade 3 isolated, you need to reconstruct.
Dr. Vidya Sagar, what was your rehabilitation protocol?
Sir, it was your patient was kept in range of ROM brace, and there was bump in the below the calf muscle, and quadriceps exercise was initiated after next day.
And one more thing, there had been associated other ligament injury like ACL. What graft you would have preferred for the PCL?
Sir, I used to take peroneus graft and semitendinous.
As such one you will say, or something else? Peroneus.
Peroneus longus and semitendinous, yes. Yes, sir, in prone position.
Exactly. Right.
Sir.
Patient will have lateral laxity. So that is very important. You should start range of motion in prone position, not in supine position, as we routinely do in our ACL cases, other ligament reconstruction. So PCL, PLC always try to gain the whole range of motion in prone position.
Thank you, sir.
Thank you, Dr. Vidya Sagar. Gurudev, are you ready? Yes, next speaker is Dr. Gurudev Kumar.
Respected Chairperson, my topic of presentation is arthroscopic PCL avulsion fixation. So the posterior cruciate ligament, it is the main static stabilizer of the knee joint. It prevents the posterior translation of the tibia. It acts as a secondary restraint to the external rotation of the knee joint. Commonly, it is a part of multi-ligament knee injury due to road traffic accident, mostly in our country and in the entire Asia, because the main mode of transportation here is the two-wheeler vehicle. Then the second common mode of injury is the sports activity. The incidence varies between 1 to 44% among all the knee ligament injury. So the diagnosis is most important. Take the proper history from the patient, clinical examination like joint line tenderness, anterior drawer, posterior drawer, PARAS and valgus stress test at 0 and 30 degree of flexion, and dial test. Here there is the posterior sag sign seen in this picture. It indicates there is the PCL injury. And of course, the radiological examination, X-ray, 3D CT, and the MRI to see the status, know the status of the ligament, cartilage, OCD, like that. The studies show that if there is partial tear, then there is less than 8 millimeter increased posterior tibial translation. Isolated complete PCL tear, there is 8 to 12 millimeter of the posterior tibial translation, and combined posterior cruciate along with PLC injury, there is more than 12 millimeter of the posterior translation of the tibia. This is the classification of the PCL avulsion. The type 1, which is minimally displaced or undisplaced. Type 2 is the minimally displaced, and it is visible in the X-ray also. And that a type 3, it's the complete displacement of the tibial spine. There is debate whether to conservative treatment or the operative treatment. So the many studies shows that if there is tibial spine avulsion, it should be fixed. There is no any role of conservative treatment for the tibial spine avulsion. So this is the X-ray of the 32 years old male following road traffic accident, left knee injury. In the X-ray, we can see there is a classical PCL avulsion from the tibial side. And this is the posterior drawer. The tibia is translating posteriorly, and PARAS and valgus stress test, it's okay, it's a negative. This is the 3D CT. We can see here there is a big chunk of the posterior tibial spine avulsion. There is minimal comminution or no comminution, and in the MRI, you can confirm there is the posterior tibial spine avulsion. The rest of the structural cartilage, ACL, meniscus, that everything is normal other than the PCL avulsion. So coming to the treatment of this avulsion, there are various methods of the treatment. Once the diagnosis is confirmed, initially in our beginning part of the career, we are going to fix it with the Lowenhofer approach, posterior reverse L-shaped incision, and fix it with either 1 screw, 2 screw, or maybe 3 screw. We can see here that this is a big fragment, and we have operated with a 3 screw, then a screw with the washer, and a small DCP, then manipulated or the molded 1/3 tubular plate, and lastly there is the tightrope fixation of this PCL avulse fragment. So coming to the quick procedure, we can see here how to fix it. So mark all the bony prominence or the mark with the marker pen, lateral fibular head, lateral joint line, medial joint line, patella, tibial tuberosity, and medial, standard medial and a lateral portal, and the posteromedial portal. So this is the case of the PCL avulsion. Put the scope through the standard anterolateral portal, and then evacuate the hematoma with the thorough joint lavage. We can see here, this is the slopey ACL, lax ACL. ACL is intact, but it is lax because of the PCL avulsion. Then create the space between ACL and the PCL by removing the fat pad and the synovium. Then introduce the scope through this in the posterior joint. Then create the posteromedial portal with the help of 18 gauge needle. By switching the light inside the theater, we can help the to introduce the needle. Then use the 11 number knife. The knife is tied with the thread over the BP handle so that we cannot miss the blade in. Then a straight artery to dilate it. Then pass the 8.5 mm cannula with the trocar. Then pass the saber through this posteromedial porter and debride all the hematoma, fat pad, bone debris, and create the proper space between the PCL and the posterior joint line so that we can do the better instrumentation. Then quantify and identify the size of the fragment of the avulse piece, whether it is single comminuted, it is a little bit comminuted here, and try to reduce with the help of examination probe. It is nicely reduced here. Then with the help of suture lasso to pass through the enteromedial portal, pass it at the junction of bony fragment and the PCL, and then loaded with the PDS suture. Then the suture is loaded with the fiber tape, and you do the clinch suture stitch over that avulse fragment. Then took another bite through the encircling the PCL and the bony fragment at the junction. Then pass the PCL jig, which is exactly 15 to 20 meter below from the joint line. We can see here between the medial and the lateral side of the gutter. Then pass the bead pin. Then drill over the bead pin with the 4 mm of the cannulated femur. Then pass the bead pin loaded with the suture thread. Then retrieve it through the enteromedial portal. Then loaded all the thread over this lip and pass it through the anterior aspect of the tibia with the help of this probe. Try to reduce it by pulling and pushing. It is a good to see here. It is perfectly reduced and with the proper tension. Now the slope sign is wind off. The ACL looks stable now, and the PCL is stable. This is the immediate intraoperative examination, which can show that the knee is quite stable, and fix it over the anterior aspect of the tibia with the help of suture disc in 90 degree of flexion. And this is the post-operative picture. Immediately from the theater, we can check whether the fragment is nicely reduced or not. And this is the post-op X-ray. We can see here it is a perfectly beautiful reduction of the fracture fragment. And this is the post-operative picture. He's a sportsman, and this is after 10 months of this of surgery, and he's happy. He's a big businessman son from Patna. Thank you.
Hello. Any question to Dr. Gurudev? Please.
Arthroscopic PCL reconstruction is always a technique which has to be learned. The fixation can be done, the avulsion, by means of a small incision by Buck-Schaeffer's approach. And that takes around 15 to 20 minutes of time. This, of course, takes around 1.5 hours. So how many of us would like to do it by open method, and how many would like to do it by a arthroscopic method?
Suppose a surgeon, orthopedic surgeon, is not an orthopedic surgeon, arthroscopic surgeon. He is a general orthopedic surgeon. He does not arthroscopy, or he has not got the facility of arthroscope. So, do you recommend by the open method?
Sir, we have already.
One more thing.
Sir, Sir, we have already shown here in the various method of fixation. There is one X-ray. We can shown here. There is a very large piece of the avulse fragment. After confirming with the MRI examination, we did the fixation with the open method by applying 3 CCA screw.
That's why I'm asking. Even by the open method, the results are quite good. And your topic was basically avulsion PCL. Okay?
Sir, the ultimate result after 2 years is the equivalent. There is no any difference.
Right.
But there is certain indication whether we have to go for arthroscopic method or for open method.
Yes.
If the fragment is too much comminuted, then in that situation, it is better to go for arthroscopic method.
So that is the criteria. Otherwise, you can go by the opens. If it is not an ortho-
Again, this is a learning curve. There is always chance of the vessel. It's very horrible and terrific surgery. I have faced certain times inside the theater. I think I have already injured the artery, but luck, it doesn't happen till now.
We have done few cases. I have done personally. I have done few cases. 3 to 4 cases I have done by open method. That's why I'm asking. Anyway, good.
There are some
presentation.
specific indication for open method. If you are doing a tibial plateau fracture with PCL avulsion, try to do it open, because anyhow you have to open the posterior joint line. If you are planning for tibial plateau fixation with PCL avulsion, if you have a very large fragment, it's very difficult to negotiate that fragment arthroscopically. Sometimes the chunk is very big. If you have a very big fragment which is taking a part of the posterior tibial articular part cartilage also, try to fix it open. And arthroscopic open reconstruction results are equally good. The only good thing with arthroscopic fixation is that you can rehab this patient early, because minimum soft tissue trauma is there.
See, Manab, it's not a fair question to him. Okay. If when the nailing started, people were taking 2-3 hours to nail. It's not that we stopped nailing. We kept on learning and we improvised. So it's not a fair question to say that the something can be done in 15 minutes while you're taking 1 hour. There are a lot of things. Bergsteifer approach. There is a huge amount of skin problem. Okay, it's not easy. Those who have done 50, they will understand that the skin necrosis happens, skin giveaway happens. Arthroscopically, these things will not happen. Okay, so of course it's a learning curve. And if you do it, you should do it this way. There is no doubt in that. Okay.
And another thing, we can address the other pathology also. So the meniscus injury, OCD lesion, and other intra-articular. At the same time, we can address all these things also.
Yeah, and I think I agree with what Rajiv says. It sometimes depends on the size of the fragment, and but I don't see major skin problems with the Birch-Cave approach. Yeah, but no.
Now, may I call upon
Even for screws, you don't need to remove them.
Okay.
Thank you, sir.
Yes, Dr. Gurudev, thank you very much for your nice presentation. Now, may I call upon the expert for his lecture on the PCL reconstruction arthroscopically.
Thank you, Chairperson. So very nice talk about Gurudev, and I think PCL, it was a PCL repair technique, avulsion. So I will be talking on PCL reconstruction. So it's a small video technique. So whenever your patient comes with a PCL injury, what we were discussing in the morning, as Ashish sir told, if it's a grade 3 PCL injury, if you have posterior translation of the tibia more than 10 millimeter in the lateral view in 90 degree of flexion, don't go for conservative treatment. Why? Most of these patients don't come with the instability. They will come with patellofemoral arthritis in due course of time. It is the patellofemoral joint which gets burned out when you don't repair or reconstruct with PCL. So nowadays, if the patient has grade 3 instability, try to repair or reconstruct it. Don't leave it like as we were doing 15-20 years back. The PCL heals very well. It's vascular, it heals very well, but it heals with lengthening, and that causes the laxity of the posterior joint line. So this is a small video technique of arthroscopic PCL reconstruction. And as you know, once you put your scope inside, there's a telltale sign that is a slopy ACL, or which we call S-shaped ACL or SAG ACL. And this lax ACL sign is a telltale sign of PCL injury, because you will not see an empty fossa sign as we see in our ACL reconstruction. You see an empty fossa sign. You see that the whole of the medial part of the lateral femoral condyle, the ligament is not there. But PCL injury, what happens? Because it has a very good vascular sleeve, it heals very well. It's the laxity which causes the problem. So slopy ACL sign with positive posterior test is a clean-cut indication for arthroscopic PCL reconstruction. So once you have seen this slopey ACL, the next important part is you should make your way for the posterior medial compartment. And this is very important. Sometimes you have to debride part of the PCL to make your way to the posterior medial compartment. Here you can see, once you have debrided it on the medial aspect of the lateral femoral condyle, lateral aspect of medial femoral condyle, you are in the posterior medial compartment. And this is very important step, making of your posterior medial portal, because that is the way through which you will see the posterior compartment and avoid neurovascular injury. The best instrument is your needle. Put your spinal needle in. Over that, guide your 11 number blade so that you can make a good posterior medial portal. In PCL avulsion, normally we make 2 portal. In PCL reconstruction, single portal is good enough. Once you made your posterior portal, the second important part is pass your switching rod over that. And once you have passed your switching rod, try to pass your cannula. Normally we use 8 millimeter cannula. You can see the plastic cannula is coming in. And once it has been done, you can see, you can visualize whole of the posterior part of the tibia. Now start saving the posterior aspect of the tibia, the PCL footprint. And this is very important. Don't use your save suction system and try to keep your blade toward the tibial plateau, because posteriorly you have neurovascular bundle, and try to save down till you see the red bundle of fibers of the popliteus. That is the end point of your saving. You can see your shaver blade should be towards the tibial side. Once you have saved it, the next important part is putting your PCL jig. So how much down? And there is a question and debate for that. Normally, you should go 15 to 20 millimeter below the joint line. This is the standard practice because PCL is not attached over the posterior border of the tibia. It has an attachment at least 15 to 20 centimeter below the joint line. And if you go down 15 to 20 millimeter, sorry, not centimeter, so it will give a good posterior support to the tibia. So try to be at least 15 to 20 millimeter down the posterior tibial joint line. So here you can see when you put your PCL jig, there's a marking there of the PCL jig, 5, 10, 15. So try to keep the 15 millimeter mark over the posterior tibial joint line. And you can see here, this is the PCL jig, and just where I will rotate, you will see the 15 millimeter mark is there over the joint line. And now my tibial tunnel will be 15 millimeter below the joint line. Once you have put your PCL jig there, fire your beath pin with direct visualization. And at this time, I am visualizing to the posterior medial portal. In this creation of the tibial tunnel, always do it under direct visualization, because you are very close, 15 to 20 millimeter close to the neurovascular bundle. Once you have fired your beath pin over that, put your reamer on. Suppose your graft is 9, try to put your 9 millimeter reamer. You can go for sequential reaming or reaming also. Here you can see, through the posterior medial portal, I am viewing it. I have fired my beath pin 15 millimeter below the joint line. Over that, I am making my tibial tunnel. It's around 9 millimeter tibial tunnel. So once you have made the tibial tunnel, you can see once you are close to the posterior cortex, gradually your beath pin will go inside. So be slow there. Sometimes ask your assistant to ream with the hand only at the posterior cortex. And once you make your posterior tibial tunnel, try to pass your suture lasso in the posterior part. Here you can see, now we have passed the suture lasso from the tibia in the posterior parts of the tunnel. You can see here. So over the beath pin, you have passed the suture to the tibial tunnel. Now take the suture either with the suture manipulator or a probe and park it in the posterior medial portal. Now you can see with the grasper, you hold this one and park in the posterior medial portal. And now your posterior tibial tunnel preparation is complete. Once you have completed your tibial tunnel preparation, you have passed the suture loop. Now you make your femoral tunnel. And this is also very important to be anatomical. Try to be 8 to 9 millimeter away from the subchondral bone. And it's towards the roof. So if you draw a vertical line through the central part of the trochlear notch, and it's between 11 to 1 o'clock position. This is the position for the PCL. So for ACL, you are posterior and down, and for the PCL, you are anterior and up. And this is important. So, and you should be at least 8 to 9 millimeter away from the subchondral. Here you can see the marking is there 5, 6, 7, 8. So I am 8 millimeter away from the articular cartilage. So now put your femoral jig and try to fire a beath pin from outside in technique. Here you can see I am firing my beath pin by the outside in technique, and that will come to the center of your femoral jig. So once you have fired your beath pin, now you make your tunnel again by outside in technique. You can see, and try to protect it with the curate so that you are not damaging your ACL or the subchondral bone. And this is the most important part of making of your femoral tunnel. So you have made your tibial tunnel, now you have made your femoral tunnel, and you can see when you are close to the medial cortex, be very gentle. And now this suture lasso, which is there through the tibial tunnel, try to pass it to the femoral tunnel. So you can see the suture lasso is crossing the tibial tunnel. Now it's coming towards the femoral tunnel, and take it through the femoral tunnel. And over the suture lasso, you will pass your graft. So one question someone asked at that time, how to prevent the killer tunnel? This is, sorry. So how to prevent this killer tunnel? The best way is that if you want to pass the graft through the tibia, then femur, pass your switching rod. You can see this is the switching rod, and try to pass the suture lasso so that your graft will go posteriorly and that will go up. So you can avoid the extra force which you have to put when you are pulling it directly. And now gradually try to pull the graft towards the femoral tunnel. Before your graft enters the femoral tunnel, pass your bead pin or guide wire in, and try to put it anteriorly and superiorly so that you can hold it with an artery forceps in that position. And this time you should be patient enough, because what happens, your graft is coming from the posterior aspect of the tibia, it's going up. So it takes some time to pull the graft toward the femoral tunnel. Normally we put 15 to 20 millimeter of the 20 to 25 millimeter of the graft inside the femoral tunnel. Your tibial tunnel is around 40 to 45 millimeter, and try to hold the guide wire with the mosquito forceps over the anterior and the superior part. And gradually as you pass it, you can see your graft is going inside the femoral tunnel. So it's coming from the tibial tunnel and going toward the femoral tunnel. And gradually you can see the mark is there. You can mark it at the 20 millimeter and your graft is inside. At this time, now first in PCL, normally we go for a femoral fixation first. So you can see the guide wire is there. Over that, through outside in technique, I will put my screw, aperture fixation. For femur, the standard rule is 8 millimeter graft, 8 screw, 9 millimeter graft, 9 screw. Sometimes you have to use an under screw also, because the femoral bone is cortical thickness, or cortex is more dense than your tibial cortex. So in tibia, normally we go one size up or two size up. For femur, it's the same size or the under size. And the most important part is that when you were going for fixation of this, try to palpate the tip of the screw through your probe, because that is very important. It should be a bicortical fixation. It should be the inner part of the thread you should be visualized. And now you can see your femoral fixation is done. And once you pull your graft anteriorly, you can see when you are pulling your graft anteriorly, the laxity in the ACL is going away. And that proves that yes, your fixation is, your tensioning in the PCL is good. Now try to fix your graft in the tibial tunnel, in the tibial side, to the aperture fixation in 90 degree of flexion. Your assistant giving an anterior draw, because your tibia is subluxed posteriorly, to try to give the anterior. And this is very important. Visualization of the graft through the posterior medial portal. You can see your graft should go at least 15 to 20 millimeter down the posterior tibial joint line, and that gives your posterior support. That is very important. So if it is 5 or 10 millimeter, your posterior support will be 5 or 10 millimeter only. So try to be at least 2 centimeter below the joint line, so that you have good posterior tibial support. And once you have seen it, visualize the graft from the posterior medial portal, and you switch over the scope to the anterolateral portal, you will see that laxity in the ACL has gone, and this is very important. Regarding rehab, two things is important. First, try to rehab this patient in prone position. Second important point is that try to keep them non-weight bearing for 6 weeks. And the third important point is that always try to use the posterior tibial support brace. Normally PTS brace is very costly. So what we do, we use indigenous extension knee brace. We try to put a small spongy cotton over the calf, and tighten the femoral belt and the central tibial knee strap, but keep the tibial or strap loose, so that your pressure is not coming over the anterior aspect of the tibia, and that the whole of the tibia is not sagging posteriorly. And that is the indigenous method by which a normal extension knee brace can be used as a posterior tibial support brace. Thank you.
So,
see, if you are passing your graft from tibia to the femur, you are concerned about the killer tunnel. If nowadays lots of people are passing their graft first from the femur, then to the tibia, then you don't have to take concern of the killer tunnel. Anytime. If you are comfortable, you can do it. It's not a big deal. But what the problem is that when you are making your femoral tunnel to inside out, you have to drill it through the anteromedial portal. And the chances of, if you are not doing it in adequate flexion, chances of denuding of the cartilage from the anterior aspect of the femoral condyle, the lateral femoral condyle is always there. So always do it under direct visualization.
Yes, regarding your question, Avinash, I usually do the PCL probe inside out all the time. In that situation, we have to be conscious before proceeding your procedure whether we are going to doing inside out or outside in, because there are two portals on the lateral side. So in that situation, we have to make lateral portal a little bit higher up, and another portal goes with the help of needle where you are going to hit on that side, the lowermost, that it is inside portal for the PCL.
So one is problem is inside out, the tunnel goes slightly more posteriorly outside.
Yes.
Oblique. That's the problem with inside.
Suppose see, now people are shifted the femoral fixation from aperture to loop fixation. So if you are planning for loop fixation, I think inside out tunnel is good, because you will build your fire your pitch bit, over that you fire your 4 mm calibrated drill bit, you measure your tunnel and you can use your desired loop. But if you are planning for aperture fixation, I think outside it is good.
So what is your take on loop button versus screw fixation?
So see, button, the only thing is that for ACL, button has been standardized. It's a standard because lateral femoral cortex is thicker. If you see the X-ray of the femur, lateral femoral cortex is thicker. Medial femoral cortex is thin. So you should be at least have 10 to 12 mm of medial femoral cortex there. Otherwise, if you are having 6 or 7 mm of the medial femoral cortex, like you accept in ACL, there is always chances of breakage of the cortex.
And so there is a lot of patients who come with impingement on the medial side of the button. Is that also an issue?
Yes, and because see, the lateral side you have a iliotibial band, you have the thick iliotibial band, you have vastus. Medial side you don't have. You are just over just below the vastus medialis. Your button is there, so that causes impingement also.
What is your take on both these?
Normally I prefer aperture fixation on the femoral side and aperture fixation on the tibial side. But for PCL, I always prefer a supplementary fixation with a post over the tibial side.
Dr. Rajeev, nice paper. Till this time, we have covered meniscal injury, ACL injury, and PCL injury. So, in multi-ligament complex, what is your protocol of doing the different ligament injuries?
So, normally, multi-ligament, I think this session will be there. So, PCL, PLC, MCL, ACL. So, always try to centralize your knee first. Go for a PCL reconstruction, either it's a PCL repair or a reconstruction, go for PCL. Then plan your collateral, posterolateral, medial collateral. And in most of the cases, I leave the ACL like that, because what happens when you rehab this patient, because of the multi-ligament injury, sometimes there is stiffness and then you don't need ACL, will not need ACL reconstruction near future. So if you have full ligament injury and try to repair 3, you can leave the ACL for second stage.
Okay.
So we'll close this session now, because Dr. Arvind will take another 15 to 20 minutes to start the next surgery. So we'll move to the next session, that is knee collateral section. So the moderator for the session is Dr. Avinash, and the chairpersons, please come upon dais, Dr. Rajeev Ranjan sir, Dr. Madhusudan sir, Dr. Ashish, and Dr. Ramaka. Next.
Good afternoon. So we are now going to start our knee collateral session. And first case presentation is by Dr. Abhishek Das. He will be talking on MCL here. Dr. Abhishek.
So just an announcement in between. So if when Dr. Arvind starts the surgery, we might break for in between the session.
Okay.
Good afternoon, everybody. Hope everybody had a nice lunch, and my case presentations will not let people snooze over. I cannot guarantee that, though. I have got two cases because MCL, there is a bit of a debate as to what to do when it is isolated, what to do when it is as a part of multiligamentous complex. So for the first part, while the audio visuals are working,
Audiovisual guys, please see this.
In the meantime, can we move on to the next presentation, Dr. Abhishek, and we'll sort out the things with this. So,
Okay, so can I call Dr. Sudeep Datta for posterolateral corner injury, PLC?
Hello, check. Hello.
So thank you, chairpersons and the organizer for giving me this opportunity. So I will talking on the posterolateral corner of the knee injury. So it was called as a dark side of the knee because the anatomy and the pathophysiology of this side is always a debate, and there are a lot of surgeries, what to do, when to do, or not to do. So I'll give a just brief discussion about the understanding so that we get a clear idea as of now. So the two most common cause of failure in ACL or PCL is, one is malalignment, which will be taken care by the next session, and another is missed posterolateral corner injury. So whenever we go for surgery for a cruciate ACL or PCL, so we must take care of these two. That is, your alignment, knee alignment is maintained. Another, you are not missing any corner injuries. That is your medial collateral or most commonly the posterolateral injuries. So what is posterolateral corner? It consists of mainly three ligaments. One is fibular collateral ligament, another popliteus, and the popliteofibular ligament. So the clinical examination, the two tests you have to do whether you are going for a cruciate reconstruction. One is dial test in the prone position. See if the rotation is more than 15 to 20 degree compared to the normal side, that you are dealing with a collateral, posterolateral corner injury. Another is the Vera stress test that indicates the lateral collateral injury. So the another sign, when you put your scope in, if you see your lateral meniscus very easily, which we call it's a drive through shine, that indicates that there is a posterolateral corner injury there. So there are two type of repair as we do. One is Larson repair, that is if you have a positive Vera stress test and your dial test is negative, then you have to only reconstruct your lateral collateral ligament. That is a small video of this. There is it's always an open surgery. That is, you just put your scope in, you diagnose it, and then open it. So you give a incision over the lateral aspect of your knee, and you raise the posterior breast flap. The most important structure there is your common peroneal nerve, you always have to identify and protect the nerve throughout. Go and identify your nerve. And that is your common peroneal nerve. You have to protect and identify this nerve. And now we identify the fibular head. So this is your fibular head. You just make sure you have to make a drill through your fibula from anteromedial to posterolateral. And that is you are confirming the movement of the tibiofibular joint. And now you are going for a drill. And the graft, most commonly you can use your semi-T graft, or you can use peroneus longus graft, or you can use opposite side semitendinous graft there. First, this Larsen repair. So that is your drill going in. And you have to always protect on the posterior side, and then you put your suture lasso through your fibula. But always be very careful, because in a small fibula you are not fractured your fibula. Now you go for the femoral tunnel. You have to identify your lateral femoral epicondyle, and just taking your 4 mm drill bit or a sleeve like, identify that point, and over the drill bit you just make a drill, making a tunnel there. If you have done a ACL reconstruction, you have to be careful that your two tunnels should not diverge. And at that time, if you have any confusion, go and put your scope in, see that it is not hitting your ACL tunnel. Then you pass your suture lasso in. Now that it's very simple, you have to pass your graft from the fibula to the femur under the soft tissue coverage. And now that is passed over into the fibula, and now you draw your graft through the femur. And before passing the graft, you always put your guide wire, because after graft goes in, it's difficult to find the tunnel for your screw. Now your graft goes in. And next step is very simple. You just, in extension, you just tighten your graft and fix it with a standard bias screw or whatever screw implant you are comfortable with. So then you can always check the stability by putting the stress test operatively. The next is if you have a positive dial test and a Vera stress test, then this procedure is not enough. There are different ways of doing it. Laprade has described it. So this is an example of a positive dial test. See, this is a patient having a positive dial test, and also the significant positive rotation and the Vera stress test. He has a failed ACL reconstruction. He has ACL reconstruction done, was failed because of missed collateral injury. So incision is very much same. We have used the quadriceps tendon graft in this case, and split it into two parts. First is the posterior base flap is raised as in the previous case, and this is the incision. Then you once again, then you have to first thing you have to identify your common peroneal nerve. You have to protect this nerve throughout your procedure so that you can not injure this nerve. Sorry. Then you incise about in the level of the femoral condyle, and then identify the epicondyle there. This case I have used only one tunnel. The Laprade has classically developed described using 2 tunnels because there was I have to do ACL reconstruction. So 3 tunnel in a lateral femoral condyle is very difficult to manage. So we are planning for a 1 tunnel in the tibia, 1 tunnel in the fibula, and 1 tunnel in the femur. So this is the fibula tunnel. So we are going from anteromedial to the posterolateral, protecting the nerve there, and so keeping a suture lasso in the tunnel of the fibula tunnel. Next, the tibial tunnel. Tibial tunnel is just lateral to the Gardis tubercle from anteromedial to posterolateral, and during drilling, you have to always protect in the posterior side to avoid the injury to your vessels. And then you pass a suture lasso in the tunnel. Next thing, you have to identify your lateral epicondyle. So I just there are different description there. This case I have used only 1 tunnel, that is just posterior and proximal to the lateral epicondyle. I have drilled the femoral tunnel from slightly posterior to anterior to prevent convergence of the tunnel with the ACL tunnel, and past a suture lasso. This is your graft goes in. The central quadriceps tendon has been split into 2 parts. Then you have 20 mm. We have marked 20 mm graft that goes into the femoral tunnel and split the graft into 2 parts. Then we fix the femoral tunnel with a screw. And then first we pass the graft to the fibula from anterior to posterior. And then pass both the limbs of the graft from posterior to anterior into the tibia. So now we fix the graft with a screw in a 60 degrees of knee flexion, and that will complete our reconstruction of the lateral collateral popliteus. And then this is the power of stability of the. So this is the closure of the window. And that's so at this junction, I like to invite you all to knee, shoulder, not only knee, the shoulder course in Kolkata in June 3rd. So thank you all.
Nice illustration, Dr. Soumyadeep. So any questions before we start the live surgery?
Yes, Dr. Datta, I think in both the techniques, the Larson's as well as the modified Laprade, which you have shown, the tunnel in the fibular head is from anterolateral to posteromedial. But in both the cases, you have shown from anteromedial to posterolateral. Anterolateral to posteromedial. The tunnel should be in the fibular head. But in both the cases...
But you need to be fibular head, you anterolateral to
posteromedial.
But you have to go from... I'm like this. I'm going from anterolateral to posteromedial.
Posteromedial.
Yeah. So, sorry. I'm sorry. Yeah. It should be because you have to see the tunnel. Otherwise, you will injure the nerve.
One question. Is there any place for modified Larson technique? Put a screw in the fibula head.
Fibula head?
Yes.
So I think in an Indian scenario, putting a fibula head screw, I think it's very difficult until you have get a patient like my stature regularly.
No, I think it is better to put a screw.
I mean, the head size is small, so.
I don't think I have never put a screw in the fibula. I think anybody in the hall have
yes. I think it's better to put a screw because when you don't put a screw, there's always a play in the tunnel. So if the play in the tunnel is there, that can lead to a disturbance of the graft.
So
You can do some stitches there. If you are,
I think the best thing is kind of avoid is put some soft tissue stitches,
You can do
graft
some stitches
over
on
there,
the-
so that will avoid playing at the tunnel. There will be fibrosis there, and the graft playing will be less. The only issue we have with this fibula screw fixation, minimum screw size is 6 millimeter or 7 millimeter. So that is too much for our Indian fibula. Chances of fractures are always there.
No. So femoral tunnel. So there are in Lapra there are two tunnels classically. One is over the lateral epicondyle. Another is around 20 millimeter proximal and posterior. One for popliteus, one for lateral collateral. So the only concern is the convergence of the tunnel. Two tunnels. If you are doing an isolated posterolateral or with a PCL, in an ACL, the three tunnels, I think it's very difficult to manage. So only concern is that these tunnels are not coinciding. That may cause the damage. So you can put your scope in after doing the tunnel so that you are not hitting your ACL tunnel.
So we are live with the surgery from Dr. Arvind, and I request the chairpersons to be seated here only. And at the same time, the moderators for the last surgery, Dr. Anup and Dr. Sudeep, please join us. And over to Dr. Arvind. Can you listen to me?
Yeah, your voice is very clear. Am I audible there?
Yes, sir.
So this is a case of 36-year male having injury to the right knee, 3 weeks back only.
Can we see the MRI, please, for a second?
Yeah, first I'll demonstrate the clinical, then we'll go to the MRI side. So this was the range of motion at 3 weeks. And if you can appreciate, particularly for the PGs and the senior resident, you can see the tibia is subluxated posteriorly. At the same time, side se le sakte ho, side se le lo. The posterior sag test is positive in this case.
Yes, it's clearly visible, Arvind.
Yeah. And the posterior door test, you can see almost more than a centimeter of translation is there.
Yes.
Anteriorly, it's not coming more than this, but little bit anterior excursion is there. At the same time, valgus test at 30 degree, there is opening. Can you see it? There is opening on the medial side. Is it visible?
Yes, there is some.
Perfect. But at 0 degree,
too much.
but at 0 degree, valgus stress is not much positive. Hardly 5 millimeter of opening is there. This is at 0 degree and this is at 30 degree. Okay.
Yes.
Now we'll see the MRI. MRI to focus.
What is Dial's test in this?
Yeah, dial test at 30 degree. Ideally, it should be compared to the opposite side. You can see 30 degree, hardly 20 degree of movement is there. External rotation.
Visible. The foot
and at 90 degree, you can see this external rotation is quite high. This is at 30 degree and this is at 90 degree. Okay.
Visible. Okay. The cameraman can zoom out a little bit, so it will be more.
Yahan kar lo beta.
Foot.
So this is the dial test as 30 degree of knee flexion. You can see the ideally it should be compared to the opposite side. And this is at the 90 degree. 90 degree, this external rotation get increased.
Cameraman, please zoom out. Zoom out. You have zoomed in. Yeah. The knee and ankle both should be visible. That's better.
This is at 90 degree, this much of external rotation. And this is at 30 degree. At 30 degree, hardly 20 degree of the external rotation is there. But at 90 degree, it is high.
Okay.
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 So next on the MRI side, sorry. So this is the sagittal section. Ek artery de do koi. If you appreciate the PCL here, the intensity is increased. At the same time, diameter is also increased. So femoral side, it looks torn, but at the same time, there is increased intensity on the ACL also.
Inside also. Yeah.
Yeah. On the coronal section, you can see very thick origin of the MCL is evolved from the femoral epicondyle. Can you appreciate?
Yes, it's
So it is the MCL avulsion, at the same time PCL complete tear with increased signal intensity in the ACL. So
how old is the injury?
3 weeks.
3 weeks. Okay.
So our diagnosis, primary diagnosis is PCL.
Age of the patient?
36.
36. Okay.
So our primary diagnosis is complete PCL tear with MCL avulsion from
cameraman, Arvind, just the glare is too much. If the cameraman can decrease the glare, otherwise the visibility is okay.
थोड़ा लाइट भी कम कर दो.
नहीं
कैमरा इधर से लेके आओ.
सिस्टम में होता है ग्लेयर कम करने का.
हाँ साइड कर दो बेटा, इतना लाइट नहीं है. तुम कैमरा लेके इधर आ जाओ. And some SRs asked me to demonstrate the graft harvesting also. So I am starting with the graft harvesting.
What graft you have chosen?
Yeah. Plan is to reconstruct the PCL with the semi-T and gracilis. Okay. And the MCL will be repaired because it's 3 weeks with very thick avulsion, almost complete from the medial side. I have kept foot free also in case I need peroneus longus, then I can harvest the peroneus longus also.
Okay. And how old is the MRI?
It's 3 week old injury it is.
MRI was taken when?
MRI date is?
That's nearer to the injury or nearer to the surgery?
I think it is 2 week or 1 week hardly.
Plus. Okay.
1 week hardly. फाइल में देखो ना एमआरआई का रिपोर्ट डेट क्या है बेटा. So first plan of MCL about the repair. If there will be any dot, I'll reconstruct at the same time with the peroneus longus. So MRI is of 11 March.
Okay.
So this is the tibial tuberosity, just 1 centimeter below. I am putting the almost oblique incision here. Not vertical. Plan is to take both semi-T and gracilis. Since it's the PCL, so I need little bit longer graft. Otherwise, in ACL, in most of the time, I do with quadruple semi-T only.
And the knees in extension, with knees in 20 degrees of flexion?
Yeah, knee is in 30 degree of flexion.
And straight knee, no.
Yeah, it's a straight. Yes, under focus हो रहा है बेटा.
Can cameraman come from behind?
इधर से आओगे तो बेहतर दिखेगा.
Yeah.
अंदर देखना है बेटा. इधर से ये लोग आएगा नरेश. यहाँ से दिख पाएगा बेटा. ठीक है. So just after separation of the fat pad, there is thick fascia is there. That is sartorial fascia, and you can see there is a bump starting here.
Yes.
So it must be the part of gracilis, and below that there will be semi-T. Now you can appreciate better. This is the plane, and there just down that there is a elevation. So this bump is of gracilis, and below that there will be semi-T. So first I'll cut the sartorial fascia in the line of semi-T and gracilis, and I'll use the seizure. Table थोड़ा down कर दो बेटा.
Table down.
बस ठीक है. So this sartorial fascia get cut, and I'll take from below and above. Since I have to take both the graft, gracilis and semi-T both. So this sartorial fascia gets separated. Now you can appreciate this is the first elevation, and below that there is second elevation. You can see it.
Yes.
This is the gracilis part, and below that, the semi-T part. If I would have been taken only semi-T, then this is the only semi-T part. Laga ke rakho beta. And above that, this is the gracilis part. Okay.
Okay.
So I am just demonstrating the semi-T harvesting first. So till this much it is tendon only, and beyond that, most of the time it's the periosteum that almost 1 to 2 centimeter give you the extra length. So you just strip the tendon with all periosteum. You can see this much of length I gained by stripping the tendon from the bone. So this much of the length I can gain this much of the length. You can see the stripped part of the periosteum here. So this help in biological healing also. Experts say because of the periosteum part, this remain on the bony side. And this is the veniculi usually associated with the semi-T, that is 2 or 3. Just I am cutting that. And after that, just pass the finger to look there is no any further veniculi is there.
So
and once all the veniculi is released, if you left your graft, this will remain as such it is here. This means you have removed all the veniculi. Grasper. Naresh, tum idhar aa jao.
Have you flexed the knee?
Yeah, knee is flexed almost 90 degree. This is just for checking the graft veniculi. At the time of harvesting, I'll make it 30 degree. So this is here. At 90 degree only, I'll pass my tendon harvester in. Then I bring it to the 90 degree, 30 degree. Then slowly, I just pass the tendon harvester. So this much of the length I have. So just I'm checking whether it's 30. If it is 30, then I make it triple. And maybe if graft is more than 9 or 10, then I can go. This is, idhar focus karo beta. This is almost 32 here. But still I'll saber paper hai beta. But this is still 32, so maybe I need 10. So it will be triple only. So I'll take this gracilis also. इधर फोकस कर लो बेटा. हाँ, ये गरम है, देखो ग्राफ खराब, ये गरम है अभी भी तुम्हारा, उसको वेट करो. And this is the gracilis part, again along with the periosteum, complete periosteum. उधर छोड़ दो बेटा, ये ले लो. Again the same, the palpation of the tendon till deep so that there is no any veniculi. It is not there. Again at 30 to 40 degree of the knee flexion, I'll pass the tendon harvester. So this is this much of length of this. So the gracilis also here. चलो बना लो, टेबल अप कर लो बेटा.
तो ये टॉल क्लिप.
So I do my all arthroscopy most of the time, leg hanging the side of the table. For PCL, usually I do high anterolateral portal. So this is the patella marking. This is the patella. This is tibial tuberosity.
Can the light focus on?
This is the patella tendon. Okay. So my portal will be somewhere high, just as high possible at the highest junction of patella tendon with the patella. Yeah, this is going without touching to anything. And this is the trocar, this will be in. So at 90 degree, this is in. Then I flex to the 30 degree, then I'll go in the suprapatellar fold. अब वहां का चाहिए होगा बेटा कनेक्शन वहां पे जा रहा है परफेक्ट पानी ऑन कर दो परफेक्ट ठीक so this is the suprapatellar area under surface of patella cochlear part कैमरा क्लीन नहीं किया बेटा ये पकड़ो गॉड प्लीज दो मुझे Yeah. So this is the medial compartment. Middle then. So this again the anteromedial portal will be also high. Like that. मे भी दोनों की जरूरत पड़ सकती है So retropatellar part little bit has to be saved off. Now this is the picture. So that increased signal intensity in the ACL because the ACL is partial rupture here. You can see.
Yeah. Okay.
ACL is partially ruptured. At the same time, the PCL from the almost it
looks lax.
Yeah, it's lot of this fiber has been lost.
Show it to us. How is it?
Yeah, you can see the partial PCL tear also, ACL tear. So I'll just augment. I'll keep this ACL as it is, and maybe I just augment with that graceless part here. So on the medial side, you can appreciate the opening on the medial side. I can see the medial meniscus posterior horn without any pike rusting. So this much of opening is here. This is at 30 degree. And again, this is at 0 degree. So at 30 degree, it's get open more. So I'll just do the repair of MCL part. And I'll do this PCL, complete PCL reconstruction with partial ACL reconstruction also. And this is the lateral compartment. Meniscus looks fine. And this lateral compartment having little bit of the chondral lesion. So here I start debridement of the PCL. अब इसका एक बार डायमीटर चेक कर लो बेटा कितना हो रहा है पेरोनियस लॉन्गस लेना है कि नहीं लेना है So just in between the ACL and PCL, I'm just debriding the PCL remaining fiber because in PCL remnant, you can do that also as ACL remnant, but the passing of graft and other thing is very sometimes tricky. So just for the demonstration part, I am taking all the remaining PCL from here. Has to be very careful about the damaging the ACL. So your saber blade always should be opposite to the ACL all the time. 70 डिग्री स्कोप और स्मिथ लेफ्ट वाला टोकार कैनुला रेडी कर लेना बेटा. So I most of the time do this PCL reconstruction at tibial side with the help of 70 degree scope. Most of the time. I'll demonstrate that here also. So this is the part of the PCL, remaining PCL. And you can see the tibial attachment of this PCL part.
ACL also looks quite thin actually.
Yeah, it's a partial. You can see the part of attach on the femoral side that you have seen on the MRI also. That the increased signal intensity, particularly on the femoral side.
Part has gone up and attached to the notch.
So we have in our mind that this may be a part of partial ACL tear. So here you can see the posterior horn of medial meniscus, and below that you can see the Sarpe fiber. I'll demonstrate that also. So Laprad say just follow that and go just medial lateral to that, around 10 to 14 millimeter down. Right? So diameter is 8 of the PCL. So I'll ask from the house, is everybody is okay with PCL diameter 8? Or should I increase? Because graceless I use for the partial ACL augmentation.
I think minimum 9 we should accept, 9, not less than 9 for PCL.
Okay, perfect. That is my view also. Let others say, Bhutan boss.
So Bhushan says, 9, I think. Not less than 9.
So
I think you take one more graft, Arvind.
Yeah, peroneus longus.
Take a peroneus longus. Or
yeah, perfect. That's perfect.
Contralateral semity, whatever you are.
Yeah.
Or you can even take the quads if you want. You have exposed the knee anyway.
So my foot is already ready. So I'll take the peroneus longus. Just I'll demonstrate in couple of minutes that harvesting of peroneus longus also. Then I'll back to the, so that meanwhile, my assistant will prepare this. Prepare the graft. So, look the beta abhi.
And what will be your sequence, Arvind?
So first tunnel for the PCL and tunnel for the ACL. Then the graft, PCL on the femur and the ACL on the femur. Then followed by tibial PCL fixation in 90 degree with the anterior door. Complete anterior shifting of the tibia. And then ACL and the MCL in the last. एक टॉवल दे दे बेटा, यहाँ फोकस कर लो कैमरा. थोड़ा टेबल डाउन कर दे बेटा.
टेबल डाउन.
बस ठीक है बेटा, ठीक. थोड़ा ऊपर करो, डाउन हो गया.
थोड़ा ऊपर. बस ठीक.
So this is मार्कर दे दो बेटा. So this is the fibula.
You already have grasses.
And this is the peroneus longus, this is peroneus brevis. You can appreciate the bulge just below the fibula.
Arvind, are you taking the whole full thickness peroneus longus or partial only?
Yeah, it's full thickness, sir. What do you advise?
No, it's fine. So I think full thickness is a good idea. So you're going to use peroneus longus to beef up your PCL.
Yeah, peroneus longus or maybe sartorius, both.
And gracilis so is for your ACL.
Semity for now I have changed the plan. The peroneus since I am taking so peroneus and sartorius, gracilis for the PCL, and the quadruple semi-T for ACL.
Excellent. That's exactly what I was going to suggest. Well done.
So just from the tip, 1 centimeter just above the tip, a centimeter incision. लाइट थोड़ा यहाँ दे दो बेटा, तो लाइट नहीं दिख रहा, थोड़ा सा दे दो, ग्लेरिंग उतना नहीं बस. Now you can see the sheath of this peroneus. So I'm just cutting the sheath of peroneus. So this sheath you can appreciate. Can see this sheath? Is it there? It is visible there.
He has to come from behind. He's coming from the side actually.
बेटा तुम लोग ग्राफ उधर कर लो ना, तभी तो बार बार बोल रहा हूँ कैमरा वाले तुम इधर आओ बेटा, यहाँ आ जाओ, कम दिस साइड। हाँ चलो और उधर चलो, और उधर जाओ थोड़ा, तुम अपना यहाँ रखो, बार बार बोल रहा हूँ, अब वहां बना ले। So this is the seat possible.
Yes, now it's visible. Yes.
Yeah, this is the skin, this is the fascia, deep fascia, and this is the seat that I was talking about. And the seat is divided 90-degree R2. You can see the tendon just below the seat here, signing structure.
Yes.
Okay. So the superficial is the peroneus longus. And you can see the deeper one also, that is the peroneus brevis, this deeper structure. Can see it?
Yes.
This is the deeper one. That is peroneus brevis. You can appreciate it?
Yes, we can. Yeah.
Perfect.
Very clear.
So just confirm you have taken peroneus longus only. Needle do beta, needle holder. Perfect. ये कैसा है, खुल नहीं रहा है ये? सेमिटी को तब तक क्वाड्रपल कर लो नरेश। 2-3 web stitch here. Nice.
Arvind, you don't stitch the distal end of the cut tendon back to peroneus
Usually I used to do that, but once I met with Dr. Bancha, he said there is no need to stitch that part with the peroneus brevis. So this is the length that I got with this. So triple peroneus longus and triple gracilis will be for PCL, and the quadruple semity will be for ACL.
So for PCL, what's the average length that you eye for that?
Usually I ask for 10 to 11 most of the time.
Okay.
इसका margin थोड़ा पतला कर देना बेटा, नहीं तो diameter. अच्छा ठीक है चलो. So again back to the joint. How much time left for my surgery?
That depends how fast you carry it out. We are all.
Okay. Thank you for that liberty.
We are all enjoying your work. Don't worry.
We are all enjoying it.
नीचे लगा, नीचे टेबल के इसके थाई के नीचे लगा. So I'll make just for the demonstration this posteromedial portal also. बेटा एक वो दे देना हमको. IV cannula दे देना.
IV cannula.
पानी में प्रेशर और गलाना है।
टूनिकेट प्रॉपर है ना बेटा? जस्ट चेक कर लेना एक बार, है ना?
पंप वाला सिस्टम लेके आना था।
नहीं, पंप नहीं चाहिए, नहीं नहीं नहीं, पंप नहीं। जस्ट गणेश को बोले एक बार टूनिकेट चेक कर लेगा, दैट्स इट एंड नथिंग एल्स। So again, this is the PCL बनवा लो राजीव, तुम नहीं समझ में। सक्शन देख लो, सक्शन नहीं काम कर रहा। ओके since it's 3 weeks only, so maybe this increased vascularity is because of that only. Now again, in the I am in the posteromedial corner. Yeah. ज्योति, मोटा कपड़ा लो थाई के नीचे रखने के लिए। So this is in the posteromedial gutter. थोड़ा ऊपर करो, और ऊपर करो, कितना कर सकते हो। So this is the compromise when you do surgery in leg hanging position in the side of the body. For posteromedial side, you have little bit of difficulty, so you just put a thick seat below the thigh, quite above, at the level of tourniquet. So then you will have enough space for the working. So you can make low posteromedial, high posteromedial portal. So just I am making little bit high so that my saver will come in a better angle. So this is the needle that I have passed. Give me the knife, please.
Knife?
नहीं निकालो नहीं बेटा, बोलूंगा तो निकल जाना, उसी के डायरेक्शन में जाना है ना अपन को।
ठीक है।
So this is at the same level where our needle is. Perfect. $70 scope अब चाहिए होगा तो कार कैनुला रेडी रखो। So this is the 30-degree scope that I am seeing right now, and this is the PCL stump, remaining PCL stump. तो कार कैनुला रेडी है, इसमें रखिएगा। So this scope is of arthrex. So we have 30-degree scope only of arthrex. We have 70-degree scope of this Smith nephew. For that you have to change that trocar cannula also. क्या है trocar cannula? आ गया है R6 का परफेक्ट चलो लगा लो फटाक है? एक बार ग्राफ तब तक दिखा दो इधर ग्राफ पे फोकस कर दो उधर ज्योति इसको लगाओ कनेक्ट करो इसको वो चाहिए होगा क्या इसमें ये निकालना होगा ना निकाल दो। ये इसके साथ कहाँ लग रहा है कहाँ है आर्थिक चूल्हा बनो
So what are your final dimensions of the graft?
ग्राफ दिखा
This was
ACL so length is 8 tibial side is 9 and femoral side is 8
okay.
Okay, so Rajiv is saying its tibial side is 10 and femoral side is 9
Okay. And diameter is 9.
Diameter is 10 on the tibial side, 9 on the femoral side.
Sorry,
so we have almost complete ACL reconstruction.
Length?
Length is 8.
8. Okay.
So I have shifted from 30 degree to 70 degree. सक्शन देख लो बेटा सक्शन नहीं काम कर रहा
सक्शन देखती हूँ
पानी खत्म हो रहा है क्या बेटा दूसरे में कनेक्ट कर दे और एक और बोतल लगा के रख लो बेटा एयरवे डाल दे उसमें पंप नहीं चाहिए बेटा मैंने मना किया था निकालो पंप उसमें से पंप अपने मन से कभी मत यूज करो बेटा so this is the posterior horn of medial meniscus and this is the PCL stump now you can see with the help of 70 degree
yes it's visible
yeah it's complete down you can see the complete footprint here PCL jig ready रखना बेटा गॉज पीस एक फ्रेश गॉज पीस दे देना थोड़ा प्रॉब्लम
roughly how much you have gone
usually 10 to 14 millimeter down the articular surface पानी बंद रखें
बंद रखिए
हाँ ठीक उसको खोल दी यहाँ यहाँ हाथ रखो
Dr. Arvind, have you looked for popliteus?
Yes, I'll see also that at the same time. Yeah. आज इतना खराब से दिखा रहा है यार
सेक्शन काम कर रहा है ना
They improve the scope.
Yeah.
I mean, it's not very clear.
ये पकड़ो बेटा
एक बार वाइट
So again, this is the posterior horn of medial meniscus. And this is the PCL part, okay. There is blurring is there, but if you can appreciate, this is the main footprint of the PCL over the tibial attachment. You can appreciate this?
Yes, it's.
Yeah, perfect. So I'm almost done from here to here, okay? In the posterior part, capsule is there.
Shave it completely. Really important to shave it completely.
Better hai.
You need to go down, and it's a big. If you want to probably will it hinder?
Slightly different from what Arvind is showing. I go over the top of the PCL. So I dissect the interval between the PCL and the capsule. And then you put your PCL graft on top of the original PCL. That
So you use a posterolateral portal as well to
just
visualize. No,
posterolateral
you just go over the top.
So just dissect the capsule from the PCL remnant. It's never adherent. So there's a nice plane of fat there. So you can easily go there. And you don't need to dissect the PCL.
So you don't have to do anything then. You just go over
just
the
go
top.
over the PCL.
Over the top.
It just makes it very easy.
So this is the tibial footprint. You can see.
Tendon preserving.
You can appreciate the capsule part.
Yes.
Separated the capsule from tibia completely. It is almost 15 millimeter down the articular surface.
Yeah.
Tibial jig de do beta.
For some reason, I could never get my head up 70-degree scope.
Right. Tibial jig do beta. क्या है लगा है? Tibial jig do beta.
70-degree scope like Arvind.
वो वाला portal बंद करो.
Looking in front while looking at the left or right side. Can't do that.
Taking a lateral, posterolateral.
You've
done that?
Tibia PCL.
I do posterolateral portal when I'm doing popliteus reconstruction.
Tibia PCL.
But
if
you have a good anterolateral slightly higher, an anteromedial portal, and one good piece posteromedial high portal, there's no need for a lateral portal.
Posteromedial portal also need to be slightly higher.
And you can do two posteromedial portals if you're worried.
Do two.
So one you can put a Steinman pin or a passing pin, so you can return.
So this is the Arthrex jig. The marking is here. And this is 14 millimeter. Curvature is here. You can see that almost at the PCL footprint. Sleeve लगा राजीव छोड़ दो वो लोग कर लेगा हम देखेंगे स्लीव दो उसका ये रहा स्लीव स्लीव बस usually this should be just medial to the tibial tuberosity, usually just below the level of tibial tuberosity on the tibia. Go in, इसको क्लोज कर दिया चलो परफेक्ट एक मिनट रुक जाओ जस्ट फॉर द विजुअलाइजेशन पर पर्पस बेटा अब उसमें पंप लगा लो ये थोड़ा अच्छा नहीं दिखा रहे कर दिया उसमें बेटा इसमें तो है ऑलरेडी इसमें मारो हाँ और उसको उसमें कनेक्ट कर लो बेटा चलो तुम इंगेज कर लियो स्लीप पकड़ो विवेक स्लीप नहीं है बेटा स्लीप पकड़ो पूरा चलो एक दो पंप मार दो बस रुक जा एक मिनट थोड़ा बात लिटिल बताओ ये छोड़ थोड़ा शिफ्ट हुआ है मीडियल साइड में तुम थोड़ा स्लीप ये छोड़ दो बेटा चलो उधर बंद रखो चलो गो प्रेशर रिलीज कर दो प्रेशर रिलीज हाँ चलो यस सर
Jaswinder, this side. The clarity of this 70-degree scope is not as much clear as that 30.
Yeah, 30 degree. I know. Just for the
there's a lot of blurring actually.
Arvind, for some reason, the inside view is not very clear.
Yeah, I know.
Is there some issue with the
This
camera?
is the problem with the 70-degree slope.
Okay.
चलो बस टिक वही रखो, ठीक है, जस्ट आ गए, जस्ट इन जाओ, जस्ट लिटिल बिट इन, अभी इन से बाहर क्यों कर दिया, बस 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 ठीक है, तो खोलो जरा.
So this you are using as zig from Arthrex.
Arthrex it is.
Arvind, can't you make it a bit clearer on the scope? It's just
30 degree दे दो आप मेरे को.
Very blurred.
Scope दीजिए, ज्योति भाई 30 degree scope.
I don't know if it's 30 or
no, 70 degree is not good scope. 30 degree दे दो. 30 degree.
even with the 30, it wasn't as clear as it normally should be.
Dry gauge piece dono.
Are you using a pump or a?
No,
not the pump as well. No?
No pump, usually just for the visualization purpose, but I have removed that also. उसमें connect कर दो बेटा.
This one, this one will connect.
No problem. ये पकड़ो बेटा, और मत छोड़ो बोल दिया. आप बीमार लगा दो. पानी बंद कर लो बेटा, वहां से पानी निकलेगा तो चलो. So you can see the bead pin there, tip of the bead pin. Just can you appreciate this?
Yes,
it's better for sure.
Take hammer then.
Hammer much clearer also. And
diameter आ गया. Diameter एक बार check कर लो कितना. So just in the at the center of the footprint of PCL, नाप लेना. अभी नाप को सकते हो ना, तब तक रीमिंग पास हो जाएगा ना. So diameter of PCL you can appreciate here. Okay. Tape डालना था ना.
how much did you get? That's triple, huh? The peroneus.
Peroneus and semity. This is 12, 11. So it is 11.
11
on each side. यहाँ टेप डालो ना. टेप क्यों डालो? हाँ, इस पे रेल लोड कर लो. तुम ड्रिल करो. 11 का रीमर लोड करो. So tape just at the end of the graft. यहाँ दिखा. Just for the pulling from the tibial side. Tape will be used here only, not in the graft.
Could you repeat that, Arvind, please?
So many a time when you take the graft from the tibial side to the femoral side,
yes,
there is lot of soft tissue in the posterior part of tibia. So you have ET bond here. At the same time, I'll put just a tape here that will give a much stronger thing to pull from the tibia to the femoral side.
Okay.
Because if this is weak, some soft tissue get stuck. Very high chances of breakage of this.
Okay.
ET bond. इस पे रेल लोड करना.
वो उसी के.
रीमर.
रीमर 11.
So meanwhile, I am just making the femoral tunnel also. Femoral ये femur आ गया. बस दे दो. Meanwhile, 11 mm graph, this femur is so tibia, it should be high as possible and the close to the articular surface because I am doing single bundle.
Arvind, aren't you worried with that sharp bead pin end in the back of the tibia just like that?
It's just, you can see.
I'm worried here that sharp tip is on the back and you're doing femoral without doing anything on the back.
I'm not flexing the knee, just it is added here. Yeah. You can see we have enough space also. Reamer mil gaya. Just for the sake of saving the time, I was going to that side. Mil gaya reamer, 11 mm. तो लोड करके दो ना उसमें तुम ही लोग के चलते मैं बीच में ले रहा था 12 का 35 चेक कर लेना बेटा रीमर लो ना 11 ये कितना है 11 रीमर रहता है ना सेट में
अरे आई एम ऑलवेज वरीड सर 2 बार आखिरी फोड़ी मुझे पता है
दिल दो फिर पकड़ो इसको तो पतला कर लेता यदि सेट में नहीं चलता
मैं थोड़ा रोटेटेड था इसलिए
यस आई एम टेकिंग लिटिल बिट बैक एज एडवाइस बाय भूषण सर पकड़ो ये दो
थैंक्स फॉर डूइंग दैट
and going back to the femur side because I am still waiting for the reamer between load करो इसको
Now Dr. Bhushan is breathing. He was holding it.
Yeah. So this is the femoral footprint of PCL. Sleeve ले लो बेटा. Brightness थोड़ा कम कर दो. Brightness बहुत है. Sleeve है ना? चलो sleeve लगाओ. यहाँ है मेरे हाथ में. इसको close कर लो. So are you happy with this position, Bhushan sir? Or you want to modify this?
No, perfect. That's fine. You're replicating the AL bundle, which is between 12 and 1 o'clock position, which is fine.
That's perfect. So it's come. Pardon?
Angle of femoral jig?
Angle of femoral jig is 60 degrees. This is again orthorex jig having curvature of the femoral condyle. तब तक 8 से कर लो बेटा क्या 11 यहाँ हमारे सेट का क्या हुआ हमारा सेट का
So you're planning aperture fixation for femur?
Yeah, aperture for the both tibia and femur. चलो तब तक 10 से करो बेटा 10 mm दो जो है वो दो ग्यारह mm यूज हो गया तो देखो ना तब तक यदि ऑटोक्लेव अब तो 2 घंटे हो गए बेटा वो खत्म हो चलो चलो This is 10 mm remove. Meanwhile, my jig is there only to protect.
So you are roughly 10 millimeter from the articular.
Yeah, I'll just रुक जा बेटा. धीरे-धीरे जा. बस ठीक. So cleaning of the margin is very important, particularly for the PCL, for the passage of graft.
Yeah, otherwise it may get stuck sometimes, and then the soft tissue will act like a valve.
चलो 10 mm टीविया के लिए ले लो, पहले इसको हैमर कर दो थोड़ा. So this is the tunnel.
Yes, it looks clear.
ठीक है, पहले देखने दो. Now back to the tibial tunnel. एक मिनट देखने दो बेटा, रुको. चल जाओ धीरे 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 धीरे. वो प्रोटेक्ट टीबिया पीसीएल देना तो प्रोटेक्ट करने के लिए. तो देखो ग्राफ्ट को यदि पतला कर सकते हो तो this thing also has to be kept in mind, because your graft should not be more than your reamer what available you have. Usually we have till 12 mm reamer we have available here, but that was used in the last case. The set was open. चेंज कर दो बेटा, पानी खत्म हो गया ना, चेंज कर दो. कमलेश को बोलो रहेगा यहाँ पे, उसमें लगा दो. चलो मिल जाओ. चलो हल्का ठीक है बेटा, रुक जाइए. वहाँ पानी वाले सिस्टम पे तुम तो हो ना. Usually it's very easy with 70-degree scope. लो पास करो राजीव, पास इट, हैमर करो थोड़ा. बस बस 10 इट. 10 mm है कि 11 जो है मैक्सिमम साइज वही दो. नहीं नहीं ठीक है, दिख रहा. चलो खोल क्यों दिए हो बेटा, टाइम क्यों बर्बाद कर रहे हो. तो we are drilling with the 10 mm that we have available, so we'll decrease the diameter of the graft. चलो चला गया, चलो धीरे धीरे जाओ, कोई बात नहीं. हैमर कर दो.
So decreasing the diameter, you had to redo the whole thing?
No, just trim the graft from the side. I'll show you. Chalo, deal karo.
And what about the whip stitches?
Also, how to decrease the graft diameter. Meanwhile, maybe possible that they will give me 11 mm. क्या हो रहा है 11 का? धीरे धीरे जाओ, धीरे धीरे. एक बार बता दो कितना देर में मिलेगा तो. धीरे 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 धीरे. फ्लिप कटर है ना, फ्लिप कटर बस में. ठीक. तो this is the tibial tunnel that we have. SS वायर दे दो. कोई पीसीएल स्टेप का कोई स्टाफ कर रहा है कोऑर्डिनेट? ये सब एक ही चीज में एक ही जगह खड़ा है। फ्लिप कटर आ गया है, फ्लिप कटर को कर लो 11 पे। So we have flip cutter. This will give us the diameter of 11. ठीक है, 11 कर लो बेटा उसको। हाँ, चलो जाओ, धीरे 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 धीरे, रुक जा पहले देखने। पानी आ रहा ना अभी, फ्लूइड एक्स्ट्रा वेसेट करेगा तो देखने में दिक्कत होगा। एक काम करो, बाहर से ही थ्रू एंड थ्रू करना है ना, बाहर से। तो दिस इज द फ्लिप कटर, यू कैन सी द डायमीटर हियर। 11 कर लो बेटा।
अरविंद, पुट द बुलेट इन फर्स्ट, उसके बाद में फ्लिप कटर डालो उसमें।
Before flipping,
if you put the bullet in the tunnel, you won't have to toggle in the because already done 10 millimeter. No?
वो 11 mm का क्या हो रहा है, कुछ बता रहे हो? एक मिनट, 11 mm बीमर है कहाँ हम लोगों का? हम लोग का 11 mm रीमर जो है डेक्स में डाल देता है इतना देर। हाउ यू नो कि कितना गया? छोड़ दो। इसको 11 कर लो। एक मिनट रुका, धीरे धीरे नीचे दे दो। 11 कर लो बेटा। कितना है? 11 हो गया। So this is 11 meter open here. I'll put little bit in this direction. Already हो ही गया। So it's coming very easily. So almost चलो ठीक। इस वाले में कर ले। यहाँ हाथ रख ले बेटा। चलो यहाँ बंद कर ले पूरा अच्छे से। बस बस आराम से। कितना है? 9, 10, 10.5, 11. So almost this is 11 mm. So almost it is 11 mm only. So okay, let's see. I will decrease the little bit graph diameter also. हमको SS wire दे दो.
Arvind, it was drilled with initially with 10
millimeter. I don't know what diameter they have given to me. Yeah. Now I have passed this SS wire from the tibial side. Hold this.
Okay.
Then I'll retrieve. अपनी ओर ले लो बस। टिल द टनल हेयर। पानी बंद कर दो बेटा, यहाँ हाथ रख लो। हाँ परफेक्ट। दिस चलो तो and then on the femoral side, यहाँ फोकस कर दो जरा। So this is on the femoral side. I'll put another SS wire here and just do little bit of passage of this SS wire. दो वो लगा लो बेटा। यहाँ तुम हाथ रखो, यहाँ पे हाथ रखो। हाँ एक पकड़ यहाँ लगा लो। ज्यादा मत करो। आने दो। तो यहाँ पे फोकस करना जरा, आउटर पिक्चर अपनी ओर ले लो। तो दिस इज usually done for the better passage of graft because high chances of getting stuck with the soft tissue. By this maneuver, your tunnel will be free of the soft tissue. In between the tunnel passage will be free of the soft tissue. But that's it.
And this maneuver will increase the diameter also.
Usually not if it is very thin. It is wide.
Osteoporotic bone or bone.
This I learned at a sports injury center. So Joshi sir is here. he may say better about the increased diameter with this technique. Joshi sir?
Is not in the his
Room
not
right
here
now.
in the hall.
ग्रुप में ग्राफ में ये पकड़ तो यहाँ दिखा दो जरा ये पकड़ो जरा साइजर दो हमको फिर से एक बार
11 कौन सा है बताओ, दिखता नहीं।
ये कैसा साइजर लेके आया चलो वो दूर रखो बेटा दिस इज 11 है ना चलो 10 पे जाओ हम लोग 10 से किए ना बट 11 से फ्लिप कटर से तो हो गया था बट यू नेवर नो द 10:30 में देख लो
The graft is now after trimming how much?
It's 10:30. 10.5. So we can take the risk whether this is passing or not because with flip cutter it was 11. Let's see.
Yeah, that was also passing very freely.
Yeah. So this was the fiber tape that was given there for the pulling purpose only. एक मिनट यहाँ वो लगा ले क्या नाम है प्रॉपर लगा ले बस ठीक चलो पास करो इसको और पास करो ये पकड़ो बेटा इसको यहाँ रखो चलो खींचो so this is on the femoral side चलो कर ले चलो चलो So it's not coming very smooth. So we'll wait for the 12 mm diameter. That will come in couple of minutes. Meanwhile, I'll do the ACL part. So you can continue with the lecture. When 12 mm diameter come, then I'll demonstrate the remaining part. Okay.
Okay, we'll do that.
Yeah. ACL jig do beta. यहाँ
Abhishek, are you ready with the lecture? OT का ट्रांसमिशन अभी रोक दीजिएगा.
So may I call upon Dr. Abhishek Das, who will be talking on MCL tier.
ACL jig दो. तुम लोग का दिमाग ऑफ हो
Good
जाता है.
afternoon, everybody. I think it will be difficult to engage everybody after such an engrossing and beautiful surgery by Dr. Arvind. My talk is on MCL tears, and I'll show a couple of cases because there has been or there is a persistent debate as to whether we should treat them conservatively or operatively. So, first case is a 29-year-old male came to me 2 days after a twisting injury to the knee with a complaint of knee pain. There was no history of knee giving way or locking, and the patient came walking full weight bearing. So on examination, there was tenderness over the femoral epicondyle region, no tenderness over the joint line or proximal tibia, no bruising, and minimal swelling, and there was full range of knee movement. So probably this is the MRI image. So what's going in our mind? Just the chairpersons or anybody, especially the PG students or the trainees. I think this is pretty clear-cut, straightforward case where there is no laxity in the full extension, no valgus laxity. In 30 degrees flexion, there's a touch bit of laxity, but with a very firm endpoint. MRI, probably there's a bit of edema, you can say, but it looks pretty much normal. The MCL, the X-rays are normal. So this is not exactly how I treat these cases, but this is more so for the grade 2 laxity ones where I treat them with range of motion brace. If it is a grade 1 with no appreciable laxity, just tenderness, then I send them straight for rehab. I do not brace them at all. With grade 2, and even for the grade 3 ones with no with a firm endpoint, I treat them with range of motion brace. There's a bit of debate as to where you should keep it for 4 weeks or 6 weeks. But to keep things simple, this is the protocol we used to do in UK: 0 to 30 degrees, 2 weeks, 2 to 4 weeks, 0 to 60 degrees, 4 to 6 weeks, 0 to 90 degrees. Any difference of opinion as to whether you would fully weight bear them or keep them non-weight bearing? Okay.
No harm in getting them full weight bear, is it?
Yeah.
With the
In
brace,
this
you
case,
can
definitely. But if there's a grade 3 laxity, I would keep them non-weight bearing to avoid the pivoting. And but there's no kind of hard and fast rule. So next case, 35-year-old male with a history of fall and knee injury about 5 weeks ago. Initially treated in a brace for 4 weeks. So when the patient came, it was about 5 weeks with a history of knee giving way, but no locking. So on examination, there was at 5 weeks, there was no tenderness over the femoral epicondyle, no tenderness over the joint line or proximal tibia, no appreciable bruising and minimal swelling, knee range of movement around up to 100 degrees, valgus laxity at 30 degrees with a soft end point, Lachman's and anterior drawer test positive with a soft end point, positive drawer negative, Dial's test negative. These are the X-rays. This is the MRI, the coronal view. So on this, what do we think it's going on? I think there's something going on with the MCL. These are the sagittal views, and the ACL, there seems to be a tear. So these are the multiligamentous injury cases, and we have had a bit of discussion on this. The chairpersons or Bhushan sir, what do you think we should do in this case?
It's a normal ACL MCL combination that we tend to see. I forgot if you mentioned, is the knee opening in extension also?
The knee is not opening in extension.
So you can safely call it grade 2 MCL injury?
Yeah.
So POL is not gone yet.
Yeah.
Okay. So so there's significant bony edema. There is no discernible major medial meniscus tear seen, at least not from here. So you would wait for 2 to 3 weeks normally for these patients with knee immobilized in about 10 degrees of flexion to allow the MCL to tension a bit or heal a bit. But you said this is already 5 weeks old and is already
patient was already treated for 4 weeks in the brace.
So it's a failed ACL MCL rehab. So
I think when the patient came, he was just treated in the brace with no appreciable rehab or you would say quadriceps or hamstring, any kind of rehab done to him. So 1 week he was out of brace, and
I can't remember whether he was sent to any physio or not.
Is the knee bending or stiff now?
Yeah, so knee is bending from 0 to 100, almost past 90, but not fully.
So, okay for surgery then. Good.
Yeah. So, first thing we have discussed that it is a case for surgery. We have already tried non-operative measures. So, timing of surgery?
Now.
6
weeks already.
Yeah, I think it's already. I won't wait to get his full knee range of movement. Up to 100 degrees is acceptable to me. We can pass the scope and we can do an arthroscopic as well as whatever we need to do for the collateral. What surgery? Pretty much. How would you sequence it? Whether you do everything together or you're just...
It's just two ligaments, so both can be done at the same time. The question will be whether you should take hamstring grafts because of the MCL injury, because that will lead to a bit more laxity, or should you take something else? I think Deepak or someone just showed taking semity, leaving it attached to the tibia and using it as a graft for MCL, and using a quadriceps, BTB, peroneus longus, contralateral semity, allograft, whatever else you want for ACL is a good option.
Yeah. Previously, like I worked with one of the consultants in UK who used to leave the hamstring, used to take BTB if it was a male patient. For female, obviously we never used to take the BTB graft. So BTB and peroneus longus or something else. There were options of allografts as well available. But he said that we should not defunction the knee even more by using the hamstring. But, you know, again, no strong feelings for or against it. MCL repair or reconstruction?
I'm going to say something slightly controversial. This will be a good candidate for a POL advancement. Now, those of you who are young ones may not remember a POL advancement as a surgery. I think senior guys will know zone-specific POL advancement. Posterior oblique ligament is separate ligament just behind the MCL. And there are 5 zones of the POL, and you can advance it based on which part of the MCL is gone. So if the femoral is gone, you can advance zone 1, zone 2. If the central part is gone, you can do zone 3, and 4, 5 are for the tibia. People almost have given up on it for some reason, but that's one of the best surgeries you could ever do for a grade 1 or for a grade 2 MCL. So that might be something you should think about.
All right. Obviously, I didn't think about that option, but in the next case, definitely that would be one thing. MCL repair with augmentation maybe, or MCL reconstruction, which is what I thought about it. Obviously, I didn't think about MCL repair at 5 weeks. Now, ACL plus MCL reconstruction, we have already discussed it. One thing, would you, in this case, do an ACL reconstruction and reassess it, or just do an EUA beforehand and then just proceed with the plan?
You can always EUA and decide whether the MCL is stable or healed in any way. But if he's had a recent history of giving way and you felt the ACL, you felt the knees opening in 30 degrees of flexion, I think it's gone.
So this is the drive-through sign. It's quite opening. And that was the reconstruction done along with the ACL. So again, what we have already discussed, isolated MCL tear heal well with good rehab protocols. Grade 3 isolated MCL tears may be managed conservatively, but if it is a part of multi-ligamentous injuries, there's a low threshold for surgical intervention, and we have seen the protocols. These are some studies which kind of show that what we have discussed, like isolated MCLs, you can treat them in a brace, but as part of multi-ligamentous protocol, you can leave the ACL, do the rest in one stage. So overall, a 2-stage procedure. Thank you.
So, Dr. Abhishek, so, I mean, how long you can wait for, I mean, before reconstructing ACL, MCL? If it's ACL plus MCL injury, grade 3 MCL.
Yeah.
So, deadline is what, 4 weeks, or we have to wait more than that?
Yeah, normally ACL and MCL injuries, if it is only these two, then I would rehab them in a brace. And that would, for me, be 6 weeks.
6 weeks. So
get
you
them
will
in a brace.
reassess at 6 weeks.
Reassess at 6
Then you
weeks.
will, if it's not healed, then you will do ACL and MCL.
Yeah, I'll do the
together.
ACL and MCL.
So what technique did you use in this case?
Sorry?
For MCL reconstruction? What technique did you use in this case?
So it was one of the standard technique where we use the, kind of we took the semi-T graft around the screw with the washer, just round them up and stitch them together. So the washer acts as a hinge on which the MCL. So it's extra ligamentous, but you can use swivel locks and other options as an interference screw.
Yeah, any role for internal bracing for MCL that works wonderfully in these kinds of injuries?
Yeah, so that was one of the things I wanted to put it in, but then it quite becomes like one company specific, so I didn't put it in my slide. There is definitely a role for them in these cases where you can do an ACL, do an internal bracing, and leave the MCL.
If it works, company doesn't matter. If it works fine in your hands, I think you shouldn't worry too much about those things.
Yeah, I entirely agree.
So you said this patient came to you at 5 weeks and had no rehab.
He was treated in a brace, but he wasn't sent to a physio. I don't know if he was instructed to, take it out of brace and do some kind of hamstring or quadriceps exercises.
So would you think of doing that first before going to surgery?
Yeah, definitely. I think there's a role for it, but he was kind of giving history of knee giving way. It was already 5 weeks down the line.
Yeah,
so.
okay. So if it gave way while he was walking itself?
Sorry?
Did it give way while he was just walking?
Yeah. So
then you need to do something anyway.
Yeah.
Any landmark where you would put the screw on the tibial side for the fixation of MCL?
Good question. Avoid the tibial tunnel. It is about, well, to be honest, I can't exactly remember. I'd like your opinion on that.
It's at least 6 centimeters down the joint line.
Yeah.
Just in front of the posterior cortex, I suppose.
Yeah, definitely.
Just anterior to posterior cortex.
Yeah.
Yeah. Right.
Yeah.
Right.
Okay, sure.
Yeah, may I call Dr. Rajkumar?
No. Rajkumar is not here.
Dr. Bhushan, yeah.
That's me.
He'll be talking on the expert lecture on LCL injury.
Let's hope this works. Yeah, okay. We need to shift the, give me a second. So I need to shift the view. They are getting the presenter's view. I'm getting the view on the screen. This view should be with me. Top display on top. I don't know. So I'm going to talk a bit about management of post-lateral corner injury. I think Soumyadeep has spoken a lot about that already, and he's already stolen the thunder. So I'll try and not bore you too much and be a bit quick about it. So a typical patient, unfortunately my own, 3 years back did a ACL reconstruction. This is about 10 years back. So you can see the result of that ACL. She's got a significantly bad varus thrust, the so-called triple varus deformity. And that's due to a missed lateral collateral PLC injury of the knee joint. That's very important not to miss this injuries, because these are very important. Houston, as he was a god of a lot of ligamentous surgeries in the knee, in 1976, actually named this as the dark side of the knee. Since then, we have found a lot of darker sides of the knee, but this was the OG dark side of the knee joint. So ACL, PCL and PLC injuries quite a few times go hand in hand, especially the PCL injury. So if you ever have a PCL, quite a few times the PCL and PLC go hand in hand. Pretty complex in terms of structure. So if you remember your anatomy dissections, this is exactly how your post-lateral corner is in 3 layers. The top layer is the IT band along with the common peroneal nerve, with a deeper layer of cordyceps retinaculum and the 2 lateral patellofemoral ligaments. Is a deeper layer, the layer 3, which is very important. Again, divided into 2 parts, the superficial and deep. This is where the main structures of your PLC are. So the LCL and fabulofibular ligament, the lateral genicular artery running between the 2 layers, and the popliteus tendon, the arcuate coronary ligament complex, and the popliteofibular ligament, which is supposed to be the most important part of the whole thing. I don't want you to remember any of this. I just want to show you the key parts. That's the popliteofibular ligament as such. Anybody interested in learning about anatomy a bit better can of course read Laprard's paper. But before that, these 2 papers are also equally good, which talk a lot about the actual anatomical structure, which are important. This is me playing with Microsoft Paint, and you can see the basic anatomy of your post-lateral corner. You can see the ITB, the biceps and the common peroneal nerve. And on the other side, you can see the other structures which are important. From the fibula comes the lateral collateral ligament. Just behind that is the popliteofibular ligament. The popliteus coming up there, and the blue dot there is the fibula, which forms the fabulofibular ligament. So these are all the structures. Any of you who have access to cadaveric dissections, just go anytime you want and open the knee from the backside. Take all the both the gastrocs out. Take the neurovascular structures out, and you get a brilliant view of the posterior capsule of the joint. And funnily enough, it looks exactly the same. So that's where the arcuate ligament is. It's a Y-shaped structure which attaches laterally to the fibula. And this is an important part of the post-lateral complex as well. And as you would see in quite a few cases, you will see an arcuate avulsion. That's what the avulsion of that fibular limb is. Now, biomechanically, it's a very important stabilizer for varus, and it's also important for anterior and posterior stability of the knee joint. And it also gives a minor role for your internal rotation restraint. So this is me doing some cadaveric dissection. The front is the ALL, the back is the popliteofibular ligament. There is a LCL seen in the middle. And you can see how rotation changes and the ligaments get tight with external internal rotation. It's very important to understand this, that there's a primary stability to external rotation for these. I won't go into details of how it happens. We all know about it. We also heard about how a dial test is important to diagnose these lesions. In 30 degrees of flexion, if you get opening excessive external rotation, that's very classical for a PLC injury. And if you are getting excessive external rotation in 30 as well as 90 degrees, it's PLC plus PCL, or maybe just isolated PCL. So important to remember these things. This is very commonly seen, and this is a knee dislocation, and you can see the big fibular avulsion pattern. So don't miss these injuries because they can lead to devastating complications in future. So you can either get an isolated PLC injury, which is pretty rare, or it can be part of a multi-ligament injury along with your ACL or PCL injury. Anytime you have ACL, PCL along with PLC, it's always a good idea to do a Doppler scan, because there are sometimes intimal injuries to the artery which are missed, and then you wake up the second or third day with a patient having a white leg or a white foot. It's a pretty frustrating thing to have that. Common peroneal nerve injury is pretty common with PLC injuries. So always examine your patient, make sure they're getting dorsiflexion in the foot and toes. And it depends on how severe the force was. On simple X-ray, you can see a Sigon fracture, but you can also see an arcuate avulsion, which is distinctly separate from a Sigon fracture. It's called arcuate sign. And you can see abnormal opening of the lateral compartment. That's pretty classical. And on the MRI, it looks as if a bomb exploded in the top surface of the fibula, where everything is just damaged significantly. We are orthopedic surgeons. We always like classifications for everything. So the posterolateral rotary instability, that means PLC along with ACL injury or a PCL injury, would lead to various types of findings. So the key test is external rotation and varus laxity in 30 degrees of flexion. And depending on the main components which are affected, the popliteofibular ligament, popliteus or LCL, and the capsule, the severity increases from A to C. Now, coming to management, there's a variable pattern seen, so you need to make sure you don't miss it. And if neglected, you can have serious problems with early OA changes in these patients, which might need a HTO in future. So we want to stabilize this as early as possible. Sorry for the very heavy slide, but essentially you can easily do a direct primary repair for something like this, where your ITB is avulsed, your biceps is avulsed, your nerve is slightly bruised or damaged, your gastroc is injured. That's a severe kind of injury. You can just do repair of everything, works quite well. For a chronic injury, you can either do a Larson kind of procedure using a free graft, or you can do a good old-fashioned biceps tenodesis, Clancy tenodesis as it was called. I haven't seen one since I started practice, but it always is an option for temporary stabilization of PLC, but no longer an important procedure for us to know. Larson sling works really well. It recreates most of the components of your PLC except for the popliteofibular ligament, and that's why the Laprat technique came in, which includes recreation of all of the three components, the popliteus, the lateral collateral ligament, as well as the popliteofibular ligament. I modify this technique very slightly, where I take one more stitch between the posterior part of the graft along with popliteus to recreate the popliteofibular ligament slightly better. Coming back to the same patient that we saw in the first part, the ACL implants were removed, a formal HTO was done, and immediately her alignment changed and her thrust went, but she still had significant amount of laxity on the lateral side. So next is to do a lateral reconstruction using either Laprat technique or any technique you're comfortable with. So the landmarks are lateral collateral ligament insertion on the lateral epicondyle. The midway area between the fibular collateral ligament, so between the fibular head and Gerdy's tubercle, that's for the ALL. We're not talking of ALL, that's just a landmark I've shown. But your incision is between these 2 points for exposing the lateral compartment. A lot of times people make the mistake of getting their incision too far posterior, and then they struggle to reach the anterior part of the incision. Let me see if I can show you. The first and the most important part is to find the nerve, and that's the most time consuming during this surgery. Quite a few times the nerve is very bruised. All you need is a good incision and finding the nerve really carefully, and always do a neurolysis. So always release the nerve all the way to the hiatus posteriorly in the popliteal hiatus to make sure the nerve is clearly seen and is completely decompressed before you go any further with your reconstruction. Now, once you're done that, you can easily palpate the area superior to the nerve and back of the fibula head, and you can easily put your finger in to find where your fibula tunnel is going to be. Now the fibular tunnel can, so that's how your finger can be there. Now, some people are brave enough to drill on top of the finger, very good, but you have really good jigs now. So these jigs are fantastic for saving your finger when you're drilling, unless you are super confident of not hurting yourself. So this is a set for a Laprade PLC reconstruction that is available through various companies, and it works really well in most people. So there's actual jig which goes behind the fibula head, and you can make a tunnel like that in the fibula head. There is also a flexible or moldable retractor which can be placed behind the tibia or behind the fibula to create your anteroposterior tunnels comfortably. So once you're done that, let me see if it works here. So once you're done that, you have created a nice tunnel. It's a standard fibular tunnel from anterior to posterior, slightly more anterolateral to posterior medial if possible, because you're trying to replicate your LCL insertion, which is more to the lateral side, and your popliteal ligament, which is more posterior medial. Hope I'm making sense and not confusing you more. This is followed by making a cut to find the insertion of your lateral collateral ligament. As you can see, it's a bruised area in the center. That's the lateral collateral ligament insertion, the lateral epicondyle. So find that area. Now you need to make 2 tunnels to replicate the anatomy. So this is how your popliteus and your LCL are going to come. The distance between the two has to be about 18 millimeters. When I say 18 millimeters, that's for a male. For a female, it can be smaller, where smaller tunnels can be used. So all that you need to do is drill a tunnel from lateral to, I'm sorry, give me a second. From lateral to medial, aiming slightly proximally and superiorly so that you won't encounter any other tunnels. And there is a brilliant jig after that to make sure you are getting 2 tunnels which are wires which are perfectly parallel without them converging or diverging, because quite a few times if you do freehand, your screws hit each other and then you get a graft which is loose. So this is what you're aiming for. You've got 2 tunnels. The anterior one is for popliteus, the posterior one is for your LCL. And the main advantage of using an all-inside technique or outside in drilling technique is now that you know where your tunnels are. You can create a ACL tunnel without tunnel coalition between these 2-3 tunnels. So it works really well when you know where your landmarks are. And then they just followed by passing the graft. So we have passed the graft in here. So that's your graft in the fibula. Those who are keen-eyed will see I've reinforced that with fiber tape. You can or may not do it, but I like to fix it to the fibula with a screw if possible. This is a this is 6 millimeter fibula head peak screw, which is being attached to the fibula head. I agree, especially in petite females or thin males, you may not have sufficient space, and in such patients, I do periosteal stitches to hold a graft to the fibula periosteum, and that works really well. But securing the graft to the fibula avoids any movement of the graft from front to back and makes your fixation really secure. Now that you've done that, you pass your one limb, that's the LCL limb, up under the ITB, and the popliteofibular limb comes behind the biceps. So that's a key part that you must remember, that the posterior limb has to go under the biceps as well as under the ITB. So that way you are replicating the anatomy now. I know I'm rushing a bit fast, but I have much more to talk. And this is followed by fixation with 2 screws proximally as well. Indeed, sometimes you can just do 1 screw and without any issues, you can make a central big tunnel. But if you're trying to be anatomic, it's better to do everything properly. Then the grafts are pulled anteriorly in the tibia and fixed with a screw from front to back. And that's the result of the final reconstruction. And you can see a endo button with an extendo button on the back where the ACL has been fixed. So this is roughly how a Laprade is done. For conditions in which you just want to do a Larsen, there is a different way we have described. It's called percutaneous Larsen, and this is just a 2 centimeter incision behind the fibula head. Rather than opening the whole lateral side, you can just make a tiny hole on the back, go very slow with the dissection, find the nerve, then make your fibular tunnel, pass a plastic tube which allows easy passage for the thread. Same thing on the top, you find the LCL insertion and you make a single tunnel. Pass your graft in. और एक 5 मिनट है 3-4 मिनट है and then you pass the graft, fix it proximally and distally, and that's your Larsen done through 2 centimeter incisions both proximally and distally. It's a good technique to do for most patients. There are some weird patterns that you'll see. This was a professional football player who felt a snap in the knee when he was running, and you can see it's an isolated LCL rupture. That's the LCL. If you can see, it's completely ruptured from the fibula head. Everything else was intact. So all he needed was an LCL repair, and he went back to become the, I think, ISL player of year the next year. Sometimes you only get a biceps injury. So this is a patient whose LCL is completely intact, as you can see, but the biceps on top is completely gone. So the biceps envelopes the LCL insertion. So the biceps is completely gone, and all it needs is a bicipital repair along with reinforcement using some implants. There are times when you wish you hadn't opened that knee, but this is one of the cases where everything was torn, but surprisingly the nerve was intact, and everything had to be repaired completely. Another case, everything was completely gone except for the nerve, which was still intact, and you had to repair everything very slowly and very securely. But sometimes you face with this. The central strand that you see is actually the common peroneal nerve, which is completely torn. And in such cases, you then have to do a tendon transfer. So this patient had a big arcuate avulsion and needed a screw along with a figure of eight tension band wiring to get the fibular arcuate complex reattached, fibula head reattached, along with his ligament reconstructions. Later, he had a tendon transfer and did really well. So to conclude, it's important to diagnose and manage these injuries. The key components are your popliteus, popliteofibular ligament, and LCL. But don't forget the biceps, the ITB, and CPM. There is a pretty variable injury pattern. So be prepared, and so you won't have any surprises when you open the knee after doing a cursory EUA. Thank you.
Thank you, sir. So we'll connect back to the OT. Dr. Arvind is waiting there. Dr. Arvind?
Hello. Hello.
Yeah, we can listen to you.
So can you see the picture, intra-articular picture?
Yes, Dr. Arvind.
So I have passed the PCL graft here till the margin of the tunnel. And this is the ACL graft that I have passed with whatever the remnant I kept there untouched. And this is your guide wire for your screw. That should be the posterior to the graft. So that graft should be anterior as much as possible.
Fine.
And pull karo isko. Ek minute. And I'll take the graft around 2.5 centimeter into the slow. Little bit more.
So you removed it 11 when we
till 11. Yeah, leave there only. Now, isko pakro. Isko halka tibial and give the graft. Since it is tunnel of 11 remove, so I'm taking the screw of 12-28. Okay. Yes.
The femur side.
On the femur side with इसका डायरेक्शन याद रखना बेटा. हाँ ऐसे मुझे दे दो. So just screw in on the femoral side. With little bit of tension both side of the graft, femoral side and tibial side. You can the screwing sound. This gives the sense of relief that the purchase of a screw is good. And this is coming, the tip is coming. Can you see the tip of the screw?
Yes.
Yeah. So this part is done.
What was the length of the screw?
12-28.
Okay.
Now I'll fix on the tibial side. at 90 degree of the knee flexion. तुम हट जाओ बेटा, आगे ट्रांसलेट कर लो टिबिया को. इसको पकड़ लो रवि, हमको 11 का 35 दे देना. Since graft was very tight even with 11 on the tibial side and the bone is very strong, so I am taking the same size screw on the tibial side also.
Graft is 10.5, no?
No, it was on the tibial side 11. On the femur side, it was 10.5.
Okay.
Perfect. ये लो यहाँ पे. So you can see the position of the knee. It is 90 degree flex with one assistant. इसके direction में रखो. Complete anterior translation of the tibia. Here, if bone is very hard, then sometime you have to take the same size of the screw, because many a chances if a screw is bigger, this may cut the ET bond. That happened to us one or twice. So whenever the bone is very strong, we used to take the same size of the screw for the PCL on tibial side, or maybe extra supplementation with. So, ये पकड़ो जान. और नीचे रिट्रैक्टर लगा लो, सॉफ्ट टिश्यू आ रहा है बेटा. नीचे नीचे रिट्रैक्टर. जरा स्ट्रेट वाला दोगे? हाँ नीचे. परफेक्ट. ये स्ट्रेट गाइड वायर मिलेगा. हाँ ये ठीक है, ये दो. Yeah. Now you can hear that sound again. Yeah, that's perfect. Yeah, Amado. So it's jam. Yeah. Picture. हम बाद में कर लेंगे. So give me the probe. Now you can see the position of PCL.
Yes,
perfect. Very close to the articular surface, and it is high as possible. At the same time, it's very tight. Whole knee is moving. I'm putting lot of force here. Okay. Now I'll fix the ACL also, but I want to come on the medial side. Just यहाँ focus कर दो बेटा. As we have seen in the MRI, it was complete avulsion from the femoral side. So many a time with MRI, it looks only soft tissue, but the MRI was depicting that it's the complete separation. So it's the bony piece here. That feeling was with me from very early. That's why I don't save any graft for MCL. You can see this is the bony piece. Table throw down kar do beta.
Yes.
Can you see it?
Yes, yes.
So it is the complete bony piece here that I was discussing on MRI also. So though I have taken a stitch, I have the bone and tendon Johnson also. I'll supplement with the swivel lock, but this I'll fix with a spike washer and a screw. Just for the anatomical demonstration part, here is the adductor tubercle. You can see just below that there is depression, and here is the elevation. Femoral condyle is getting up.
Can camera be slightly up?
Adductor tubercle is here.
Can camera be slightly up? Your hand is coming in between.
Beta dikha do jara. So on the medial side, this anatomy should be kept in mind all the time for MCL or MPFL. So this is the adductor tubercle.
Yes.
This is here you can see the depression, and this elevation is adductor tubercle.
Yes.
Here the MPFL groove is there. and this is the MCL completely with the epicondyle part. So this is distal to the adductor tubercle and little bit anterior to the adductor tubercle. So this is the medial epicondyle. Now give me the beat pin do beta. Beat pin load करके. Spike washer ready है. Beat pin इस पे लोड करके दो. चेक कहाँ है के वायर वाला? गाइड वायर का. डेप्थ गेज रेडी है, मुझे दे दो. So on the lateral side there is ACL tunnel also. So I direct little bit proximal. खोलो इसको बेटा, चाबी दो. 4.5 का रिमर चाहिए होगा. डेप्थ गेज रेडी रखना. डेप्थ गेज चाहिए होगा. डेप्थ गेज दे दो. इसको निकाल लो, निकाल लो. फोर 4.5 का कैंसलस स्क्रू रेडी रख लेना बेटा. तो दिस डेप्थ इज 80 आ रहा है. 80 दे दो विथ स्पाइक वॉशर. So this is the cancellous screw, partially threaded with a spike washer. इसको
कैमरा
रखो आरटी से प्रेस करके रखो रोटेटिंग के साथ. And I have done the curettage of the margin also with the curette.
Okay.
Meanwhile, in between the time I have. So this is going very strongly. You can hear the sound also of a screw purchase. So knee is in little bit of varus and 30 degree of flexion around. So this is strongly compressing. यहाँ focus करो जरा. So this is just strongly compressing over the femoral epicondyle. Now you can see it has compressed very well.
Yes.
There is hardly any movement. Now I will supplement with this swab lock also. Okay. Now you can see, choro. You can see hardly any opening is there. And the ACL भी fix करना है ना. ACL का screw दे दो बेटा.
Is there need to for supplement fixation for that MCL?
Pardon?
Is there any need to supplement that fixation for MCL?
Just for the security in the back of mind of surgeon only. The screw hold is very good. It compressing.
Yes.
It compresses the fragment very well. ये इधर आओ, एक आदमी पकड़ो इसको. ये पैर हटाओ सेवर पर से. ये पकड़ो. छोड़ दो, कुछ नहीं करो. Since PCL reconstruction was here, so that's why I'm not giving any posterior door test for the ACL. टेबल अप कर दो बेटा. डाल दो इसको, छोड़ दो. Let's see the intra-articular picture. Probe दे दो मुझे. So this is PCL. That is quite tight. ACL pull कर लो बेटा final. So it's adjustable loop. So we have advantage of making tighten the graft from the femoral side also. Now it's completely tight. You can see also. So PCL, ACL, and on the medial side hardly there is opening. You can see I cannot insulate my this probe in between tibia and femur.
Yes.
So ACL, PCL reconstruction with MCL repair. Now let's see the clinical also. There is hardly any, whole body is moving, but tibia is not moving at all. And this valgus testis is also negative. Any question, please?
Fine, fine. Any questions? Well done job, Dr. Arvind. Big round of applause for Dr. Arvind.
Thank you, sir. Light on kar do beta.
So, Dr. Arvind, we'll move to the next session because you had a lecture.
Yeah, I can give my lecture also. No problem. I am free now. Rajiv will put the swivel lock of that. So, Binay can put my lecture there on this screen, and I can give the lecture from here. Binay?
Yeah, we'll take another
Okay, we're doing
2
that.
minutes. We're doing it.
Bhushan sir, for PLR, posterolateral rotatory instability B and C, you prefer modified Larson, that is 2 femoral tunnels, or modified Laprade?
Prefer Laprade for type C. Type B depends on the patient. If it's a low demand patient,
वहाँ
it's a
screen पे क्या आ रहा है?
With 2 femoral tunnels?
Again, depends on the size of the patient. So the problem with us is that we don't
बोलो
have
ना मेरा
smaller screws than 6 millimeters, 7 millimeters. So the minimum size of the tunnel is 6 or 7 millimeters. If you don't have space on the lateral femoral condyle lateral wall to have 2 7 millimeters, which are at least 1.5 centimeters apart, a central tunnel works fine for a low demand patient. But for a high demand patient, I would try and replicate the anatomy as much as possible.
I had come across an article which says that even for type C, modified Larson with 2 femoral tunnels is equal to Laprade.
So, if you read the papers done by Laprade group, they vehemently deny it. But there are other people who say it doesn't make much difference. But it makes sense to replicate the anatomy as much as possible. So in Larson, the popliteal ligament is not replicated at all. So it's better to do a Laprade. Laprade works really well in most patients.
So, Dr. Arvind, we are ready. Are you there?
Yeah, I am ready. Next, please.
Dr. Arvind?
Yeah, I am ready. Can you hear me?
Yeah.
Yes, we can hear you.
Next slide, please.
Next slide.
Next slide.
Yeah, start.
Next slide, please. This is the test for this. So this was the case that came to me in the August 2015 with this X-ray with severe difficulty in walking. He was walking with the help of brace. He was 28-year male guy. He was from Patna only, working at Bangalore as an engineer. Next, please. So his story started. Next slide, please. Yeah. So his story started almost 2 years back in Feb when he sustained bicondylar fracture of the tibia that was fixed. This was the post X-ray immediately after some time. Next slide, please. Yeah, but even after the back. So even after the end of 1 year, he has instability. Though he don't have any pain, he has instability. So this was the post-op X-ray, the dawn second level first X-ray. So this was the final post-op X-ray. After 1 year, he has instability. So doctor suggested him for removal of the implant and the ACL reconstruction. So removal of the implant and the ACL reconstruction was done with the hamstring tendon with bioscrew both the sides. So this was the X-ray, final check X-ray after the surgery. Next, please. But his instability persisted. So after couple of months, again he went to another surgeon. He advised for your slope correction osteotomy of the tibia. So this was done in I think July 2014. There is some problem with viewing of this slide here. You can see the date written there. So this surgery was done, and after that patient again continued with the instability problem. So he went to another surgeon. This was the third surgeon that he visited. Next slide, please. And this was the X-ray after revision ACL reconstruction and the posterolateral corner reconstruction. Doctor said him that your ACL is not working, at the same time you need posterolateral reconstruction also. So this was the X-ray of February 2015. Next, please. And this is the August 2015. Patient is still walking with walker with the knee brace on. 28-year male guy, engineer, having all these problems for almost 2.5 years. So this is the X-ray. You can see the tibiofibular subluxation is there, particularly on the posterolateral side. So Bhushan sir, what should be done now?
How is his alignment, Arvind? Do we have a scanogram or something to see?
A scanogram is missing. Truly speaking, in 2015, I was not much aware of this virus or something like that for this. Just after that case, I started getting this scanogram for failed ACL.
Okay. So I would get some stress views to see if it's...
it is still unstable. First slide was anterior door is positive, grade 3, pivot shift is positive, dial test is positive. Varus stress test is positive. Valgus is fine. Posterior door is fine.
It's a failed ACL plus PLC.
It's also got a translational this thing, no?
Yes, sir. There is translation of the tibia and femur. 28-year male boy. Both the side hamstring was used. One side BPTB was used. You can see the broken guide wire in the femoral tunnel that was used for the BPTP with bioscrew. So, what is the problem with the posterolateral corner in this case, Bhushan sir? Suppose dial test is positive, it means the posterolateral corner is not working.
Yeah, if the dial test is positive, then it's not working. Was he fixed in internal rotation or was he fixed in external rotation?
No, its rotation was fine. So by seeing the X-ray, the femoral tunnel is almost non-anatomical.
Yeah.
You must be agree, Bhushan sir.
Yes, I agree.
Yeah. So non-anatomical reconstruction of posterolateral corner is very high chances of failure. At that same time, the femoral tunnel of the ACL is also non-anatomical. So two ligament non-anatomical, very high chances of the failure. So whenever revision is there, try to keep the reconstructed ligament at its anatomical position. So this was planned further for third time ACL reconstruction with revision of the posterolateral corner. Here was the problem with the graft because both the side hamstring were bone patella tendon, one side, opposite side was used, and not very much aware of quadriceps tendon that time in 2015. Now it again back with this. So that time the concept of peroneus longus was arising. Next slide, please. This was the CT scan of this patient. You can see the two screw in the femoral side, lateral femoral condyle with non-anatomically placed screw for the posterolateral tunnel. Next slide, please. And you can see the tibial back, please. You can see the tibial tunnel that was quite enlarged in this case. So next, please. Next, please. So revision was planned. the thing was with the staging. We planned for the single stage in spite of the tibial tunnel that was almost 12 to 13 millimeter was there. So we use bilateral peroneus longus. So peroneus longus gave us the diameter also, at the same time length also. One peroneus longus, quadruple peroneus longus for the revision of the ACL. The diameter was 12 for the ACL that time. So at that time we asked for the 12 millimeter diameter screws from the Arthrex guy. And from that time we have facility of that. The reamer was also called that time only. And another peroneus longus for the posterolateral corner. Next slide, please. And this is the post-op X-ray operated in September 2015. On the tibial side, ACL graft along with the screw, it was augmented with the screw also. And on the tibial side, along with the screw fixation for the posterolateral corner, that is the modified lap rod, I use single screw on the femur side, and on the tibial side, rest remain the same. Bhushan sir, comment on the check X-ray, please.
No, looks good. Now it makes sense how anterior the original tunnel was on the femur for the PLC. It was way too anterior. It's as if someone tried to replicate only the popliteus and not the LCL. And that's why it all failed. So now you got a fairly good position. The knee doesn't look that bad now.
Yeah.
How was the articular surface on the lateral side when you went?
Little bit compromised it was.
Okay. But that looks good now.
Yeah. So next slide, please. So this is the modification that I was talking about. So on the femoral side, single screw with a spike washer instead of the two screw that was demonstrated by the lap rod, and the graft get rolled in the same fashion that is there. So along with the bio screw in the tibial tunnel, the remaining graft were fixed with the spike staple also in this case. That's why a staple was there. So double fixation on the tibial side for the ACL also and for the posterolateral corner also. So next slide, please. So this was the X-ray almost after 1 year. The subluxation of the tibia femur was almost obliterated. It now absolutely normal. And lateral view also looks fine. Knee is reduced. Lateral compartment looks better. And this time patient came for the screw removal on the tibial side that was there. And at the same time patient got married also for last 3 years. Now that time he was 31, back to job, doing everything. Next slide, please. This was after removal of the screw. Next slide, please. And this is 2021, the morning time at the Bangalore. Next, can this video can run? This guy was from my village area. Initially, I used to refuse the surgery for him, but somehow I operated in with very much fear in the back of mind. But you can see the result of this patient. And next, please. And rehabilitation in this re-revision type of cases, particularly for the posterolateral, it should be slow. So we started range of motion after 1 month only and weight bearing after two months only. Next slide. Thank you.
Thank you, Dr. Arvind.
Dr. Arvind, what
Yes,
were the challenges faced in the tunnel placement, considering this was a re-revision case with all the implants in situ?
In fact, truly speaking, it was very easy because tibial tunnel was almost here. There was no problem with the tibial tunnel. Only I have to take the plate from the tibia that was there. And I made as the straightforward all the tunnel for posterolateral corner. On the femoral side, posterolateral screw side was virgin. There was nothing, previous surgery part was there. Because previous surgery was quite interior and little bit proximal. So really operating part was completely virgin. So I don't have any problem with the femoral side. Tibial ACL part, I use 12 screw with graph diameter of the 12 with extra fixation on the tibial side. So that's why I keep the rehab slow, range of motion after 1 month and the weight bearing after 2 months only.
So it was a good thing that the previous tunnel on the femur was way away from where the tunnel had to be.
Thank you, Dr. Arvind.
So we'll close this session now. Thanks, chairpersons, and we'll move to the next session. May I invite the chairpersons, Dr. VK Sinha, sir, is here.
Dr. Jasminder, just a second. Can I audible there?
Yeah, please.
For John sir, it is. Sir has to come at PARAS only after the lecture, because this case is of ACL with varus deformity medial compartment. Meanwhile, I am doing ACL reconstruction. Then sir will do the high tibial osteotomy in this case. Okay, so it's a next case of ACL with HTO.
The chairpersons for the next session, Dr. VK Sinha, sir, Dr. Ranjit Singh, sir, Dr. Praveen, sir, Dr. Rajeev Ranjan, sir. And the next talk is by Dr. John, sir. It is on evaluation of HTO. Evolution of HTO, sorry.
So I welcome Dr. John for his wonderful lecture on HTO. A few years back or some time back, there was TKR, and TKR. Now there is another wave of HTO, and he is one of the best person to say final words on this subject. So I invite Dr. John. Dr. John, please.
Thank you, Dr. Sinha and Dr. Praveen. I'm just going to talk very briefly about the evolution of HTO. Later, I think when we look at malalignment, until recently or until the turn of the millennium, there's very little evidence to show that malalignment caused problems. There were a couple of Swedish papers which showed that if you had early osteoarthritis with varus, there was a chance that it progressed a little quicker. But it was really around 2001 that the first paper directly correlating malalignment with osteoarthritis and progress of the disease was written by Sharma et al. When they looked at 237 patients, and they found that if you had a varus alignment, the odds for radiological progression increased fourfold. There was another paper from the Japanese authors, Miyazaki et al., which looked at varus with dynamic loading. That means there was a varus thrust when they walked, and they found that increased the risk of progression. And another paper in 2013, more recent paper by Felsen et al., which showed that a frontal plane deformity of more than 3 degrees leads to osteoarthritis and should be corrected. And they found that if you had 4 degrees of deformity, there was a 3 times risk of osteoarthritis. Now, high tibial osteotomy has a long history dating back to the time of Folkman, but it was really in the 1950s and 60s. There were a few papers which came out on it, and this one by Coventry in 1965, which made this procedure quite popular. And this was the paper in JBJS by Coventry based on the osteotomy titled Osteotomy of the Upper Portion of the Tibia for Degenerative Arthritis of the Knee. Now, unfortunately, subsequently, a number of people who were doing osteotomies started looking at their results more sort of carefully in terms of how long it lasted. And when you looked at Coventry's results, which were very good at 5 years, by 10 years, this successful result came down from 87% to 69%. Ritter and Fechtman, who at 2 years had a 95% good result, was down to 58% at 10 years. And Hernigu et al. In France, who did open wedge osteotomies, their 5-year results were 90%, but by 10 years, it was down to 45%. This was the subsequent paper by Coventry et al., where they looked at a number of cases over a long-term period, 87 cases, which they looked at long-term and found that the results deteriorated with time. Similarly, Hernigu in 87 published his results and found that the 5-year results were pretty good, but by 10 years, the results were poor. Similarly, there were open wedge osteotomies described by Pudu with an interpositional plate, which is still used. And also you have the gradual correction using the distraction techniques of Ilizarov. So this was the paper by Hernigu, which again came out in 87. The Mackay dome osteotomy was the other method of osteotomy. Mackay never published it himself, but the technique was published by other authors. And basically it was a curved osteotomy in the upper tibia just above the tibial tubercle. And this was could give you more correction, and the use of the external fixator allowed a certain amount of adjustment to your corrections. Okay, so there were some advantages of the Mackay dome, which gave you better and more correction and the adjustability with the external fixator. And you had the ability to tighten the MCL without affecting the patella tendon. However, you had the problem of the external fixator, which is something which people don't like sticking out of their bodies. And another thing was that if you looked at the dome, it was pointed distally. So your cora was actually further away from the knee joint than it would be if the dome was the other way. Now, looking at these bad results, people kind of tried to analyze which patients had bad results and why. And this study by Berman et al. Looked at 39 osteotomies, out of which 10 had poor results. And they found that really the indication for many of these was not correct. So 4 of them were for diffuse degenerative arthritis. That means the opposite compartment, the lateral compartment, was already involved. 2 had inflammatory arthritis, that's rheumatoid, etc., which it didn't do well for. 1 had a prior septic arthritis, and 1 had severe post-traumatic deformity. This other study by Chilag et al. Looked at the quality of surgical technique. So they looked at 30 osteotomies with a 51-month follow-up. 43% were satisfactory, 57% were unsatisfactory. And out of the 17 poor results, 10 had major technical errors of either over, under correction, or joint penetration. But they found that all the 13 that had good results really were done technically correct. So therefore, for the HTO to be successful, you have to have the right indication in the right patient. You need to do the correct amount of correction. And of course, the technique and soft tissue consideration must all be taken into consideration before you do your surgery. And now we all talk about the ideal candidate, which is more mythological than actually exists. Very rarely do you get the ideal patient to do it. But we do extend the indications to a lot of things. But remember the things I talked about, like rheumatoid arthritis, or where the lateral compartment is already involved, those would really be contraindications. A bit of patellofemoral arthritis is not really a contraindication. Now, Joe Pelly in 1994 looked more closely at osteotomy, and he did a lot for the way we plan our osteotomies in terms of the level of deformity, whether the joint line was involved or not, the sagittal plane also, which is something we didn't look at all, and also ligamentous laxity. So he devised this reverse dome osteotomy, which we will talk about a little later. The questions that were there in everyone's mind was 5 to 7 years really the endpoint. What are the inherent limitations? And is TKR after HTO really a problem? And I think when we look at osteotomies done with better techniques and better indications, the results are much better. And Naudi et al. In a 10 to 22 year follow-up had 80% survivalship at 10 years. So much better survivalship. And they found that patients who were younger or who did not have or had a good range of motion were the ones that did better. Sprenger et al. Similarly, 76 osteotomies. These were closing wedge with internal fixation. 90% survivorship at 10 years. And similarly, you have a number of papers from Asia which have results going as far as 20 years, doing pretty well. Although one of the more prime things were most of them had precise restoration of the valgus angle. What about TKR after HTO? I think this paper by Pavesi et al. In 86 really put the cat among the pigeons, and they showed a high rate of radiological loosening and high revision rates with TKR done after an HTO. So again, that became an issue for people. So they said you shouldn't do an HTO because after that, a TKR would be difficult. However, there have been papers, this was by Ritter et al., which looked at 39 bilateral TKRs where one side the patient had an HTO and the other side they had not. And they found no difference in knee scores, functional scores, or the X-rays in the patients who either had a HTO or not. Okay, similarly, there were other papers by Karat Botsos et al., which showed that really after an HTO, you were still able to do a satisfactory total knee replacement. Now, what was the problems with the lateral closing wedge osteotomy for a TKR? One was the loss of bone stock because you were excising a bit of bone. The second was scars and adhesions because your incision was slightly lateral and in the opposite direction of where you were going to do your total hip replacement incision. And also there was an alteration in the mechanical axis because if you're doing your osteotomy away from the cora, you need to translate. So this led to the lateralization of the tibial peg. So here's an example. This is not one of my own cases, but from the internet, where they showed that when you do a TKR after an HTO, you end up with the peg being more laterally. Okay, so if you want to get the axis right, the peg has to be much more laterally. Okay, now the other problem with the closed wedge osteotomy was the lesions of the peroneal nerve. Now these were not all frank foot drops, but if you did EMG studies, there was a fairly high incidence of abnormalities in the common peroneal nerve after a lateral closing wedge osteotomy. The other thing was the assessment of your correction because this 1 millimeter equals to 10 degrees was based on an average side of the tibia, proximal tibia being 56 millimeters in width. Okay, it's only then that 1 degree will be equal to 1 millimeter when you're doing your correction. Okay, now the dome osteotomy, which was popularized by Dropelli, was this smiling dome where the dome was in the opposite direction. And what it did was it brought the cora closer because you had a dome like this and the cora was closer to the joint line. So the amount of translation you needed to have was less. And it was very simple to do because we did a few of these earlier where we just draw this kind of arc with the center at the knee joint. And then you did your osteotomy through that region, use the Elizarov to correct it. And you could adjust your corrections if you needed to. And these did quite well. So this patient who did very well, and this was him about a year and a half after the osteotomy. And then he came back 10 years later. And his knee, which was, we did the osteotomy, was still doing well. While the opposite side, which was okay at that time, had developed quite frank osteoarthritis, had varus, and even had a fixed flexion deformity. And I felt it was too late for an HTO, but he really insisted on us doing the same thing, even though, as you can see, he had a significant fixed flexion deformity by then. So we ended up doing an osteotomy for him with a ring extending above the knee to correct his flexion deformity. And that's what we ended up with. He still hasn't come back to us now. So I don't know if he's still okay or not, which is now more than
X-ray was done. It was osteoarthritis, both knee. Left more than right. This is the X-ray. Pre-op X-rays done in January 2017. So, treatment options. What do you think here? This is the pre-op 77-year-old female, bilateral knee. Treatment options. What we think first? Take care, obviously. But what we think, the patient may not. So what if the patient says no? Conservative. She was already on conservative treatment for the last 5 years. So she opted for high tibial osteotomy. This was the immediate post-op X-rays. First left side was done in January 17. 2 weeks time. This is 6 weeks. You can see good healing of the osteotomy side. This is a 6-month follow-up. These are clinical pictures at 6 months. At this time, she was so happy with the osteo that she actually opted for the other side also. So she came for the surgery for the other side, and again she opted for the HTO rather than TKR. Another side was done in August. This is the 4-month follow-up time. Clinical pictures. This is a video of the same lady after 4 months of the opposite side. She was quite happy and she was doing well. 77-year-old lady, she can manage to walk pain-free. Now this is 5-year follow-up. She came last year. This is her clinical picture. And now she is 82 and she can walk pain-free, but now she is using this cane for the support also. But she is still happy with the surgery, and this is just a message. We can do the HTO in the older patients also, rather than the usual indication in 5th or 6th decade of the life. Now coming to case 2, she was 50-year-old lady, came to us in January 2019, bilateral knee pain, again left more than right for the last 2 years. This was the X-ray. So first, the left side was planned. You can see the varus, gross varus, and mainly the medial compartment osteoarthritis in scanogram. So we opted for the high tibial osteotomy, left side first. This was our clinical picture. In this case, we have done something different. So we opened the joint, removed the osteophytes, and then proceed for the HTO. Usual manner, cut in one plane, another plane. It is spreaded and check it on the C-arm. Laminized spreader is applied and the plate was fixed. In this case, what we did, we just put all the osteophytes in the osteotomy site, and we have seen the healing was quite faster rather and much better than the usually what we do. These are intra-op assessments we done under the C-arm. This is the final picture. Immediate post-op. This is a 10 weeks time. You can see there is good consolidation and hardly you can see any scar in the osteotomy site. Healing was very good. This is 6-month follow-up. It's a 3-year follow-up. After 3 years, patient came for the another side, but this time you can see it's a tri-compartment syndrome. So we opted for TKR in this side. TKR was done. Now in February 2000, 23 last to last month, sorry. She came for the follow-up. Almost 4 years has gone. This is her clinical. She is walking pain-free and she is satisfied on the both sides. Means she is even happy with the STO and TKR both. Thank you.
Thanks, Dr. Ratnesh Singh, for your excellent presentation. And really, it was very good to know that in 77-year-old lady also, we can give good result if cases are well selected. Yes, because she does not accept arthroplasty. Yes. So STO is a better option in those cases.
Yeah, if the other compartments are not involved so much, then STO can be done even in 70 years.
Do you think STO is beneficial when there is patellofemoral osteoarthritis mainly, predominantly?
Some patellofemoral osteoarthritis can be acceptable, even in this case it was present.
Okay, that's nice.
Ideal candidate is very tough to get.
Yes, that's. Thank you once again. Our next speaker is Dr. Manish Kumar from IGIMS, and he is frequently doing all the arthroscopic procedures, and he will present his cases for HTO with ACL reconstruction. HTO with ACL reconstruction.
Once again, before I begin, PGs, SRs, none. Okay. So I'll give you a scenario and let's see what we can do. Now here's a case of 40 years male, height 177 centimeters, weight 88, BMI 28.08. Instability, history of twist injury when he was 18 years old. He underwent a ACL reconstruction about 14 years after the injury. Somewhere in Nepal. Okay. Now he had an injury again after 1 month of ACL reconstruction. And there was a recurrence of instability. The patient presented to us 7 years after the previous ACL. So I am saying instability of 22 years because he had an interval of only 1 month when he underwent ACL reconstruction, which failed because of re-injury. So from here, my question to the house, how do we proceed? Any feedback? Anyone? Dr. Ratnesh? Any feedback from your side? Okay, you need an X-ray. So here's an X-ray. Now, I had not seen an implant of this type earlier. Maybe I'm new to this field. So this was the implant. You can see a medial side osteoarthritis because the patient was 40 years when he presented to us, and he had an injury when he was only 18 years old. So this is the X-ray of the patient. Anything else you want? MRI. Before MRI, I'll give you an alignment view. So the alignment view clearly suggests that is a medial compartment osteoarthritis. You can see a varus deformity of the knee. Now from here. Sir.
It's obvious is significantly varus, is loading the medial compartment, is already got medial compartment arthritis, and is ACL deficient.
Right.
So is either for a slope changing osteotomy if the lateral view suggests that, or for a ACL plus HTO.
Right, sir.
40.
He's only 40 years.
हम तो कर सकते हैं, but patient का क्या? 40 में he will only survive for 10 years.
Sir, 15 साल तक यूजफुल लाइफ रहेगा, फिर देखा जाएगा, बार-बार सर्जरी होगी. Okay.
The MRI picture. Next MRI, the axial view. Now we calculated the mechanical axis and the different angles. The LDFA was 90 degrees, MPTA was 83, and the posterior tibial slope was 12 degrees. Now from here, what do we do now? ACL plus HTO? Okay. So first of all, the problem was the implants which were inside. Removal of these things were then the foreign bodies, all the non-absorbed metals, they were removed. And the patient underwent an HTO procedure. This was the HTO which was done on 19th of August 21. And as you can see, the alignment, it is quite good now. Now, I differed in this case. I did not go for an ACL reconstruction at the same setting because I saw the history of the patient. He was suffering for last 22 years or somewhere. The luck was not with him. So I thought if the soft tissue was also not good, the wound or the skin condition on the medial side was also not good. So I just tried a HTO first and then thought what to do next time. So this was the alignment. I think it's a good one. And then the patient was planned for ACL reconstruction. We saw on examination the different findings. The LET, we did an ACL reconstruction along the LET because the pivot shift was almost grade 2-3. So on examination and anesthesia, what we found, so this is the audio band kar denge. Hello, audio. So this was the pivot shift. So the intra-op status after the ACL reconstruction, a good ACL reconstruction was performed. With the stump sparing. At the same time, we performed an LET. The graft was passed, the IT band graft. And what we are doing at our center, we are fixing this LET with a staple, not a screw. So that, immediately after the surgery, you can see a good stable knee was achieved. So what I want to convey is this is the POD5. Peroneus graft was taken. Post-operatively, the status of the patient, a nice squat. The patient is able to squat nicely. And if you can see, very good and stable knee, very good alignment. So my take-home message, we should not be afraid of doing something. We should always try to conserve the knee first and only then think of a arthroplasty. Thank you.
Thank you, Dr. Manish. Our next speaker is Dr. Bhushan Sabnis, sir. His topic is planning and technique of HTO.
Dr. Manish, you planned LET because it was pivot grade 3 with laxity or reason was different? LET.
Grade 3.
I think more than revision, pivot is more important. More than 3 days. Might be a revision surgery because low pivot will not do LET.
Well, hello all again. This is slide and go as quick as I can. So we're talking about preoperative planning of osteotomies, mainly HTO, and the surgical steps of the arterial osteotomy. You're going to see Dr. John in action in a few minutes. So it will all make sense, hopefully, whatever you're seeing this now. So your aim is to get the alignment perfect so that the weight bearing axis passes to the center of the joint. And that's what you're going to do. The osteotomy as a surgery is a very powerful procedure. It's a very versatile tool. You can change in various planes. You can change the coronal plane, the sagittal plane, or rotational plane alignment of a patient. You can alter the slope of the tibia to compensate for ACL, PCL deficiency. You can unload the damaged area of the knee joint. You can retension some of the ligaments. You can improve range of motion, and you can even use it as an adjunct for other procedures, even when there is no arthritis. So there are a lot of things you can do, but what's important to understand is which bone and what correction you're going to do. So this has been a problem for almost more than 200 years for the world about what to do with this Leaning Tower of Pisa, and an osteotomy is the ideal solution for that if it works for this. So it's important to understand the deformity. That means analyze the deformity and then what correction can be done or what is required for this. A couple of books which are essential if you're interested in osteotomies and realignment procedures is the Kenneth Krakow book on analysis of axial deformity of the knee, the Drawer Palace textbook on principles of deformity correction, and the AO Foundation book on osteotomies around the knee. And all of these make a wonderful reading if you're interested in the axis. So the first step before you do anything is to get a good scanogram. So scanogram is a standing X-ray of a patient all the way down from the waist to the feet. And if it's done properly with patella facing forward without any rotation, which is calibrated and with adjusted pelvic obliquity, then you can decide what you want to do. TraumaCAD planning was a fantastic device, but suddenly they raised the prices by about 100%. So most of us have stopped using it. Now I use a Bone Ninja or another device called as OsteoMaster, which are software planning techniques for your osteotomies. So this is how a scanogram looks. So you can easily see the weight-bearing axis of the joint of the body from center of the hip to center of the ankles, and then quantify the deformity. So the point at which that axis divides the tibial plateau is called as Mikulicz point and is graded from 0 to 100 from medial to lateral side. Obviously in this patient, it's in -100 or -85. So that's a pretty severe deformity as such. The one on the other side is a pretty straightforward, about Mikulicz point about 20 or 30. Those of you who know me will know my desktop looks something like this all the time. So it's riddled with all scanograms of all HTOs that I tend to do. So you need to understand the basic axis of the knee joint. So you have the anatomical axis of the femur, which is essentially the diaphyseal axis. You have the mechanical axis, which goes from the center of the hip to center of the knee joint. And you have the mechanical or anatomical axis of the tibia, which is for all practical purposes the same. Now you measure the angle between the femoral axis, now we're talking mechanical axis, and the tibial axis, and that forms the HKA axis or the HKA angle, which is the actual varus deformity in the knee joint. Now this is one image that you need to remember if you ever want to do HTO. And the two angles which are important for you are the MPTA and LDFA, which are these two. So MPTA is medial proximal tibial angle, and the LDFA is the MLDFA. That means the mechanical axis of femur is considered here, and the lateral distal femoral angle, and both are around 87 degrees. Those are the values which are important. Now let's forget about sagittal plane. Today we're talking more about the anatomical plane. So if you look at the weight bearing axis bisecting the tibial plateau on that image, I don't know whether you can see it properly, it's going just in the valgus side as compared to what it was before. Now this is the only photograph I could find of Fujisawa anywhere. So funny enough, I've seen a lot of old Japanese people being projected as Fujisawa, but this is the real Fujisawa. And his definition of Fujisawa point has, I won't say bothered, but has confused everyone for quite some time. We no longer follow the Fujisawa point of 62.5 or 67.5 or whatever you want to define it as. We like to go in the valgus area of the joint, normally the lateral tibial spine or the downsloping part of the lateral tibial spine, which is corresponding to about 57 to 60%, and that is the right axis for correction. Now, important to know that you spend your time on your planning of osteotomy based on your knowledge. So the simplest way you can do it based on scanogram is a Miniachi technique, where you draw the weight bearing axis of the body, which is from center of the hip to center of the ankle. Now let's take a pathological case. So center of the hip to center of the ankle, that's the mechanical axis drawn. Now you want the axis to pass through the center of the knee joint, slightly more on the valgus side. So I've bisected the tibia to about 60%. So we're going in the 60% zone now. Now you draw another line joining these 2 points, exactly where the osteotomy, I don't know whether you can see it properly or not. So where your osteotomy hinge point is going to be, and that angle is called as the angle alpha, theta, or x, whatever you want to call it. And the same angle is now subtended or drawn on the tibial side, and that's the amount of opening one must do at the proximal level of tibia. The dictate that 1 millimeter opening corresponds to 1 degree doesn't hold true. There's something called as law of cosines, and that only applies when the width of the osteotomy is 57 millimeters. So you should not be using that law regularly, but it can be a rough estimate of how much you're going to do. So this is how a deformity analysis is performed. So you find out the angles around the knee joint. So if there's a varus deformity, you find out where the varus lies. If it's a valgus deformity, you find where the valgus lies, and based on that, you decide correction. You do not say that femoral deformity always causes valgus and tibial deformity always causes varus. So you need to find out exactly where your deformity lies. You can do correction for early disease or for severe disease. So for grade 2 or grade 4 arthritis, you can do correction. And when you're doing it for a more severe disease, your correction is much more significant as compared to when you're doing it for a less severe disease. You can play with the slope. So when you are playing with the slope, you want to flatten the slope or reduce the slope for ACL deficient knees, and you want to increase the slope for PCL deficient knees. That's all you need to remember. So based on what you're dealing with, you can play with the slope. I won't go into details of that. That's slightly more complicated. So this patient had a PCL deficiency. So in this patient, we increase the slope purposely rather than flattening the slope. So in such patients, it works quite well. There's another plane called transverse plane or the rotational plane for patellar instability. I have a lecture tomorrow on that. I'll talk to you about that. But this is what is required. This is called as a distal femoral derotation osteotomy of, along with varization. So it's slightly more complex field. Now, 90 out of 100 times your varus deformity will be in the tibia. So when you measure the angles, I know you can't see it that clearly, but that MPTA is 82, normal is 87. So your deformity correction is going to be in the tibia. Again, 90 out of 100 times the valgus deformity lies in femur. So that MLDFA value is 85, which is slightly less. So that needs to be corrected to a normal value. So it's a distal femoral osteotomy is required. But sometimes there is a valgus deformity coming from tibia as well. So this patient required a closing wedge, and sometimes a varus deformity comes from the femur as well. So this patient required a closing wedge lateral distal femoral osteotomy to get the deformity corrected. So you need to understand that deformity can be contributed both from the femur and the tibia, or isolated from the femur or tibia. So this is another patient with a very severe valgus, as you can see. And if you correct everything in one bone, you're going to get a very oblique joint line. There's a good paper by Babis, which is quoted multiple times, which talks about the joint line obliquity. So if your joint line obliquity is more than 7 degrees, you're essentially screwed. The joint line is so oblique that the patient will never be comfortable. Every time the patient walks, the femur will be slipping on the tibia, and you will get a significant problem in these patients. So in such patients, you can do a double osteotomy. So you can do a femoral osteotomy as well as tibial osteotomy to correct the deformity, but to keep the joint line flat. It's a very important thing to understand. Another example, you can see the values, your MPT and LDFA both are slightly deranged. So you do both femoral as well as tibial osteotomy to correct the deformity as such. You can also do it for patients who have a medial meniscus bucket handle tear without any arthritis, but with varus alignment, because it will never heal in varus alignment. You can also do it for transplants. You can do it when you do a microfracture AC or MACI on the medial femoral condyle. You can do it for SPONG conditions. You can do it for ligament reconstructions. So it's important to know that rather than doing a complex knee replacement, you might be able to get away with an osteotomy in most patients who are not having bicompartmental or tricompartmental arthritis. Dr. John talked about an ideal candidate.
The only important part here I would consider is a non-smoker and a well-motivated patient. Everything else can be managed by osteotomy, in my opinion. This is generally how a standard osteotomy gives you a picture. So you can have an early disease or a severe disease, but not with subluxation. So there's something completely wrong about sublux knees, where you need a different kind of operation to correct the deformity and get the alignment sorted. So just a quick case, someone, a typical 45-year-old lady with a typical varus MCOA, does the planned correction, and that's her 6 weeks from surgery, walking independently without any issues, with almost full range of motion in the knee, no swelling, and able to march. This is a very important test that I do in clinic. If someone is able to march on spot, that means they don't have much problem in the knee, and the core and the quads both are working fine. So that's generally how I would plan my osteotomies as such. So a quick go through surgical steps for the process. This is now the Bone Ninja software, which allows you to plan the surgery on screen before you even go in theater. So that's the planned correction that you're going to do. Now, before you start the surgery, on table you mark your landmarks. But before that, you clinically assess whether the deformity is correctable or not. The reason you do that is because this will decide how much release you're going to do for your MCL, because MCL release is a must for correcting the deformity. So let's go through a quick video. So a standard medial longitudinal incision, nothing fancy about it. You need about 4 centimeter incision on the medial side of the knee, midway between anterior and posterior side of the tibia. Again, everybody has a different preference. People do oblique incisions, which are absolutely fine. It depends on what your company is releasing the medial side and creating a window for your surgery. So what I do, again, this is what I do, everyone has a different way, is I make a L-shaped cut, as you can see, on the proximal medial tibia. So you can see the vertical limb, which is just next to the medial end of the patellar tendon, and a horizontal limb of the L, which is about 1.5 centimeters from the joint line. So I'm trying to avoid damaging the deep MCL, but I'm releasing everything on the medial side. So almost this is a subperiosteal dissection. We are all have done trauma, so we know what subperiosteal dissection is. So I'm just using my cautery and peeling off the whole of the pes fascia. And after a few minutes, you start seeing the MCL. You have to release the MCL pretty bravely. And believe me, even if you release the MCL completely, I'm talking of superficial MCL, the knee doesn't become unstable. It gives you a perfect view of your surgical site without any issues as such. So that's your MCL. You see how lax it is? Now I'm releasing the remaining MCL as well. So that's completely gone now. So that MCL is completely cleared. So that's what is required to achieve your medial release. Now the key part of the surgery is the posterior dissection, or putting a blunt humor on the back. This is an important component. It's a curved osteotome. It's a curved periosteum elevator which goes behind the tibia, and you should go all the way and hit the proximal fibula when you do this. So if you go all the way and hit the proximal fibula, then you are more or less certain that you're not going to damage anything on the back of the knee joint. That's a radiolucent curved homen, which is blunt, and that goes and protects everything on the back. Now you make sure your position is fine for the plate that you're putting. Next is a pretty straightforward thing. Once you're done the dissection, all you need to do is pass 2 guide wires, as you can see here. So your guide wires have to be starting about 3.5 to 4 centimeters from the medial end of the tibia, aiming for the fibula head, as you can see. Now, sometimes the fibula head is quite high. So fibula head as a landmark is not a good point. So you should be at least 1.5 centimeters from the lateral tibial plateau to get a sufficient purchase. So those are the guide wires passed. As you can see, you're confirmed your position is quite good. And that's your osteotomy done. So you always go distal to the guide wires because you don't want to veer into the joint. And you are skirting the guide wire, kissing the guide wires as you go in all the way to the lateral side. And you take an X-ray to make sure that your blade is perfectly parallel to the guide wires and you're stopping well short of the lateral cortex by about 1 centimeter or so.
So once you've done that, you do what is called as proximal biplanar osteotomy. This is about 110 degrees to the original osteotomy, and this is going under the patellar tendon. So there is a small homon which is protecting the patellar tendon, and that's the plane of the transverse osteotomy, and that's the plane of the biplanar osteotomy. It's important to do biplanar osteotomy so you can get sufficient purchase area for the plate to fix. So once you've done all of that, that's how your osteotomy will look. Now, and of course, this one different patient because you can see it's the other side. But once you're done this osteotomy, you will be able to stack in what is called a stacking of osteotomes. So you can pack in osteotomes very gradually so that you are able to open the osteotomy gradually. So you put 2 osteotomes, then third in the middle, then fourth between the second and third, and gradually tap it with while someone is protecting the hinge. Once you are done that, you will be able to see something like this, where you have created a nice wedge of area, and when you try and open and close it with a laminar spreader, your hinge is intact. So I do this for every patient that I do H2 on. Sometimes I'm not very sure of my hinge, and I put a K-wire on the side. That's called as a hinge protecting wire, and that works really well because then you can put a screw on as well as on that wire. Now this is a good video. So the first one. Once you're done the osteotomy, you won't see the osteotomy cut because it's done very well. But then just moving the leg, you can see the osteotomy opening and closing. I hope that's making sense to most of you. This is followed by opening the osteotomy to the predetermined cut. So in this patient, it was 8 millimeters. So that's 8 millimeters in the posterior cortex and 5 millimeters in the proximal cortex. It's never a rectangle. It's always a trapezoid. So the posterior opening is always more as compared to the medial opening. Otherwise, the slope will change drastically. And then you assess the alignment of the patient using a long metal rod. I don't like to use a cautery wire because that's not a very rigid structure. So I like to use a stout metal rod going from center of hip to center of your ankle and find where I've got the deformity correction to. So this is slightly less than what I wanted. So I've increased the correction very slightly, and once I'm happy that I'm perfectly in the middle of the, on the tip of the lateral tibial spine, which is corresponding to about 57 to 60%, I'm more than happy now to accept this as the correction that I want to do. All that is left now is fixing the plate onto the bone. Now the plate is a T plate, is a Tomofix variant from Indian company. Now fixation of the 3 proximal screws is done first, followed by fixation of a cortical screw in the first hole distally to get the plate molded onto the bone, and then fixation with remaining screws. So it's just like a normal plating technique that is done. So when you do that, you get a nicely fixed osteotomy, fixed with 4 screws proximally, 4 screws distally. All of them are locking screws. So you got a very stable construct where you can start weight bearing the next day of surgery without any issues. You can put bone graft in if you want, but it's important to understand that your fixation has to be very strong if you're weight bearing early. I think since last 7 years, I've been allowing patients to weight bear almost immediately now without any issues as such. So that's the same lady I talked about. That's how the X-ray looks, and that's her walking. I know she looks similar to the one that I showed before, but it's a different patient. Again, 6 weeks. This sort of a standard thing. I make them walk from out to in. I make them sit, move the knee up and down, and then ask them to sit cross-legged if they can. So this is a standard thing at 6 weeks. So in 6 weeks, you should get patients walking independently, comfortably with complete quads activation and being able to do most of their normal activities regularly. For a working person, I tell them 6 weeks, you can go back to work and driving also. So finally, this is how the osteotomy goes. 2 K-wires which are going from medial to lateral, aiming for the fibula head tip or 1.5 centimeters from the lateral joint line. You make your cuts, you stack your osteotomes to open the cut, make sure the alignment is perfect where you want it to be. Then you put a plate in and you fix it proximally and distally to get your osteotomy fixed. However, it's very easy to overcorrect this. Now, this is a patient referred by someone to me. If you look at the overcorrection that's happened, and if you look at the joint line is massively oblique. The weight bearing axis is around 90%. It should have been at 60%. So this patient required a revision, whether I had to undo everything. So I did a closing wedge osteotomy of the open wedge done before and fixed it with a screw laterally along with a plate on the medial side to give an acceptable correction, and she did really well. So it's very easy to overcorrect. That's why you need to assess on table despite doing everything that you have done in preoperative planning. So ultimately, it's a very, very good option for joint preservation of the knee joint. Not everyone with osteoarthritis is for TKR, since not every TKR is happy. But HTO is a good option, will give easily 10, 15, maybe 20 years to young patients who want to stay active. I allow my patients to run after HTO. There is no restriction on them. I allow them to do hard labor also. I think there is no change in the results of TKR after a well-performed medial opening wedge osteotomy. The modern fixation techniques, the Tomofix or variants of Tomofix work really well with excellent results that can be achieved. Thank you.
Thank you, Dr. Saab. Thank you very much for your very good and excellent paper, giving all the details of the HTO. Our next speaker is Dr. Arvind Gupta, and he will be speaking online from the PARAS Hospital. Dr. Arvind Gupta, are you ready?
Arvind?
Connect to Dr. Arvind Gupta.
OT mein connect.
So when do you put a hinge supporting screw?
So honestly speaking, I've started to put hinge protection screw for every patient now for last 2 years.
Any reason?
No, so I had 2 patients who had a missed hinge fracture, so which wasn't visible on table. When they started weight bearing, they complained of lateral pain. I did a CT scan. There's a complete hinge break, which wasn't seen on X-ray. So if you are more or less certain during surgery that you don't need it, you don't put it. But there's no harm done by putting one extra screw laterally. So I started putting it for almost every patient now because I like them to weight bear immediately. So the guide wire starts at the level of semi-T. So when you do the release on the medial side, it's about a couple of 1.5 centimeters from the tibial tubercle for most patients. Now, we don't talk of centimeters in Indian population because all of these criteria of 3.5 centimeters were designed for Caucasians. So if you look at an Indian patient, go distal to the tibial tubercle where the semi-T is, just mark that level that normally corresponds to your medial starting point for the osteotomy. Yeah, just pause. So semi-T gracilis ke beech mein is ideal.
So how much valgus you actually aim for?
So I aim for Michaelis point going to 57 to 60%. So I'm expecting 3 to 5 degrees of valgus.
So another question is like regarding all your assessment starts with standing or weight bearing.
Has to be. Yes.
But while you are doing, you are assessing on, lying down position. That's non-weight bearing. So how do you correlate that?
That's very clever. So essentially, there is no way of replicating a standing position when the patient is lying down. So what you do is push the knee from the lateral side when you have corrected the varus. So there is a paper by a Korean group which talks about giving 55 newtons of force from the lateral side to emulate or simulate a weight bearing status. I don't think that's a very right way of doing it because body weight is different for everyone. But if you get a correction in the valgus zone, even if that changes by 5% or 10%, it won't make any difference. As long as the weight bearing axis is in valgus with good medial opening, you should be happy.
What would be your indication for bone grafting?
So anything about 10 millimeters of opening, I bone graft normally. I use allograft. I don't use autologous graft, but it works quite well.
Do you repair MCL which you erased?
No. Leave the MCL like that. So MCL falls back and scars exactly where it is in a lengthened position. If you start repairing the MCL, then you're going to have severe pain on the medial side. If you don't release the MCL, you'll surely get a hinge fracture or a Takeuchi type 3 fracture, which is going in the joint. So MCL has to be released, otherwise it doesn't work.
Excuse me, sir. So you have talked about the flattening of the slope in case of ACL. So how to calculate that concept? How much to flatten?
So there is a formula for that, but roughly speaking, every 2 millimeter opening corresponds to 1 degree. So if you change the slope, the difference between the posterior opening and the anterior opening, if it's more than 2 millimeters, you are changing the slope by 1 degree.
Like if that is ACL deficient knee and we are doing the HTO that time, how much to correct the slope? Means how much to flatten that one, sir?
So you want to go in the zone of normalcy. The normal slope is between 3 to 7 degrees. Acceptable slope is up to 10 degrees. If you use the PTA axis, the proximal tibial anatomical axis way of measurement of slope, if you use that technique, I'm sorry if I'm not making sense to you, but there are various ways of measuring slope. The standardized technique is called PTA. So if you use the proximal tibial anatomical axis technique, then you have the slope between 3 to 7 degrees on the lateral side, 3 to 7 degrees on the medial side and 3 to 9 degrees on the lateral side. So depending on what slope you have, suppose a patient has a slope of 12 degrees or 13 degrees, then you can flatten the slope. But if you're doing a revision ACL and the slope is about 8 degrees, you can still do a slight correction of slope toward 5 degrees. Now this 2-3 degrees depends on the variation of correction in the posterior and anterior plane. So I told you have to do a trapezoidal cut. So if you make a trapezoidal cut like that, that's anterior, that's posterior, then you are flattening the slope more. If you have a rectangular, you are increasing the slope by about 1 or 2 degrees.
His question was mainly for my case. He had a problem. So could we manage only by slope correction?
Yes. For a low demand patient, you don't need a revision ACL or
Dr.
PCL.
Manish, we will switch to next, please.
Okay. Thank you.
Dr.
Thank you,
Arvind,
sir.
are you ready in OT?
Yeah, I'm ready.
Dr. Arvind?
Yeah, I'm ready.
Yeah, okay.
Yeah, I'm
we
ready
are
here.
running your presentation.
Yeah, I'm ready here.
Okay.
After that, Dr. Rajkumar should be ready for his presentation.
Vinay,
yeah, it's displayed here. Is it displaying there in the OT also? The presentation is on here. Dr. Arvind, are you with us?
I'm ready here. I'm ready here.
Okay, so can you see your presentation?
Yeah, it's a little bit blurred, but it's fine. It's a little bit blurred, but it's fine for me.
Yeah,
No
please,
problem.
please start it. Thank you.
So this is 50 year female having history of pain in the knee for last 1 year. And this pain get aggravated 3 months back. And it is so much severe that she cannot walk without help of walker or any stick. Next, please. So this was the escultogram of this patient. So varus is very obvious. So Bhushan sir. Any medial side pain that get aggravated without any very strong history of significant trauma, and patient is having so much difficulty that she or he cannot walk. And on examination, flexion more than 90 degrees, painful with medial joint line tenderness is there. So what's come into your mind?
So this patient is having
Bhushan, sir?
medial discomfort. And yeah, can you hear me?
Yeah.
So this patient is having medial knee pain along with pain in deep flexion, you said.
Yeah.
Okay, so I'm looking at the scanogram. I'm looking at moderate varus. So I would be thinking of a medial overload along with a possible medial meniscus tear and possibly a mucoid ACL degeneration or ACL tear in the patient.
So 58-year male with medial compartment osteoarthritis, that is very obvious in the X-ray. Did you ask for MRI?
Yeah, of course. So it can be a root tear also from what you said.
Okay, perfect. So next slide, please. This is the osteometer that says there is varus deformity of 10 degree, 11 degree. Next slide, please. So MRI was asked. And this is the medial meniscus root tear was here. So along with the medial compartment osteoarthritis with medial meniscus root tear. So how many of you will go for medial meniscus root repair with HTO, or how many of you will do simple HTO only?
Arvind, how long is the history? When did he have? When did he start getting severe pain?
For 1 year, he has history of medial side pain, and for last 3 months, he has significant pain, and he has visited almost 5 doctors. But when he used to walk, he has severe pain.
So, from what you're saying, the first 1 year pain that you're saying is because of medial compartment overload or arthritis. 3 months has gone worse because of the root tear. That would be logical in my opinion. So I don't know about others, but I think it's a good candidate for HTO plus minus root repair, looking at the quality of the tissue. Though nowadays most people or most surgeons are deviating away from a root repair with HTO because the latest Korean paper states that the root tends to heal even you do HTO. But if it's a good quality tissue, then why not restore the anatomy? So I would do an arthroscopy, see the knee. If it's repairable, I'll repair the root along with HTO. I don't know if anyone else wants to say anything.
Yeah, that's perfect, sir. My thought matches with you also. So next slide, please.
Dr. Rajeev Ranjan is saying something.
Yeah, Rajeev boss.
So whenever you are planning for HTO, how often do you do for routine and diagnostic arthroscopy?
For me, almost each and every cases, but with sir, almost in 30% of the cases, we do arthroscopy.
I think that is the advantage of, So whenever I think we are planning for osteotomy, I think after routine arthroscopy, it's not only root tear, sometimes you have degenerative meniscus tear also. You can just debride that. And if you have a root avulsion, I think not repairing and coming out would not be a good option. So it's better to repair the root. And now we have good plates also where you can tie the knots with the you can repair the root and go for HTO also.
Yeah. Thank you. Next slide, please.
Arvind, just one more thing, Bhushan here. Unfortunately, I've been sued a couple of times in life. And one of the patients who sued me was a HTO patient where I did not do an arthroscopy. And she sued me saying her pain was not because of arthritis. It was coming from a meniscal tear as was told to her by a surgeon, a friend of mine, unfortunately. So post HTO, she still had some pain, which miraculously recovered after arthroscopy and meniscectomy in 6 months' time. So no. So since then, I've started scoping every HTO.
Next slide, please. Next slide. So this was the osteometer. Next slide. And you can check how much correction and after correction how it looks. The planning. Pre-op. Next, please. And this was the intro. Picture. So you can see the cartilage and on the femoral side. Somebody run the video, please.
So Arvind, this is very good. You have documentation also to what is the condition of cartilage.
Yes,
I think this is very important. So once you put arthroscopy, you can document it.
Yeah, you can see the root. Here. Continue with the video, please. You can see the medial meniscus root is completely separated. Tissue looks good. There is not much problem with the tissue. Only problem with the cartilage on the femur side. This is after the pie crusting. You can see how this get opened.
So normally what happens is you get
of the MCL.
Yeah, Arvind, you get two type of tear. Sometimes there is a fibrosis between the root and your capsular tissue. Those tears with degenerative, sometimes you can leave like that. It's like here it's a floating root. So I think you should repair it.
You can see the root
is floating root. You should repair it.
Yeah, it's root coming in front of you. There. So this is floating root. So
this
next slide, please.
Might have been giving locking sensation sometimes also.
It's like meniscectomy, huh? Yes. Not more of a locking pain will be there,
next slide,
severe degeneration of the knee joint. It's like there is no meniscus because with every stress, flexion.
Please run the video. This is after repair of the root. You can see the quality of tissue of the meniscus is good. There is no problem with that. And root has seated very accurately. Two fiber tape there. Yeah, this looks perfect. This is the compartment medial femoral condyle. ACL looks fine. Lateral compartment looks fine. There is no problem. Next slide, please. Next slide. And this was the HTO done. So you can see I have placed the 4 mm reamer in while doing HTO. So that my screw should not collide with the tunnel. That was made for the medial meniscus root repair. Next slide, please. Next slide, please. This is the check X-ray. This is after maybe after 2-3 months. Next slide, please. Yeah, this is after 5 months of this. Now patient have relief of pain, but still she has little bit of the varus thrust. Next slide. Yes, done. Thank you. Any question, please?
It was nice presentation, Dr. Arvind. Even from PARAS OT, you could do it. Thank you.
No, we can move to the live surgery.
No, Dr. Arvind, there is a lecture which is remaining from Dr. Rajkumar. So
you will finish it in 5 to 10 minutes.
Surgery is going on. So we can have that lecture after this live surgery. That is the STO by John sir. Okay. You can see on the screen.
Okay.
Sure.
Please continue with live surgery.
Yeah. वहाँ खोलो निकल
Okay, can you hear me? Hello? Anyone there? नहीं तब तक
Hello.
Okay, can you hear me now? Hello. Am I audible?
Dr. Arvind?
Yeah, can you guys hear me?
Are you there with us? John sir?
Yeah, I'm here, but I don't know if you can hear me. Hello. Can you see me?
Hello. John sir?
Yeah. Can you hear me? आवाज नहीं आ रहा है.
हेलो.
इधर मत रहो ना, उधर से कैसे आएगा? तुमको इधर रहना है ना.
हेलो.
Okay, can you hear me now? Hello. चेंज कर दो ना.
हेलो.
क्या हुआ? हड़बड़ाओ मत.
नहीं जा रहा लगता.
हेलो. Hear me? Yeah.
Hello.
Yes. Can you hear me?
Yeah, John sir. Rajeev.
Can you hear me now? Can you hear me now?
Yes, sir. We can hear you.
Okay, fine. And you can see. Can you see what's happening here, Toki?
Yes, sir. We can see the Siam images right now.
Okay. Siam दिख रहा है. इधर में करो. Okay.
I think we can have two views, sir. One camera on the Siam and one outside picture.
दिखाना कितना बार बोल रहा है तुमको. उधर से तुमको कुछ ऐसे आ जाओ इधर. बस थोड़ा दूर में रहो. Okay, so basically what's happened? This patient has a 6-month-old injury.
Sir, can you show the pre-op X-ray?
The mild PARAS. Yeah, we'll just show you the X-rays. Okay, it's got a mild PARAS. Hello,
sir. Yes, you are audible.
Okay, so he's going to have an suction. Arvind started the tunnel, but he hasn't put in the graft yet. Okay. And so actually made a oblique incision. So we've extended the incision proximally and distally. Okay. So X-rays दिखा देना मेरा.
Sir, we need to see
the pre-op X-ray, sir. Can we see the pre-op X-ray?
We are still seeing only the Siam picture is seen here, sir, not the other view.
ये वाला Siam का दिखाओ यार.
The surgical picture is not seen yet.
Okay, we'll get it just in a minute. Focusing on the X-ray. Okay. The MRI shows changes on the median, the lateral compartment is okay, and an ACL injury. Okay, so there's a very mild virus. Actually, it's I don't think we've operated. That is so strange. We're going to do it today. I'll just go through the steps. Can we come to the operative site now? यहाँ पे ठीक से. Can you see the image? हटाओ ना यहाँ से. Okay, so this was the original ACL incision. We've kind of extended it proximally and distally. Okay.
Hello.
Yeah, can you see the operative site? Hello. Have you lost us?
Hello.
Yes, I can hear you.
Yes, sir. We can hear you, sir.
Can you see the site?
Sir, we can see the operating site. If you can say a brief history, sir, about the X-ray, because earlier it was not audible.
Pardon?
Brief history of the patient and the X-ray, pre-op X-ray.
Didn't he show you the X-ray just now?
No, sir. He is showing the
X-ray दिखाने बोला नहीं देखे वो लोग. क्या कर रहे हो?
Just focus on X-ray, then sir will speak on that. Yes, sir. It's an MRI. Right, sir.
Okay.
X-ray उसको zoom कर दो कैमरा में, just zoom it. Yes, sir. MRI. Yes, yeah, please sir. Yes, sir, now we can see the X-ray, please, sir.
Okay. Is that okay?
How much was the MPTA, sir? Sir, there is a question, what is the MPTA? We have a orthoscanogram and we have measured the angle also.
I can't hear you, Rajeev.
Sir, what is the MPTA?
लंबा वाला.
Yes, sir. We can see the X-ray now.
Okay. So Arvind को जा बुलाना. Okay, so now since so basically one of the tendinosis has been taken. The gracilis is here. That's the ACL tunnel. Okay. So we'll just put something there. Reamer there. उसका MPT and other angles उसमें डाल दिया. Can't see that actually. So just tell them what's the MPT. Check करना. Okay. So now the osteotomy basically is above the pes. Okay. And it's an income osteotomy. Okay. So I'm just going to mark osteotomy. It's going to be this is the tibial tuberosity. So it's going to be oblique down here, and then transverse. I'll just show you what we did. And I'm going to take this off for the moment so that and we are going to transfer. There, okay. So the MCL has been released and to the back of the knee so that we can get our hormones down there. Okay. This is important because cutting the posterior cortex is important. Okay, so you get your hormones down here. Okay. One second. Just to retract.
So you are planning for a biplanar osteotomy, sir?
Yeah. So the HTO, open wedge osteotomy, the way we do it today is always biplanar. Okay, so I'm going to put one wire just a hole that Arvind has made. This is aimed at the top of the fibula, about a centimeter and a bit below the knee joint. Okay, image please. Image please. So that's going too far up. So the curve. Okay, that's where we want to be.
Can you show the CM image? I think you can show picture in picture. One CM image and one for uploading. Cameraman, show picture in picture. Oh, there is only one camera?
Yeah, but no, there are two. There's one guy had gone for a walk.
Oh, all right. So yes, sir, we can see it. Yeah. So okay, you are heading, you are aiming towards the fibula head. All right. Okay, yes, so sir. Now we can see. Yes, now it's good, sir. Okay, yes, sir. Now we can see picture in picture. Yes, sir.
Okay. इसको काटने के लिए. The second one I'm going to put more posteriorly. Show me that point. Okay. Again, parallel. Let's. You have to get out of my way. No, that's not. ये दिखाना मेरे को. Bob here. Listen. Come here and help with the case instead of dreaming. Okay. So this has to be parallel to the other wire. Okay. Look out. Okay. So that's your two wires. Can we cut the wire? So we'll cut the wire short because otherwise they get in your way. One person holds the. Okay. So now we've got here. So the osteotomy is distal to the wires, but proximal to the pes. Okay. Beaver, please for the back. So the MCL is out of our way. MCL is out of our way here. One sec, just wait. Just wait. Okay, so you have to make this. Okay, so you have to make this space tight and in patients. Okay, Okay. So we use a small. Saw blade for the part of the osteotomy. अच्छा ये दे दो पहले.
Medial cortex.
One, so I'll do the back first. 180 degrees. Yeah. Okay, so bend the knee a bit. Keep the knee a bit flexed. When you're cutting the back. This has to be distal to the wires. Okay. So always you have to remember that the wires are protecting you. The soft bone above.
And knee is in 20-30 degree of flexion, sir. You have to bolster also. Yeah.
There's a bolster here. Plus
Yes, sir.
Okay, so you see the back.
Yes.
And you have to make sure that the posterior is okay. Image, just check it. Okay, so that direction is okay. Tablet. So, and the anterior part of the osteotomy is a complete osteotomy. Okay, so just
So do you put any Homan just underneath the patellar tendon? No.
It's dissected out quite well, so I don't need to.
All right.
You can see that there. So I can actually visualize it. So I have to start the cut perpendicular. Otherwise your saw tends to skive off. Then go horizontal. Okay, so you cut across. So you go right across. Complete osteotomy. Okay.
Yes, the oblique osteotomy is the complete one. Yes.
Yeah. So you're going right across there. You make sure your two are touching. Okay, so now once you've done that initial part, then you start with your osteotomes. Okay, start with a broad osteotome. So again, you have to make sure that your posterior cortex is being cut. दिखाओ. Okay.
All right, sir.
दिखाओ. Someone look at the markings here. How much have we gone? 30. Okay, so 30. Okay, so let's go at least 40. दिखाओ. Okay. What's it that? दिखाओ. So little more and we are done. Okay, दिखाओ.
Up to 75 to 80%.
Okay, so that's about as far as we go. Okay.
Yes.
As far as we go. Okay. Next. Use the next.
So still your posterior cortex is intact, sir. You are anterior to the.
You see that here? It's cut here.
All right.
Hang on. I'll show it to you. So that's our posterior cortex. Can you see that?
Yes.
So I think it's as cut. As it can be. Okay. You happy with that?
Yes, sir. So
okay. So that's the first part. The first part you cut. Okay. And that's important. That's important because the flow will go haywire. Okay, so then next one is just parallel and ये दो बार आवाज क्यों आती है? I keep hearing myself. Disconcerted.
There is echo, I think, inside.
Yeah. Okay. Can you see that?
Yes. So you have put in the broader one first, and gradually you are just widening the osteotomy.
Don't stress the knee. Okay. Can I see the image, please?
Hello.
Okay. Good.
Okay. Hello.
Okay. Next. So you have to be careful. You go slowly. The main idea is that you try to keep the lateral cortex intact. Okay. So this one, and the chisels are designed such that when you're up to here, it will be the same length as the earlier cut. Pardon? Sorry, can you hear me?
Hello.
Yeah, can you hear me? Sound is gone again. Okay.
Hello.
Hello, can you hear me?
Yeah, now we can hear you.
Okay. I think it looks like sound is the one that we use. If I can't hear, you guys can't hear it. Okay, so see what I'm doing.
Yes.
So this is the fourth one. Okay, let's see that. So I think with 1 minute, okay. So they all come out. Okay. Now you put in. So this device is
spread.
Important thing. Okay. So we want to do a Bowie check now. We'll do a Bowie check. So you guys this. Center of hip, please.
You are using diathermy cord. Yes.
Yeah. It's not the best, but
yes.
Ucha kar.
And the assistant should lift the leg, I think. Yes. So it should not be in flexion.
Yeah. We'll do that.
You lift the leg. Then yes.
Keep it internally. I mean. Joint दिखाओ. थोड़ा नीचे होगा. हाँ बस हो गया थोड़ा ही सर. What shadow are these things there? Okay, I think that's about right. Come to the bottom. What's your thumb here? Listen, keep the correct rotation. Okay, so we've got that. थोड़ा सा lateral जाओ. यार एक हाथ से इसको दूसरे हाथ से वो करो.
So knee in extension and patella should face towards the ceiling. Yes.
Yeah.
Yes.
I'm trying to get that to happen.
Yes.
Go more lateral. Not that much time. Come back. Lift back. Little bit at a time now. दिखाओ. Yeah, that's about right. So now come to the knee के पास. So keep it medially. Let's see that. Okay, so it's just.
So what is your ideal point, sir? Lateral to the tibial spine, over the lateral spine.
Okay, so we are aiming for lateral to the medial spine. So we'll be aiming for it to come growth. दिखाओ. About there. Okay.
All right.
Okay, chalo. So I think different sort of Yes, definitely. You can't just have you assisted him? Oh. No. Mop. To cut these. Just cut the wire because it's getting in the way of the. Okay, so this instrument is 0 degrees in when it's closed, and as you turn it open, as you can see there. Okay, and that gives you the angle of correction. Okay. So you put
Cameraman,
this in,
if you can zoom in, so sir can show where to put this spreader. What is the ideal?
This should be the cortex. Okay.
Yeah.
So you have to make sure that dikhaw. So you want to go all the way to your cuts. Just dikhaw. A little bit more. Dikhaw. Just a little bit more. We have to be very careful through these steps. Almost always when it goes wrong, it's because you lost your concentration sometime. Dikhaw. Bit more. Ab dikhaw.
John sir, do you prefer putting a prophylactic hinge wire on the lateral cortex?
I haven't done it yet.
Oh.
But if you want me to, I will. Okay. So who's going to do the correction? Okay. So just ये वाला देख लेंगे. Okay. So in here probably looking 7 or 8 degrees, but we'll check it. इसमें सीधा. And when you're doing the correction, keep the rate because you don't want to correction it too much. नीचे. Okay, चलो. How much is that? No. Relax. How much is that? 10. वापस जाओ. That's okay. Let's see the. So at this time we check the axis again. So again, just osteotomy front of the osteotomy at all. Okay. Arthroscopic. So you see this. The oblique part of the osteotomy. It's still in contact part of the bone. Okay.
Mm-hmm.
Can you watch that?
Actually, it's glistening over that area. Yeah, now we can see that part.
Come karo.
Yeah, now the contrast is good. Yes.
Just to show. Of course. Check.
So for the benefit of audience, where do you want to put this laminar spreader, osteotomy spreader?
So this, like I said, I want more posterior.
More posterior.
So that the posterior cortex is definitely opened. Yeah. Okay. So that's about it.
And sir, what are the tips to maintain the neutral slope? If you don't want to change the slope, what are the tips?
So if you don't want to change the slope, correct it. You're not correcting front or back. Okay. आगे चलो. So in this case, we are not trying to slope. Yeah. Okay. So they have not looked at it before. So,
I think the bars are coming in. Yes, sir.
Yeah. Okay, that looks okay.
Yes, sir. We can see it. Yes,
now come to the
knee joint.
Okay, so that's
yes, sir. Yes.
Okay,
Lateral.
Okay, as much as we want. I'm going to now once you've done that, you put in here. Okay.
Yes.
Hammer. So this is a way your position when you remove निकालने के लिए अब वापस करो. So now you take that off. Laminar spreader then. So the laminar spreader, you go right at the back. Then click. Okay. So just when hyperextender. Okay. Speak now. You should actually check your correction at. एक बार फिर दिखा दो. ये वायर निकालने के लिए. So now you have to take out anterior wire because that will get in the way. Tomofix दे दो. So I'm going to fix if the tunnel will go for the polyaxial plate. दिखाओ. So that's pretty good. So we can avoid the tunnel. Okay.
All right.
Okay, just check the alignment again. Front. You need to go. ऊपर क्या जा रहे हो? Go lateral. थोड़ा lateral जाओ. Little more. Push a little more. थोड़ा सा. Okay, fine. Ankle. Location. कितना बार बोलेगा? थोड़ा सा lateral. Bit more. Okay, good. अब इधर देखो. Okay, so that's about what I wanted.
Yeah.
Okay. Okay, so now the plate ये वाला देना वो
होल में
डाल के लिए
3 month. So you are using sir Tomofix, I think.
Yeah, I'm going to use it because that's the one I like. What I'm used to it. Okay, so little bit lower. Okay. Now I put one of the tops. Okay. That इसको plate को रखो. ऊपर दिखाओ. Because you want to make sure angle is correct, huh?
So do you prefer to put plate over the face or under the face, sir?
So it's over the face using a spacer, yeah.
All right.
So you're not compressing. Little higher. ऊपर. Just hold it there. दिखाओ. Now that looks good.
Yes.
दिखाओ. अब दिखाओ. कितना है? 70 हो गया. 70 देना. Hold everything and so the anti hole very often will hit the okay. We have to be careful of that one. Good. दिखा दो हाथ हटा लो okay, looks good. Talk limiting. So I'm going to leave the anterior one for the end. We put the other. Before you put your second situ, you need to make sure your plate is in the right position.
Yes.
It is concerned, okay? Because you change it while you've got one, not after you got the second.
Is the plate a bit higher, or it is a view?
What it was? True level. एक बार दिखाओ तो सर.
Yes.
Actually, earlier the screw was coming down, so it is up a bit. एक बार दिखाओ फिर. That looks okay. It's maybe just a margin. knee को bend करो तो. sit करो. सीधा करो. हाँ ठीक है. You have to be careful. Your screw doesn't go out of the back.
Yes.
It's always better to check that. 60.
Yes.
The posterior one very often goes back because of the conduct. दिखाओ. ठीक. Okay. So the next screw we put in is the dimensional screw. Here, okay. So let's go follow. If you look at the pest, it's a long way. Drill. Ordinary drill. So we have a spacer at the bottom and a spacer here. So this by chance you got it. This screw become because it tensions the lateral side. Eh? Measure. Now it's important not to put this thick because it will close the gap a bit. 44. 44.
Pace, but with a spacer.
Yeah, and over the pace. So once you're passing it over the pace, so when you want to harvest the graft in next time, that's the problem.
He's already harvested.
Already the graft had been harvested.
Suppose it doesn't need ACL reconstruction.
Okay.
Later on, if
he's already measured that.
Yeah.
Drill. Good. Measure.
Because I have a habit of putting it under the pace.
As long as you got a spacer.
32. So once you put that, you get all the other things and check. Put all the. क्या हो गया? Huh?
1 hour.
Okay, so now you take out everything. Okay, ऐसे दिखाओ. Okay. lateral दिखाओ
Yeah, but you already दिखाओ सामने से हटो ना तो यार
Yes, all these screws are, yes.
Okay, and the slope
Yeah,
is
yes.
okay.
Slope is
Want
okay.
to make it
And there is no intra-articular penetration. Yes, sir, perfect.
It looks okay. Yeah. चलो हट जाओ अब हो गया ना So now we the screws Fraser निकाल and your ACL का okay last में ये जाएगा कि नहीं छोटा screw डाल दें drill चलो measure so that's what top limiting
Sir, AO came with the principles of golden screw. So for benefit of audience, what is this golden screw?
golden screw is first conventional to put in because that's golden in color. So what it does keep it So two things it does. One is it tensions the plate. Okay, so if you see the shape of the plate, it hinges, and the lateral cortex gets compressed in a way. So if by chance you crack it, so you see this impact MPL because it shows
Yes.
No, but it shows that अभी दिखा देगा ना एक बार अभी दिखाओ ना So now you see that, yeah?
Yes.
Okay, so that little opening there is compressed, yeah? Okay, so then you don't need to worry about that. You just mobilize the वो लगा दो तो leave इसका drill और sleeve doesn't either which is sleeve shouldn't it go down so it's not hitting that
Yes.
and this goes important because oblique
It's almost oblique and parallel to osteotomy also.
measure दिखा दो See. Again, just check that you're not going out there. 65. Okay. And always check the direction because sometimes
It goes into
because if it's soft bone, it can change tracks without you realizing it. Yeah. Okay.
Yes.
So now there's one thing. If that's hitting that, you put a small screw, not hitting it all the way, locking here and we are done. Okay. So I'll leave it to Arvind to finish off the rest. Thank you very much.
So what is your weight bearing protocol after osteotomy?
That's a good. So we actually mobilize them. I mean that's to the second day. We get them up on sort of a partial weight bearing. Okay, and then a lot of them are full weight bearing by 3 to 4 weeks. By 6 weeks, when they come for the follow-up, they are allowed full weight bearing.
All right.
Okay.
So full weight bearing after 6 weeks.
Yeah, but a lot of them are full weight bearing at 3 weeks.
Mm-hmm.
Patients who feel comfortable start doing themselves. Because we don't constantly tell them to do full weight bearing for 6 weeks. With their local patients, see them at 3 weeks, allow them full weight bearing. In their asymptomatic problems. Okay.
All right, sir. Just for the benefit of our audience, when do you want to correct the slope? How do you manage the wedge? If you want to correct the slope,
because of your system, you can actually change where you correction. Okay. So if you want to correct the anterior part, then you put anteriorly. Okay.
Yes.
Okay. And correct it more anteriorly. Similarly, if you want to correct posteriorly, you will put it posterior. Normally you put it because posterior part is more to correction.
Mm-hmm.
Okay, because there often doesn't get cut properly, and it tends to open out posteriorly. So you have to be sure you cut the posterior cortex, and then you can use correct anterior or more posterior. Or you can use your lamina anterior or more posterior. Okay. So as you are doing that, you can slope on the lateral. If you want to change this. Okay.
And sir,
don't rely on the severe instability. Okay. It will help you with instabilities. To try to do it for a grossly unstable knee, it's not going to work. Okay.
Yeah. And sir, how often do you recommend to have a lateral view while you are cutting the posterior cortex?
Never.
All right.
At least. So because when you're visualizing it, why do you need a image to look at it? Okay, so you want to see if it's cut or not. Your direction you're seeing on the C-arm now. So if you release the medial collateral ligament enough and take it off the bone, then you can actually see that you have cut the posterior cord. Okay.
All right, sir. Thank you, sir, for wonderful demonstration. Thank you so much. Thank you, sir.
Okay. Bye.
Arvind, should we continue?
Yeah.
Just have to take the
Next session.
राजकुमार सर बोले कि कर लेते हैं
चलो हटाओ राजकुमार सर का वो है हटा दो चलो ये पकड़ो ग्राफ दे दो बेटा
So Rajiv, you can get on with the lectures of Dr. Rajkumar.
There is one more talk left that Rajkumar sir, we have planned sir's talk for tomorrow as I told.
Okay. So
And before closing this session, may I request Rajeev Ranjan sir to please felicitate. NK Singh sir is here or is not there? NK Singh sir is not there. Okay. Then Pawan sir.
जानकी को सर फोन कर दीजिए ना
So may I request
कंटिन्यू कर ही देगा
Rajeev sir.
रुक जा ध्यान नहीं है बेटा रुक जाओ पीछे चलो
कुछ को कर दीजिए. May I request Rajeev sir to please felicitate our respected Dr. Pawan Kumar
सतीश
sir.
को मालूम होगा सर चलो कंटिन्यू ठीक है बस हो गया बेटा हो गया छोड़ दे चलो हो गया व्हाइट वाला अलग कर ले तो ले लीजिए
Dr. Anil Ram sir is here. Is not here. Okay, sir. So, may I request Dr. Bhushan sir to please felicitate Dr. Vidya Sagar. Now Anup Kumar sir is not here. Okay. Dr. Avinash Kumar sir. Yes sir. May I request Ratnesh sir to please felicitate Dr. Avinash sir.
just 1-2 मिलीमीटर पिछले बस पिक्चर
उनको दूसरे दे देंगे.
कितना बज रहा है 7:45 बज गया
Then Rajiv Anand sir is not. And Dr. Ramakant sir is not here. Okay. Dr. Abhishek Das sir. Yeah. Please may I request Pawan sir to please felicitate Dr. Abhishek Das sir.
ये टैक्स लगा ले बेटा इसको पकड़ ले बेटा उधर या ये पकड़ो इसको पकड़ो
Dr. Soumyadeep Datta sir, may I request Manish sir to please felicitate Dr. Soumyadeep Datta sir.
खींच के रखो बेटा इसके डायरेक्शन में खींच दो तो कट जाओ वेन को इंजेक्ट कर देना वेरी इंपॉर्टेंट एक्सरसाइज में
Sir,
और वेन को का पाउडर डाल देना उनको
Sinha sir is not here. And Praveen Sahu sir is here. He is also not. Left. Okay.
डबल लॉक दे दो
John sir is not here.
भी दे दो
किनको बोले? May I request Rajeev Ranjan sir to please felicitate Dr. Bhushan sir. Oh, sir is here only or? Okay. Then, okay sir.
हैमर दे दो
Sir,
धागा पास करो ना
please for Dr. Rajkumar sir, please. Yeah. May I request Rajeev sir? Yeah. To please felicitate Dr. Yeah. Yes. Sir. Yeah, please sir. Then,
दो ही जाएगा बेटा एक बार में पंगे मत ले लो इतनी ज्यादा
yeah. May I request Dr. Jivendu Bhushan sir to please felicitate Dr. Bhushan sir. Bhushan sir, please. अब है सर आपका उधार
इससे क्या रहा है क्या?
सबसे ज्यादा
May I request everyone to please join us for snacks followed by the dinner. So, yes sir. सर 7 बजे तो लिखा हुआ है टाइमिंग, तो स्नैक्स के बाद फिर जैसा हाँ ग्रुप फोटो सर लोग भी आ ही रहे होंगे मेरे ख्याल से। प्लीज सर, प्लीज कम ऑन द डाइस फॉर अ ग्रुप फोटो।
चलो हट जाओ तो जरा, चलो निकाल दो ये।
प्लीज सर, may I request everyone to please सर वहाँ चले हैं
सर बोले ना डिनर
चल एक मेमोरी के लिए आप सीएम को बुला रहे हैं ना, अल्लाह को।
हेलो हेलो बोलिए हेलो
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 हेलो चल
नहीं नहीं ठीक है आप मत बोल
चेक
हम चेक कर रहे हैं ये वाला सब में वही दिक्कत है हेलो
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 आया आया
Check, check. Hello. अब ये बंद किया ना नहीं जाना
हेलो चेक हेलो 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 चेक हेलो 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 चेक हेलो 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 चेक चेक हेलो हेलो चेक
Hello.
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 Hello. Check. Hello. 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 Check. Check. Hello. Check. Hello. Hello. Check.
Hello. Check. Check. Hello. Hello. Satish.
लपेट के सब उस पर रखो ना। हाँ, मेरा साउंड जा रहा है ना? ठीक है, आप बोलिए तो उधर से कुछ।
चेक चेक। हेलो।
नहीं आ रहा है।
हाँ?
नहीं आ रहा है।
क्या नहीं आ रहा? साउंड नहीं आ रहा है?
नहीं नहीं। हाँ, निकलिए ना, ऐसे हम भी चल।
चेक
हाँ।
चेक 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 चेक। कहाँ? चेक चेक। हेलो।
हेलो।
हाँ।
रुक जाइए, उधर से बोल रहा है ना माइक में, जैसे
चेक
चेक
चेक।
है ना।
हाँ हाँ,
रुक
तुम अपना
जाइए।
ऑन करो।
नहीं रहेगा ऑन है भाई, रुकिए ना
अभी।
क्या है ऑन पे? हेलो। हाँ बोलिए ना।
हेलो। चेक
नहीं,
चेक
blink बोलिए तो।
चेक चेक।
नहीं आ रहा है, रुकिए रुकिए।
तुम्हारा तरफ से? हाँ,
मेरी तरफ से नहीं है, हम ये चेक कर रहे हैं।
हेलो।
लग रहा है कि ये खराब हो गया।
चेक चेक। हेलो।
लेकिन आ रहा है, ठीक साउंड आ रहा है।
हेलो। हेलो। चेक।
रुकिए रुकिए।
हेलो। चेक चेक। हेलो। हेलो। चेक।
हेलो।
हाँ।
नहीं आ रहा, आपका साउंड का ही नहीं आ रहा। हेलो। मेरा जा रहा है तो ये हमको लग रहा है उधर वाला ये खराब हो गया है, जो इधर से माइक में जा रहा है ना, वो एक एक ही पर वो काम कर रहा था यूएसबी वाला, तो सुबह से लगल है वो खराब हो गया है लगता है। ये और हम वो वाला था वो खराब के है, ये भी इसमें भी लग। अरे यूएसबी नहीं लगाएंगे, माइक का कैसे देंगे साउंड? माइक का साउंड कैसे जाएगा, और फिर उधर से आएगा भी कैसे? हेलो। मोबाइल से बात।
बोल रहा हूँ माइक खोल रहा हेलो हेलो मेरा तो चाह रहा आप
चेक चेक आया
हेलो
आया
आपका भी तो साउंड नहीं आ इको कर रहा है
अब इको नहीं ना कर रहा है
कर रहा है मैं आपका थोड़े कर रहा है मेरा कर रहा है हाँ सुबह से नहीं कर रहा था जब अरविंद सर जब जो बोलने लगे ना प्रेजेंटेशन दोबारा जो प्रेजेंटेशन दिए थे उस समय से करने लगे और वो लग रहे तो जॉन सर भी यहीं गए तो उन्हीं वाला माइक उनको दे दिए तो सारा माइक चेंज कर दिया इसीलिए हो रहा है माइक चेंज कर दिया अब फिर हाँ और फिर उनको से निकाल जैसे ही उनका जो थैंक यू बोले उसके बाद निकाल के फिर अरविंद सर को दिया था ठीक हो गया आप बोले कि ये उधर से बंद किए हुए हैं इसीलिए हो हम रीस्टार्ट करते हैं कंप्यूटर ठीक है हाँ लागू कुछ सेटिंग कैमरा पैक करो इसी पर चल रहा है उसका रोक लो तो बोले नहीं जैसे मन हुआ इनको आ रही है हम उसको बोल देते हैं यार तो पड़ जाएगा तो तो जब पे जाना है तो आप लोग छोड़िएगा